Good morning, everyone. I'm Dr. Sayeda Nisar Fatima, resident of Psychiatry, SVS Medical College. I welcome you all to the Indian Psychiatric Society Telangana State Branch 6th Annual CME program with the theme Knowledge Update to Every Partner in Mental Health Care. I would like to begin the program by the first topic of the day, Invitation to Psychiatry for Undergraduate Students. Please note that due to COVID precautions and due to COVID protocol, the undergraduate students will be attending the program online. First, I would like to invite the chairperson for the session, Dr. Gandaya sir, to the dais. He is Professor and Director, Department of Medicine, SVS Medical College, Mehboob-Nagar, and he is currently serving as Chairman of API Mehboob-Nagar Chapter, that is Association of Physicians of India, Telangana State Chapter, from 2020 till date. He has previously served as Professor and HOD of the Department of Medicine in MNR College, Sangareddy 2007 to 2008, Professor and HOD Department of Medicine, SVS Medical College, Mehboob-Nagar 2008 to 2017. And he also served as Medical Superintendent in the past, Director of Department of Medicine from 2017 till date, and he is Director for Postgraduate Education at SVS Medical College. He has conducted various regional CMEs and zonal CMEs, mega health camps, conducted World Diabetic Day and he still conducts the World Diabetic Day every year, organizing secretary in Conference for Physicians on Mind-Body Medicine, organizing secretary Combined State Conference, organizing chairman IDA State Annual Conference 2016, organizing chairman Telangana State Midterm Conference in 2018, and published 20 original research papers in national and international journals. He is the honorary founder secretary Twin Cities chapter of API from 2003 to 2006, and he served as vice chairman of API for 2 terms in combined states 2011 to 12, 2012 to 13, and also served as chairman-elect in 2018 to 19, and currently, as I have already told, he is the chairman of Association of Physicians of India, Telangana State Chapter from 2020 till date. Now I request Gandaya sir to please invite the speaker, Dr. Praveen Kumar Chintapandi sir, to the dais and give a short introduction of the speaker of the day and the topic for today. Same order, jo pehle tha na.
Good morning and welcome to all of you, those who are in the gallery and those who are participating online to this unique program, the 6th annual conference of Indian Association of Psychiatrists. Actually, I was very much interested in psychiatry. I don't know what made Dr. Ashok Reddy to call me, but basically I was interested in psychiatry. When I passed out in 1975, waiting for our posting as intern, at that time we had a college day at Osmania Medical College. It went on for a week. So as I was interested, I went to mental hospital, met Dr. Raghuram Reddy, and those days one clinical psychologist, Niranjan Reddy, was there. And there was another person who was planning to go to US, and he was there. I met them and I told them that I would like to be a volunteer to the Department of Psychiatry for whole of the college day, So that's how I was there in the psychiatry department for 1 week. But unfortunately, I could not become a psychiatrist due to the very reason that we were not having post-graduation in our state at that time. So that's fortunately or unfortunately, I was not able to do it.
He will introduce, he will call him. After that, you can
So I congratulate, and at the outset I thank the organizers and particularly Ashok Reddy Garu for giving me the opportunity to chair this session. Now I request our beloved speaker. It's my privilege and honor to welcome our renowned speaker, Dr. Praveen, He graduated from Usmania Medical College and did his DPM from NIMHANS, did his MRCP from London, and is also a consultant psychiatrist and director, Tranquil Mind, Hyderabad. He is consultant psychiatrist at Apollo Hospital, Jubilee Hills, Hyderabad. I request our beloved speaker, Dr. Praveen, to take over and give us the introduction to psychiatry. And this knowledge of psychiatry is not only important for psychiatrists, but it is very important for non-psychiatry physicians, particularly general physicians and neurologists, because as we studied, now I do not know what it is, but they used to say 90% of the psychiatry problems are dealt by non-psychiatrists and only 10% are treated by psychiatrists. So the knowledge of psychiatry is very important for non-psychiatry physicians and people of other specialties. So this is a branch, this is one of the oldest branches of medicine. To start with, in 18th century, there were only two specialties in medical field. One is medicine and the other is surgery. But in 1808, one Dr. John Christian, he was the person who brought about the specialty, and so this is the third specialty in medical field. So it's not inappropriate to call him as the father of psychiatry. Now I request Praveen to introduce the psychiatry, which is the need of the hour. And it is said that depression is going to be a major illness in the days to come. Now as it is the cardiac problems, then the malignancies, and the respiratory problems, and diabetes, etc. So this is going to be the leading cause of death and mortality and morbidity in the days to come. Thank you. Over to Dr. Praveen. Thanks.
Good morning, everybody. At the outset, I'd like to thank Professor Ashok Reddy, Organizing Chairman, and Dr. Pratik, Organizing Secretary, Chairman, sir, for the session, Professor Gandaya Garu, and my teacher, Dr. Gangadhar Garu, who's here, and my friend and senior, Dr. Kishan Garu. It's indeed a great privilege to be here and to be talking about something which is very close to my heart, and it's rather my own journey in terms of being a psychiatrist and where does it all begin for a student, a medical student. Where do the seeds get laid? Where does the injection of thought of psychiatry happen? And how do we end up being a psychiatrist? So, can we start with the first slide? Yes. The ముందు slide ఉన్నట్టుంది. Yeah. Thank you. So, in 1986, I joined medical school at Usmania, and it was like any medical school. You believe that like you're on the top of the world. And yesterday, my professor was saying, like, you are on cloud 9. Those days, when you joined Usmania, when you got into a bus from, I used to live about 5 kilometers away from it, and when you got into a bus and you had a white apron on your shoulder, people would get up and give a seat to you. And that was the romantic days when medicine, like, if you are going to be a doctor, you need not be a doctor. But if you're, a medical student, like, conductor would not ask you to come and show your bus pass even. They would just nod your head and then smile and go. And drivers used to make sure that if somebody with an apron is walking past, he'd stop the bus if you're a regular. So those were very romantic days of being a medical student. And we had this beautiful medical exhibition in Usmania called MedX. In 1987, I was doing my anatomy during my anatomy days, the first year of medicine, first 1.5 year of medicine those days. So we had a MedX, and then we said, like, all these people had influence. Dr. Niranjan Reddy, as Sir said, and Professor Raghram Reddy Garu, and we said, oh, we're going to have a psychiatry department in medical exhibition. So what would we place in psychiatry department? By then I had these thoughts like, this is something like we had surgery, we knew what it was. I mean, a surgeon could see what he was cutting and what he was going through, and a medicine man knows what tests to do and what, if somebody had, like those days it was very popular to have tuberculosis, you had a test, you had an x-ray, and you had blood tests and all that stuff, and then you had cardiac conditions and all. It was very clear, medicine was very clear, surgery was very clear. But when we wanted to have a psychiatry department in the medical exhibition, we didn't know what to do. Then I went and saw Niranjan Reddy, said, "Arey boss, konni testlu pedamu. Psychological testing untayi kada. Testlani free ga cheddam. Andarki IQ testlu cheddamu, personality testlu cheddamu, Rorschach cheddamu ani." I said, "Okay, fine." And then one of my colleagues, who is a gynecologist now, she got this great idea. We took a black, huge poster, big size poster, almost the size of this screen, and then splattered some white ink on it, white paint on it, and then left it at the department and started asking people to post their responses. What do you see? Because psychiatry was considered to be an unknown thing, and everybody had an interpretation. Everybody thought psychiatry in their own way. Psychiatry was, for some, psychiatry is something like, कोई भी PG seat नहीं मिलता, psychiatry में join हो जाओ. For some, psychiatry is very esoteric, and then there was this notion, people used to say, "Arey, psychiatry patient la sushi psychiatrist le pagal aipotar bhai." There was this notion which was happening, and then we had this interesting notion like, psychiatry is something unfathomable. There is nothing happening in psychiatry. So you don't know anything about psychiatry, you just don't know anything but continue to take care of people. And what do? Oh, you just lock them up, current shock de do, khatam. So we wanted to demystify psychiatry. 1987, that was my first year med school. So we had this huge poster. And we had very beautiful responses. We had students coming from different schools who would come visit the anatomy department. They would see cadavers being opened, abdomens being shown, kadupulo intestine itluntadi, liver itluntadi, lungs itluntayi. And they saw these dead bodies being shown to common man, and then we had physiology, hearts pumping and blood flow being shown to people. Those sort of experiments were shown. And they came to psychiatry, and this huge splatter of black poster with white color splattered. And that was my first experience to what we would call as, how do you see your mind in external space, and how do we understand? Because psychiatry, I cannot really go about like, put a stet on somebody's brain and then say, oh, okay, this guy has, delusions, hallucinations. But my patient tells me what is happening inside their mind space, and I interpret. So these responses were very interesting. Somebody said, it looks like Big Bang. A few minutes after Big Bang, the whole universe is forming, the cosmos is forming. That was beautiful. And somebody started saying, oh, this looks like my life. That was interesting. And then somebody started saying like, this is like, a disorganized mind. And another response was organization in disorganization. And somebody said, this is like a brain picture, these are all neurons. So as we got the responses, we had about 1,500 responses. We started looking at psychiatry, and then that was, for me, the injection of psychiatry into my head, wherein I started finding psychiatry to be something which is a challenge to understand. This is something which is an unknown journey, which I'm curious, I'd like to know more about, rather than trying to be, dancing around with the known things. Medicine, like, when I got into 87, I wanted to be a psychiatrist. That's first year med school. And people bolna shuru kare ki I went and spoke to my parents, like, "Are inka clinicals gaలేదు కదరా, నువ్వు hospital పోతే తెలుస్తుంది నువ్వు ఎక్కడ పోవాలి. You should go to the hospital first and then decide whether you want to be a physician, surgeon, radiologist." Pediatrics was very popular those days, and orthopedics was popular. So I said, like, ye kar lo, wo kar lo. Like, first ranker entrance seats, these were the popular things. I said, no, I want to be a psychiatrist. And my father had this weird look. Beta, inka time undi kada, alochinchuko, tondremi. And I went, I thought like, perhaps this is something I need to go and understand. And then I went to a surgeon who was very popular those days. I went and said, this was like coming to 88, like third year into medicine. So I went to this surgeon who was a mentor and a nice man. I said like, sir, psychiatry చేద్దాం అనుకుంటున్నాను ఏమంటారు. And this man, did his surgery in England those days. He was very popular, very friendly and nice guy. He said, Praveen, you should become a surgeon. You see, you have the charisma of being a surgeon. You are very popular with people. You can just help people directly. This is the, why did you get into medicine? And, all right, that was a big question. Like, why did I get into medicine? I said, like, sir, I wanted to help people. And, sir, I want to have a decent life, earn a decent living. And, sir, I want to be a good person. What else? I said, you see, Praveen, these things are not just important. You need to be popular. You should make money. And those days he had a Maruti car. Maruti was very popular those days. Having a Maruti 800 was luxury. So we had a Maruti car. He took me in this Maruti and then said, like, Praveen, ऐसा वैसा नहीं चलता, पैसे कमाना है, बहुत अच्छा बनना है. This is, psychiatry में क्या पढ़ा हुआ है? I said, oh, all right. So I should buy a Maruti, nice car going at 50 kilometers an hour. That was fantastic. So I said, like, oh, probably surgery is an option. Then it started tickling into my head. Probably there is world other than psychiatry. As we got into clinical medicine, and when we had our postings, by then PG seats were there available in IMH. So when we had our clinical posting, every time we went into the mainstream medicine teaching was very simple. Like, you go in Hutchison's manual, you study medicine, you'd say like, you do what is called a history taking, and then you do an examination, then you order investigations, you get a diagnosis or a working diagnosis or a differential diagnosis, and then go into management. Standard procedure, history taking, theek hai. Examination, theek hai. Investigations, theek hai. So this, and then you come with the diagnosis, and you go into psychiatry posting, and then those days psychiatry places were more of people with psychotic illnesses who were admitted to major mental hospitals with very little, other conditions, what we call as depression today, or what we call as anxiety today, or obsessive compulsive disorders. This was a very tricky proposition. And we could go and see, like, people being medicated, yes, people receiving ECTs, people confined to hospitals, and people doing, being very unwell even, like, aggressive and all those sort of things. And then there was this fear in the mind, कि लोग बोलना शुरू करें कि don't turn your back to patients कुछ कर देंगे, they'll beat you up or something like that. This was the myth, common myth. I mean, this is what we've been told. So people said, like, can we get to the next slide? It's not progressing on this. So people always said, like, God, this is like, a dangerous profession. It's scary. And, people like this surgeon had a Maruti car, and the superintendent of the hospital used to come in a car, a government car, an ambassador, and the rest of the faculty were coming on their scooters. Arey, isme to paisa bhi nahi hai. And like, by then I was sitting in the Maruti, koi charming nahi hai, and whichever hospital you went with this, by then the corporate setup was starting in Hyderabad, so you go into the then corporate hospital called CDR and NIMS. They were all very posh. They had people in uniform mopping the floors, which was like, wow. Usmania mein gaye to kahin bhi jao, gandagi, whatever was the issue then, hospital, I know it was smelly and all, but these private spaces were beautiful. IMH, it was difficult. Psychiatric hospital, we had a locked ward. That idea didn't sink in very well. And then there were hundreds of patients. You were taking care of things. Then I thought, I mean, probably surgery mein paisa hai, radiology mein paisa hai, pediatrics mein paisa hai. You don't have to really worry about somebody beating you from behind. This was a bizarre misconception which was thrown in when you are in your medical school in your final year. And then you start saying, like, Monday, Tuesday, nenosta, Thursday, Wednesday, nuvura, so that professor doesn't notice that students are missing. So we start skipping classes. And this drama goes on, and then when you're intern, you get some hands-on on psychiatry. You start realizing, oh, this is the fellow who was brought in by 10 people beating, he was kicking them around and all those things. And today he's wearing a nice, shirt and coming to the OP. Oh, this is the same fellow. Oh, Rajshekhar gada, aa roju vachindu, kodutundu andarni. Are ivala gentleman laga vachindu. How is it possible? Then there is this beautiful element of transformation which happens wherein you know that psychiatry, ladies and gentlemen, and young friends, medical students who are watching and being here, psychiatry is one specialty which has the best outcomes in any field of medicine. People always think psychiatry, people pagal hai, dawai dete, zindagi bhar. This notion medicine is given for lifetime, medicine is given, people, psychiatrists, what do? They give injections, they give tablets, which they'll have to take lifetime. They just, they make them sleep and go on forever. This is a major myth. I'll come to that in a few minutes. But the most important thing is that psychiatry has the best outcomes in any department of medicine. Of course, pathologists have better outcomes because they'll never see the patient. So, radiologists will just see, probably they'll never see a patient. But psychiatry, in the clinical branches of medicine, I cannot think of a single specialty which has as good outcomes as psychiatry in anything. So that went back to the previous question. Why am I doing medicine? I wanted to help people. I wanted to help as many people as possible. And I wanted to live a decent life. I want to earn a living which is respectful, and I want to earn a living which is respected in the society, and I want to live a decent life. I don't want to be really having a miserable, economically bad life. And I want to be, in a place where I continuously help even without a retirement age. That's one of the things which people, drives people into medicine as a life choice. So, this journey, I'll pause for a few minutes. I'll start, if you can look at the slide, some of you might recognize him. It's Vincent van Gogh. He's an extraordinary painter, and this painting was done while he was in Paris. So, Van Gogh, you wouldn't see that there is something wrong with this person. He's like any other painter who probably drinks and, or does whatever. He was into absinthe. That's one of the alcoholic preparations made from a plant. So he wouldn't be any different. He's like, if you take Raphael or Michelangelo, he's no different. But Van Gogh had a condition. People said it's bipolar, some said it's schizophrenia. He died very young. And one of the interesting things while I was looking at his works was that during the end of his career, he cut off his ear and gave it as a gift to one of his friends, lovers, whoever it could be. And why did he do that? People say that the story goes, it's not exactly true, but the story which I was told when I was a student is that he cut off because she said, can you just give me a ear to what I'm saying? Can you hear me? That's what she meant. And she said, can you give me an ear? And then he gives the ear concretely. He cuts his ear and gives the ear. And that didn't, a pagalpanti hai. That was the word which was used. How can somebody cut off a ear and give it? This is absolutely madness. As I started my journey into final medicine and then neurology posting, we had this interesting thing. This neurologist, Dr. Dhairyawan was, he was an assistant then. He was teaching neurology. He said, the frontal lobe has these functions called abstraction and concreteness. I said, what is concreteness? When you tell people things like, Sametal Japtam Gada, when we tell proverbs, they cannot interpret. Sir, does this mean, if somebody says, give me an ear, does that mean that, if somebody cuts their ear, what does that mean? Oh, this is lacking abstraction, and it is concreteness. That's what he said. I said, oh, there is something about psychiatry which is, connecting brain as well as the thought. Why did Van Gogh cut his ear? This was because he was thinking concretely. He was missing on this abstraction, the softness or the nuance of the conversation. And ladies and gentlemen, 1 in 100 people. So 1 in 100 is a huge number. You don't have any other illness. If you look at, like, cancers, you look at strokes, you look at MI even, it will not be that high a number. 1 in 100 people will end up having schizophrenia in their lifetime. That is a lifetime risk of general population. So if I know we have 150 students per undergraduate batch for SVS Medical College, so take 5 batches being there in the college, that's 750 students, leave a bit of referred students, add another 50 to 100 of referred students coming in, 800. So the likelihood of people having schizophrenia on the campus at any given time is 8 to 10 people. And schizophrenia is a treatable condition, and we tend to ignore it. So that is only one condition, a major illness in psychiatry. So 8 people within the campus have a major illness. Now, the next question comes in. Okay, we have this thing about schizophrenia, Van Gogh cutting is here, concreteness of mind, which is a brain condition. Now we are going a bit into from abstraction as not knowing, like, the poster on the wall with white spots, wherein people imagine their things or project their inner spaces, mind spaces. Now we got this thing like, oh, this has got something to do with the part of the brain called frontal lobe. And then we had other conditions. I was sitting in the medical college library, final year preparation, and we used to have this guy who used to come and sit, medical student, Usmania, bright red tie. Those days ties weren't popular, and crumpled shirt, a pair of pressed trousers and a jacket, a coat, and with glasses, and he used to sit on a table and smile at everybody and then come out and then talk to everyone. For 6 months he would do that, talking to everyone and being aggressive at times, irritable with the library attendant and everything. And then 6 months is not seen. So this was the pattern. Exams he passes a few exams, fails a few exams. Finally, in medicine, we were told, like, psychiatry may say, "Ek question to aayega pakka." So we started looking at something called bipolar. Oh, 6 months, there is a possible mood can go up like this and mood can go down like this. And during these high phases, he was wearing these beautiful ties and all, and then few phases he would not be seen in the library. This could be bipolar, wherein people are high, expansive, gregarious, friendly, and cheerful, and trying to do lots of things. He used to have a pile of books from surgery to pathology to philosophy on his table, library table. And kuch din dikhta hi nahi bilkul. So we said, bipolar. What is bipolar was? And then started looking, bipolar disorder ke liye to padhna hi hai. Ek question to pakka aata hai. So started looking at bipolarity. And looked at it, got prevalence 1 to 2% general population. So now 750 of students or 800 students in SVS Medical College. Usmania was the same number those days. 800 people mein kitne log bipolar honge? So 8 schizophrenia, 8 schizophrenia, and now 8 to 10 bipolar. So 20 people are ill in the college now. So good. I can't, if I'm a surgeon, if I have a catchment area of 800 population, if I live in a village with 800 population, how many surgeries will I do in my entire lifetime? Not many, but if I'm a psychiatrist, definitely 20 of pakka patients guaranteed, if you're the only psychiatrist. So the reason I tell is that people fear that psychiatry is a profession which is not economically rewarding. People think that psychiatrists don't earn money. People think that psychiatrists will live very bizarre lives, or people are odd and eccentric, or psychiatrists have a problem. That is the reason they join psychiatry. Like any other specialty of medicine, 800 people, 20 major illnesses. Leave away another possibility of 6 more illnesses on psychotic spectrum. So you have actually good 30 pakka patients forever. It's better than dermatology. Like some of the dermatology conditions, people say lifetime. దామాద్కు అల్లుడికి ఏం కట్నం ఇవ్వాలంటే ఒక 20 మంది పేషెంట్లను పంపించడం అని అంటారు. But like this is very, very different. Here you are actually helping people. These 30 patients will be leading a very successful life. Not only that, people used to say, psychiatry mein our patients ki penli cheskoleru, udyogalu cheskoleru, life etla lead cheyaleru. These 30 patients, if you were there practicing at that time, they will go to find a meaningful employment. They'll find a job. Almost all in the current climate, probably 20 years ago, the story was different. In the current climate, all my patients with a major diagnosis of schizophrenia or bipolar, they have a job. And more than 70% of patients are married. About all of those who are married have children, and they live meaningful lives, and they are actually taxpayers. Unlike some of the patients in other spectrums of illnesses where they'll not be earning, or 70% of my major illness patients are actually taxpayers. They're paying good amount of tax into economy, and the roads are working because of my patients paying taxes. So psychiatry, ladies and gentlemen, is a field where we have extraordinary outcomes, and now we have 750, 800 students in SVS. Now comes the next thing. Depression. How many, I think, I mean, like, we have a small crowd here, but lots of people online. People think depression is something which happens to somebody out there somewhere and never touches our lives. And go and talk to person one-to-one. I don't know of a single individual in my life. I meet a lot of people, and I'm active socially, I have friends. I consider myself reasonably active socially. So I don't know a single person in my life who doesn't know a person who has depression. Everybody knows somebody who has depression, and people think depression bole to are depression ante suicidal unte depression. No, depression is wherein our inner energy, the life chi or the source of energy, the inner space wherein you feel, your things you were enjoying, you're no longer enjoying. The world seems a boring place, it's no longer interesting, and your energy levels are down, you're feeling sad most of the time, most of the days for more than 2 weeks. So this story, if you look at depression, depending on which statistics we take, which country we follow, we know that even on the conservative estimates, 7 to 10% people will have what would be considered as major depressive disorder. Major depressive disorder. We are not looking at the depressive spectrum of illnesses. Depressive spectrum of illnesses would be something like, 20%, 23% in US statistics and 25% in UK stats. But lifetime possibility of feeling sad or feeling depressed at some point. But core clinical depression, 7 to 10% on conservative estimates. So now we have 800 leaving away the staff justice students. How many more do I have? 30 plus 10% really 80. So I have my 100 patients in a small village of 800 people. So now we have this 100 patients living in this community, and then we have obsessive illnesses, anxiety spectrum disorders. Anxiety is something which we all have experienced at times, like, people feel like, we all feel anxious before the exams. Like, are chhati mein gadbad ho raha hai. And like, my college days, we used to say, when Krishna went to, Krishna was at the war, and Arjuna goes and says, like, God, I'm having a conflict in my head. I don't know what it is. And those days, when younger days, Krishna asks Arjuna, what's that? What do you want? And what does Arjuna say? Aaj ki language mein, tension Keshava, emaitundo telustaledu. Full tension unnadi. So what is the tension, boss? This is like, a conflict inside my head. What's going to happen tomorrow? How am I going to deal with? How can I really do something and justify it? So these conflicts, these tensions do happen to everyone, and anxiety disorders are very common, and unfortunately they are pretty high amongst medical students. So now I have another 80 patients added to my list. Now I have a number of 180 people within the list. And then you take the other spectrum disorders, like, hyperactivity, attention deficit. And by the time people reach final year of medical students, we have this interesting bunch of students कि 8-10 लोग हर दिन बियर चलते रहता हॉस्टल रूम में. Must have heard of it. You will be having one hostel room ki, it's very popular that, like, this room every evening there is a beer party, every evening there is something happening. And we know that in the current climate there is an increased use of cannabis in the campuses, among student campuses. So that is another small spectrum of, how much do we have? 10-15 people at any given time in a campus. So 800 people, we have 200 people having some psychiatric need, an active psychiatric need. And what do we call it? 1 in 4. 1 in 4 people in the community will need psychiatric help at some point of time to take care of them. And for 800 community, how many psychiatrists do we have? We have a professor, we have an assistant professor, we have an additional professor, but they're taking care of patients from outside. These 800 people probably will need 2 people, a psychiatrist, a psychologist, and therapist. So this is this various spectrum and an extraordinary need. And ठीक है भाई, schizophrenia treat नहीं करेंगे, will not treat bipolar, will not treat depression, will not treat anxiety. What's going to happen? What's going to happen? People die. What happens in medicine if we don't treat certain conditions, if we don't treat a heart attack, people die. Similarly in psychiatry, if we don't treat, people die. How many people die? WHO estimates that 1 person dies every 40 seconds in the world. 800,000 deaths every year. That's an extraordinary number of people dying. 40 seconds may egg death to suicide. That's disgusting, that's unacceptable if we call ourselves humans and then we call ourselves like, something we are doing a great thing. We have opinion about everything. There is war somewhere, we want to say. There is pollution somewhere, we want to talk. There is Greta Thunberg, we want to say. And every idiot has an opinion about everything. But when it comes to people dying of mental illness, people want to turn a blind eye. They said, so he said, damag mein zara weak tha bhai. Or they were, he wasn't strong at heart. No, people die because they have major psychological illnesses, and they can range anywhere between, like, 13% in certain conditions to 15% in certain conditions. So 13% of people with bipolar illness and 15% of major severe depressive disorder kill themselves. That's a very sad state of affairs. And if you do treat them, you would have saved these lives. Ladies and gentlemen, and especially young doctors and to-be doctors, medical students, I urge you, this is your call. Psychiatry waiting for you, and I believe every physician who passes out of medical school is 70% psychiatrist and 30% physician. Because unless you have the skills of being a psychiatrist, you cannot be a doctor, you cannot be you cannot practice medicine without being psychiatrist. As Professor Gandayar said, like, varu emannaru nenu psychiatrist aidam anukunnanu kani varu roju practice psychiatrist chestha untaru anukunta migitha vishayalu endukante nenu na patient tho etla maatladutunna nenu enta reassure chestunna vaani manasikamayinatuvanti paristhiti etla undi. Simple things like, when a patient comes and says, like, recent COVID thing, and 50-year-old man comes or 60-year-old man comes and says, sir, he's lost his wife to COVID 15 days ago, 20 days ago, and he's very sad and depressed. What does a physician do? ఏం చేస్తామండి, ఇట్లా అవుతా ఉన్నది, కోవిడ్ వలన ప్రపంచమంతా అతలాకుతలం అయిపోయింది, చాలా నేను ఈ స్టోరీ బాగా మీకే కాదు చాలామందికి ఇట్లా అవుతున్నది, వాళ్ళందరూ బాధలో ఉన్నారు, అండ్ ఎందుకైనా మంచిది ఇగో ఈ 10 అమిట్రిప్టిలిన్ వేసుకోండి అని పంపిస్తారు. Libotripano, they give a small dose of antidepressant. These physicians are extraordinary people. The smart, you would see that the gold medalist of, somebody who writes this thing will not have greatest practice, but the successful physician who has big psychiatric chunk in his heart is a successful physician. Neurologist, you go and see, the successful neurologist has got 90% psychiatry, 10% neurology. physician, 70% psychiatric, 30% medicine. And what did the doctor say to his patient when he said, "Chalam mandiki avutundandi" ante? He spoke, it was psychotherapy in his own way. He's generalizing the experience, saying that the shared experience, lots of people are going through, you're not alone in this journey. And what else did he say? "I'm so sorry, it must be very tough on you." He's acknowledged the pain of the person. Without knowing the principles of psychiatry, he is practicing psychiatry on a day-to-day basis. And what did he do? A gentle dose of tricyclic. He said that's what he's trained in. When he was in the medical school, he's told, like, when you bunk your psychiatric classes, you would not know that. Or when you bunk your general medicine proper with a good physician who's got 70% psychiatrists in their heart, you would have missed that. But if you attend that, then, when you are a medical student, say, sir, liberty he's got something else, why are you giving tricyclic? And somebody comes in and says, like, we have this Hyderabad, lots of people come with body aches, somatic aches. Dr. Minhaj is an expert in the somatic syndrome. So, he tells his physicians, add a small dose of medicines or SSRI, sab theek ho jata. People say, sir, body aches, give an analgesic, investigate, do neurological examination, do this CT scan brain, do nerve conduction studies. And this clever physician, what does he say? Small dose of SSRI, and the patient is very happy, continuing with their lives very well. If you miss out on psychiatry, you miss out on medicine. Psychiatry is the core of medicine, and the core of medicine is empathy. Empathy is about experiencing somebody's pain to be yours, somebody's experience to be yours, and unless you experience that, you cannot practice medicine. And nobody else can teach you empathy and compassion as effectively as psychiatrists. And this is what I say, ladies and gentlemen, and young doctors, this is the key of medicine. I joined medicine because I care about other person and I feel somebody else's pain to be my pain and I want to resolve that pain. Mortality, reducing morbidity are secondary gains. If I prevent somebody dying, that's secondary. If I prevent people killing from themselves because of suicide, because of psychiatric illness, that's an additional bonus. But being able to experience somebody else's pain to be mine and then wanting to relieve it, to reduce as much as I want to reduce my pain, that is the core principle of medicine. And that I do it with dignity, respect, and compassion for patient without compromising the morality, ethics, and values which I engage in a relationship. No other specialty will make you learn this as part of your curriculum than psychiatry. So you want to be a great doctor, I think starting point would be psychiatry. People like, just I'll run through a few more slides. Sir, whenever it's time, you let me know, sir, I'll stop. People say, like, psychiatry is something which people chain. People no longer chain patients. This is a myth. Nobody restrains unless there is very this thing. And this is not the form of restraint. There are enough medicines now which take care of aggressive patients. And aggressive patients are very small number of psychiatric practices. If patients were aggressive, we wouldn't be practicing. All of the psychiatrists here and, in Telangana and everywhere, we would have all had broken bones. No, patients are not aggressive. And if you look at aggression among psychiatric population versus general population, like, if I'm going on the street and I meet 100 people, the likelihood of aggression, like road rage, car rage, and all those rages, versus psychiatric population are very least likely to hurt anyone in comparison to general population. The violence among psychiatric community is much lesser than the general population. You're more likely to get hit by an idiot on the street than any patient on the psychiatric wards. And this myth that, like, long-term sula dena, long-term current laga dena, this is absolutely rubbish. When people talk of ECT is an extraordinary treatment. If people get some time, go about seeing, talk to medical professionals who had ECTs. Doctors who were unwell who took ECTs, they vouch by it. We will not talk about, people have this huge thing. ECT, how can you put current to the head? No, ECT is a pretty safe treatment. Like, the amount of energy which is given is like, 300 millicoulombs. That's like, if I bang on this table, this is much lesser than 300 millicoulombs, the amount of energy which is delivered. So if people believe that ECT is barbaric, that's absolutely rubbish. We do have lots of procedures. There is lots of investigation which happens, lots of examination which happens, and there is dose titration. ECT is not like somebody puts plug into the mains and put electricity. No, 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 no. ECT happens in a very scientific manner, and people say, ECT se sab bhul jate. No, it doesn't happen anymore. So don't go under these myths that, like, we are giving ECTs to fry the brains up. No, that's not how it happens. ECT is an extraordinarily safe treatment, and we don't go about giving ECTs to everybody who walks through the door. In any clinician's practice, a very small fraction of patients who are very, very unwell receive ECTs, and they are also when there is high suicidality, depression with high suicidality. No drug in the world will save the patients as quickly as ECT does in depression with suicidality or depression with psychosis. So ECT is not a bad treatment. Don't go with these myths, like, don't go with things which are shown in cinemas that it's barbaric. ECT is a safe treatment. There are lots of other modern treatments as well. And this thing about sedating drugs being given, we psychiatrists are very conscious not to give sedatives. We are very conscious of our working population. As I said, like, almost all my patients contribute, they pay taxes. Gone are the days where people were, staying at home and they lock the door from outside. No, almost all my patients pay taxes. So we want people to be functioning well in the society, have a good married life, good sexual functioning, happy children in their houses, and they go about contributing. They go to the temple, they go pray, they have a nice time, they go to the parks, they go on holidays. And this idea of sedating medicine, because we find major myths are from doctors, sir. Actually, when doctors have their children, because these doctors have bunked their psychiatric posting. If they attended, they wouldn't have been speaking like that. So these people having myths are the ones who, damage or don't help the patient. They're rather hurting the patient's outcomes. So it's very important that you guys know psychiatry is not about giving medicines, sedating medicines forever, no. Sometimes in aggression we give medicines to calm down patients, but it's not the lifetime choice. Depression, we give medicines for 6 to 9 months, that's about it, and they're done. And certain conditions need medicines for a few days, some conditions need medicines for many years, but the thing is that they're pretty safe these days, and they're pretty, compatible with productive and successful life. And other thing people talk about is like, psychiatry, is for people who can't practice medicine. Well, psychiatry is for people who can practice medicine. If you want a challenge in life, it's, with no disrespect for any specialty, if I am an oncosurgeon, if I'm a cancer surgeon, I get a pathology biopsy in front of me saying that this is particular type of carcinoma. If I'm a breast surgeon, I know it's an interstitial carcinoma, or if it's a, a duct carcinoma, or if it's a benign tumor of some sort. I have a biopsy, I have a lesion location, I have the size of the lesion, and I have MRI, ultrasound, all the things laid in front of me. And how much brain do I have to use? Not much. Probably skill. A carpenter also has skill over a period of time. With no disrespect, I don't mean to say, skill is something which is acquired. A challenge is something I choose to go. And psychiatry poses a challenge for everyone. And every patient is very different. You might have diagnostic categories, the pigeonholing which we put in, but every patient makes you think. How lovely life is. Like, if your brain cells are used consistently, continuously, and every patient brings in what we call as insight. We have patients coming in and say, like, sir, today I went and spoke to my daughter. She's 16, and she said she has a boyfriend. And I'm really sad, I don't know what to do. And this is a very social insight. And if you have children who are 16, if you have a daughter who is 16, that brings in a lot of insight in terms of what's happening in the society and what's happening inside your own self when you do talk to this patient who has a similar experience. And it brings in the whole challenges of reflecting your own life. Not only that, At the same time, you want to really separate yourself and try to help the patient. Because that's not going to happen if you're going to have a patient who has got like, somebody who comes to you with diabetic ketoacidosis and you're managing in the hospital. It's unlikely to happen that like you're going to draw some insights into your life and you become a better individual, better human being, or better whoever it is. Psychiatry teaches you every moment of your day, every moment of your life to be a better individual, and perhaps one of the things I tell is to have a meaningful life. No other physician would constantly say like, కొంచెం slow down kandi అని అంటాం. Psychiatrists will say like, perhaps you need to take a little break. And when we mean break, like, slow down, reflect upon things, calm down, do some meditation, do some yoga. But the whole point is that it's to create the reflective spaces inside the patients, and it's not going to happen unless you are reflective yourself. And psychiatry, ladies and gentlemen, will make you reflect continuously, every day, every moment, and that's a useful tool for you to have in your life, because you're going to be that better person with your wife, with your children, with your husband, with your in-laws. So psychiatry is a tool which is a wholesome life tool. If I'm a surgeon, I'm not going to take any life tools or wholesome life tools into the system. And before I finish, I'll just have one thing which I wanted to say. Psychiatry, I told you, like, the journey of psychiatry. After finishing my medicine, I went to train at NIMHANS and then went to UK, started living there. And trust me, I had a great life. I wouldn't go back, like, if some people come in and say, like, oh, would you have been happy if you were to be a surgeon? I don't know how many surgeons would say, do you think you would have done differently? Oh, probably in a neurosurgeon aithe bagun. If I were to be given a choice again to practice, if I'm in medicine, whatever stage I am to choose, I'll still choose psychiatry. I'll not choose anything else other than psychiatry because it's given me great life. It gave me very comfortable living. I was, people, used to write PLAB exams and all those things. And those days, they gave me a PLAB exemption and gave me a job on the day when I went to UK. So psychiatry gave me those opportunities in life, which I wouldn't have got it. If I were to be a surgeon, I would have been in the queue, like, doing my PLABs for 6 months, 1 year. So psychiatry gave me those options. And psychiatry gave me this extraordinary insight into life about the connectivity between brain and mind. People think brain is different, mind is different. We know that, like, brain is probably an organic substrate through which mind operates. So it gives you that extraordinary things, and to think beyond what is available on the face of it. Because medicine always teaches you to be objective. Ye dekha karo. Oh, what is your X-ray finding? Viva question. What did you see on X-ray? What are your auscultation findings? Here it says, psychiatry is one subject which says, what do you feel? When you see the patient, how does it feel inside? Because when Kreplin said, like, broilers prior to this thing, he said something about the feeling inside the chest, dementia precox, about schizophrenia. The feeling you get when you inside your chest, precox, inside near your chest. So these experiences which are quantifiable, accountable, to help the patient, I think that's an extraordinary insight which you'd get in psychiatry. And I ask young doctors, please, 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 do consider psychiatry as as your career choice, because 800 people, we said 200 people have problem. 800 on the campus, 200 have problems. So we have 1 in 4 who need help. We know that every 40 seconds somebody dies. And it's our responsibility as a responsible society to have more and more number of psychiatrists in the community. It's the need of the hour. And when Telangana agitation was happening, Udyamam Samayamlo, there were lots of young people killing themselves. We didn't know how to go about helping. There was a need for a huge number of psychiatrists. So young doctors, medical students, I urge you, interns especially, psychiatry is your career choice. And I trust me, you'll never regret. You might do anything else and might regret, but if you become a psychiatrist, I think you'll have a great, great life ahead. Welcome to the Club of Psychiatry. Thank you.
Thank you very much, sir, for your lucid presentation and bringing out the truths of the psychiatry and the prospects and the life of the treating physician and the patients. Thank you very much, sir. And the incidence is very high, and what they say in general population is about 40% of the psychiatry problems. And those who are attending OPs is about 30% of the individuals. Inpatients is about 40%. It's very high. We need a lot of psychiatrists. Of course, non-psychiatrists also treating. So thank you very much, sir, to highlighting the importance of psychiatry in everybody's life. Thank you very much. Any questions? Sir is ready to answer.
So, sir, presently 240 undergraduate students are online participating in this. They're not visible to us here, but 240 of them have logged in and they are online, sir.
Thank you.
And all this is recorded. It is available even for seeing again afterwards. Just somebody has to click on the YouTube. It is going to YouTube.
Thank you.
In the YouTube, you have to feed IPSTSB. Then this presentation can be viewed at any time, even after this. Thank you.
Thank
We
you,
can proceed
sir.
with the question and answer session, sir.
Any questions, please? Those who are online and those who are in the gallery, welcome for any questions. Sir is ready to answer. Anybody in the gallery like to?
Okay.
If no questions,
If no questions, let us then proceed.
thank you.
I once again thank Dr. Praveen Kumar sir for inviting UG students to psychiatry and at the same time efficiently challenging and addressing the widely held myths about psychiatry. I now request our chairperson Dr. Gandaya to present a memento to the speaker. Dr. Praveen Kumar sir. Thank you, sir. May I now request Vice President IMA TSB and Chairman of SAARC Countries Affairs Subcommittee IPS, Dr. P. Kishan sir, to please present a memento to the chairperson of the session, Dr. Gandaya sir. Thank you, sir. Thank you, sir. Let us now proceed with the next session of the day, that is the inaugural function.
In 2 minutes, we'll reorganize the stage and then we'll start.
I once again welcome you all to the Indian Psychiatric Society Telangana State Branch 6th Annual CME program with the theme Knowledge Update to Every Partner in Mental Health Care. The first program that we have now is the inaugural function that will be lasting from 10 to 10:45 a.m. Let us take a break for around 2 to 3 minutes for the arrangements for the inaugural function. I would like to begin the program by the inaugural function. First, I would like to invite the dignitaries to the dais. I request our President IPS Telangana State Branch, Dr. G. Jagannath Sir, Director Asha Hospital, to please come on the dais. Next, I request our chief guest for today's program, Dr. B.N. Gangadhar Sir, Chairman, Ethics and Registration Board, National Medical Commission, to please come on the dais. Next, I request Vice President IPS Telangana State Branch, Dr. M. Rama Subba Reddy Sir, Professor of Psychiatry, Osmania Medical College, to please come on the dais. Next, I request Organizing Chairperson of the CME program, Dr. K. Ashok Reddy Sir, Professor of Psychiatry, SVS Medical College, to please come on the dais. Next, I request our guest of honor, Dr. K.P. Joshi Sir, Vice President, SVS Medical College, to please come on the dais. Now I request Honorary General Secretary IPS Telangana State Branch Dr. Minhaj Zafar Nasirabadi Sir, Professor of Psychiatry DCMS, to please come on the dais. Now I request our Organizing Secretary of the CME program Dr. Vijay Raj Pratik P Sir, Assistant Professor of Psychiatry SVS Medical College, to please come on the dais. Now I request Chairman Scientific Committee, Dr. R.S. Swarupachari Sir, Professor of Psychiatry, SVS Medical College, to please come on the dais. Now I request Treasurer, IPS Telangana State Branch, Dr. Vishal Akula Sir, Assistant Professor of Psychiatry, Government Medical College, Nizamabad, to please come on the dais. Now I request Editor, IPS Telangana State Branch, Dr. Sai Krishna Puli Sir, Associate Professor, Chalmeda Anand Rao Institute of Medical Sciences, Karinagar, to please come on the dais. Now I would like to hand over the mic to the presiding officer, Dr. G. Jagannath Sir, for the inaugural function.
Thank you, Saida. We'll start the program with the prayer sung by Dr. Srishti and Dr. Tanmayi.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय पालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरि जुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
Now I request Dr. R.S. Swarupachari, Chairman, Scientific Committee of this CME program, to read the messages sent by the well-wishers.
Thank you, sir. Thank you very much. Good morning to the respected dignitaries, delegates, my seniors, colleagues, and my dear students. I extend a warm welcome to all of you to the 6th annual CME program of Telangana Psychiatric Society. I am Dr. R. Swaroop, working as Professor of Psychiatry at SVS Medical College and Hospital. I would like to take this opportunity to facilitate the conveyance of messages from our respected directors, management of SVS Medical College, and the messages from other eminent well-wishers who could not make it to this program today. And the first message is from Dr. Raghuram Reddy sir. The message goes like this. It is noted with immense pleasure that 6th annual CME IPSTSB is being organized on 11th April 2021 at SVS Medical College, Mehboob Telangana State, both as a webinar and also physical sessions. It is noteworthy that the organizers have, with a wide vision, selected the theme, knowledge update to every partner in mental health care. Taking care of various partners in mental health care. It is done with diligence to cover all dimensions of mental health care, a contemporary approach to the care of psychiatric patients. The CME is being inaugurated by Padma Shri Dr. B.N. Gangadhar sir, the chief guest, who is a distinguished psychiatrist, has been an able administrator and learned person with knowledge in various aspects of mental health care. Hence, his presence is a source of inspiration to the participants and presenters. This is a message by Dr. P. Raghuram Reddy sir, who is a consultant psychiatrist at Asha Hospital, Hyderabad. So, thank you very much, sir. Thank you very much for your words of appreciation, and you have our deepest gratitude. Thank you, sir.
Now I request Dr. K. Ashok Reddy, organizing chairman, to give the welcome address.
Okay, sir. Okay, sir.
We are skipping one message from our. Is there? Okay. You just. రాలే కదా KJ Reddy sir, you can start your message, sir. Please give your message. We are here listening to you.
Thank you. Good morning. It's a great honor and privilege to be part of your meeting. Thank you very much, Dr. Ashok Reddy Garu, for organizing a wonderful meeting. Can you hear me, Dr. Ashok Reddy?
Hearing, sir, hearing. All of us are hearing in the hall, sir. And online also.
And
We are not able to see your video, but we are able to hear you, sir.
Yeah. As I've been always saying, Dr. Ashok Reddy is very passionate about teaching, training, conferences, and we're very fortunate to have him along with his team. And it's a great honor to give this opportunity for the hosting this meeting. And as I think I was listening to previous lectures, as all of us know, psychiatry problems are underdiagnosed, undertreated. Not most of the people do not come forward for the treatment, and especially during this difficult time, we have to continue the care of the patients as well as educating ourselves, exchanging our views by way of organizing these meetings. And I just wanted one word about SVS. We started our hospital in 1998, first batch in 1999. So it's about 22 years ago we started this medical college in Mahbubnagar. And we have 150 admissions presently, about 350 postgraduates in all specialties. And it's a 1,000-bed hospital with 14 operating theaters, about 90 ICU beds. And we are treating, diagnosing so many COVID patients. We had about 120 beds dedicated for COVID patients, which were free. And now yesterday, there was a meeting with the government requesting us to increase the beds. Probably very soon, we're going to make it 150 beds. So once again, I thank Gangadhar Garu. I spoke to him this morning. Such a wonderful and a great personality to come and inaugurate as a chief guest, and all the faculty and the psychiatry, Telangana Psychiatry Association, all the speakers and faculty, and all the delegates. Once again, wish you all the best. Have a wonderful meeting. Thank you once again.
Sir, thank you very much, KJ Reddy Garu. Thank you for your message, sir. Now I request Dr. Ashok Reddy, organizing chairman, to welcome the gathering.
Very good morning to all those persons who are in the hall now, and especially the President, Dr. G. Jagannath of the IPS Telangana State Branch. We welcome you, sir, to the city of Mahbubnagar and SVS Medical College. And we are grateful to you and your team for permitting us to conduct today's program here, which is actually a part of the annual conference, the second day component of the annual conference. Because of the COVID, we have completed the first part of the annual conference in September, and the second component of the CME program, we are conducting it today. Welcome you, sir. I welcome Dr. B.N. Gangadhar, today's chief guest, President, Medical Ethics and Registration Board of National Medical Commission, a great personality who has retired from NIMHANS, Bangalore, who has shown the way for many of us how to think in a simple way, lead a simple life, and benefit the society at large. I worked with him for a year at NIMHANS as senior resident, and the affection what he showed at that time, he shows even today. I am grateful you, sir, and welcome to the Mahbubnagar and SVS Medical College, and thank you so much, sir. We welcome our President, Vice President, Ram Subba Reddy Garu, for gracing today's occasion on our invitation, because your presence will encourage us to conduct more such programs. Welcome you, sir. I welcome Dr. K.P. Joshi, Vice Principal, very dynamic, active personality in this college. All the groundworks are done by him. He was helpful in each and every aspect of conducting this today's CME program. To connect to the students, he has helped a lot. To arranging all the things, he will coordinate between us and the management and extends a great help. Sir, 240 undergraduate students have logged in the morning. Welcome to this session today. I welcome Dr. Swarupachari, our Professor of Psychiatry from our unit, who is also a part of today's program. Welcome you, sir. I welcome Dr. Minhas, a dynamic Honorary Secretary of IPSTSB, who has helped me in communicating the invitations twice or thrice so that more people could log in for today's program. And as of now, 272 people have registered for today's program. We are not seeing them here, but they are online. So total 272 registrations have occurred with your effort. Dr. Minas, thank you and welcome. We have Dr. Pratik, Assistant Professor of Psychiatry from our department, who is a right hand to me, who will execute all the orders what I give and makes my job comfortable. He has done all the groundwork. In the last 1 week, he was working very hard. We welcome you to this program. We welcome Dr. Sai Krishna Puli, a very dedicated editor of IPSTSB, who is developing our journal to a great extent. And he is requesting all of us to publish more articles in his journal, and is very dynamic. We should help him how to improve the journal much more. We welcome you to today's program. We have a very dynamic treasurer, Dr. Vishal Akula, who is from Nizamabad, who works very hard for mental health awareness programs from IPS, TSB, and also at the national level of IPS. Welcome you, sir, for today's program. We welcome all the chairpersons. Here we have Dr. P. Kishan, Dr. K. Chandrasekhar, who is my teacher in psychiatry, a very dedicated teacher. I should be failing in my attempt if I don't explain his commitment to the teaching, even after resigning from the government service. He used to teach us, coming to the institution in the evenings after his practice, and he prepared us for examination. We remember your efforts, sir. Thank you so much, and welcome to this program. We have other chairpersons, Dr. Keshwar Rao, Dr. Sudharani. Here, we welcome all of you. And Dr. Mrs. Sunita from the College of Nursing. We welcome all the speakers of today. The first speaker, a wonderful speaker, we heard Praveen Chintapati, who makes the programs very active and dynamic. Welcome you, sir. We welcome all other. Our chairperson, Dr. Gandaya, Professor of General Medicine here, is also a teacher for me at Osmania Medical College. He is a great committed teacher in this medical college. He encourages students to participate. Welcome you, sir. We welcome other speakers, Dr. Anita, Dr. Chaitanya Lakshmi, Dr. Ashok Chandani, Mrs. Padmaja to this program, and welcome all the delegates who are in the hall and online to today's program. Thank you so much. Thank you, Mr. President.
Now I request the chief guest, Dr. B.N. Gangadhar, to water the Tulsi plant and inaugurate the CME session. Respected chief guest of today's function, Padma Shri Dr. B.N. Gangadhar, former director of NIMHANS and current chairman of Ethics Committee of National Medical Council. Dr. KP Joshi, Vice Principal, SVS Medical College, Organizing Chairman of the present CME, Dr. K. Ashok Reddy, my fellow office bearers of IPSTSB, Dr. Ram Subba Reddy, Dr. Minhaz Nasirabadi, Dr. Vishal Akula, Dr. Sai Krishna, Dr. R.S. Swarupachari, Chairman Scientific Committee of this CME, Dr. Vijay Raj, Organizing Secretary of the CME, Senior Psychiatrist Dr. Kishan, Dr. Chandrasekhar, Dr. Ashok Alim Chandani, Dr. Praveen Chintapanti, Dr. Sudharani, Dr. Anita, and Dr. Gandai Garu, and all the senior people. Speakers and chairpersons who have come to share their knowledge with us today, PG students, ladies and gentlemen. On the behalf of IPS Telangana State Branch, I welcome you all to this CME program, which is an extension of the 6th Telangana Psychiatry Annual Conference, which was held on 6th September 2020 in this same auditorium. It is my great privilege to share the dais with Dr. B.N. Gangadhar. I thank Dr. Ashok Reddy for giving me such an opportunity. The theme of today's program, knowledge update to every partner in mental health care, reflects the commitment of Dr. Ashok Reddy in educating the people from different walks of society about mental health programs. మరి డాక్టర్ గారి అశోక్ రెడ్డి గారి కమిట్మెంట్ గురించి చెప్పాలంటే మీ అందరికీ ఒక విషయం తెలియజేయాలి. మనం మానసిక వ్యాధుల గురించి అనేక విధాలైన అవగాహన కార్యక్రమాలు సదస్సులు చేపడుతూ ఉంటాం. దీనివల్ల ప్రజలలో అనేక విధాలైన అవగాహన డెఫినెట్గా పెరుగుతున్నది. కానీ ప్రజలకి మన మీద ఎప్పుడు కాన్ఫిడెన్స్ వస్తుందంటే వాళ్ళకి అవసరం ఉన్నప్పుడు మన అందుబాటులో ఉన్నట్లయితేనే మన మీద కాన్ఫిడెన్స్ వస్తుంది. ఇది డాక్టర్ అశోక్ రెడ్డి గారు 1990 సంవత్సరంలోనే గ్రహించారు. ఆ రోజుల్లో అన్ని జిల్లాల్లో సైకియాట్రిస్ట్ లేరు, ఇప్పట్లాగా అన్ని జిల్లాల్లో సైకియాట్రిస్ట్ లేదు. ఎస్పెషల్లీ డిస్ట్రిక్ట్స్ మహబూబ్ నగర్ కానీ, నిజామాబాద్ కానీ, ఆదిలాబాద్ డిస్ట్రిక్ట్స్లో అసలుకే సైకియాట్రిస్ట్ లేరు. ఆ రోజుల్లో డాక్టర్ అశోక్ రెడ్డి గారు ప్రతి 2 వారాలకి ఒక్కసారి, అంటే మొదటి ఆదివారం, 3వ ఆదివారం రోజుల్లో బస్సులో హైదరాబాద్ నుంచి నిజామాబాద్కి వెళ్ళి అవుట్ పేషెంట్ సేవలు నిజామాబాద్లో అందించేవాళ్ళు. అట్లాగా ఒక్కసారి కూడా మిస్ కాకుండా 15 సంవత్సరాలు నిరవధికంగా వెళ్ళారు. వారి తర్వాత మేము కూడా కొన్ని రోజులు నిజామాబాద్ వెళ్ళాము, కానీ మా వల్ల కాలేదు. 1 సంవత్సరం రోజుల్లోనే ఆ కార్యక్రమాన్ని ముగించుకున్నాము. కానీ వారి ఇచ్చిన బుక్లెట్ వెనకాల ఇన్ ఎమర్జెన్సీ ప్లీజ్ కాంటాక్ట్ డాక్టర్ జగన్నాథ్ అని చెప్పి నా నెంబర్ ఉన్నది. ఈ రోజుకి కూడా నాకు అనేక విధాలైన టెలిఫోన్ కాల్స్ వస్తున్నాయి, డాక్టర్ అశోక్ రెడ్డి గారు వస్తున్నారా, ఎప్పుడు వస్తున్నారా, ఎక్కడ అని చెప్పి. ఇదే సందర్భంలో డాక్టర్ అలీం చందాని గారి గురించి కూడా నేను చెప్పదలుచుకున్నాను. వారు కూడా ఇక్కడి నుంచి ఆదిలాబాద్లో ఉన్న మంచిర్యాల పోయేవాళ్ళు. ఆదివారం మంచిర్యాల పోయి అక్కడికి వాళ్ళ ప్రజలకి సేవలు అందించేవాళ్ళు. దట్ ఈస్ ఎ గ్రేట్ థింగ్ యాక్చువల్లీ. మరి ఈరోజు ప్రోగ్రామ్కి కనుక వస్తే, వారు ఈ ప్రోగ్రామ్స్ని అరేంజ్ చేసింది చాలా చాలా చక్కగా ఉన్నది. యూజువల్లీ ఇట్లాంటి CME ప్రోగ్రామ్స్లో మనము ఉట్టి సైకియాట్రిస్టులకే కావాల్సిన ప్రోగ్రామ్స్ అరేంజ్ చేస్తుంటాము. లాస్ట్ ఇయర్ ఓన్లీ డాక్టర్ గారు చెప్పారు, అశోక్ రెడ్డి గారు, జగన్నాథ్ మేము ఈసారి నేను కొత్తగా ఐఎంఏ డాక్టర్స్ని కూడా ఇన్వాల్వ్ చేయదలుచుకున్నాను, జనరల్ ప్రజలకు కూడా పనికి వచ్చే సైకియాట్రీ సబ్జెక్ట్స్ గురించి తెలియజేయదలుచుకున్నాను, కానీ కోవిడ్ నిబంధనల వలన ఈసారి నేను కండక్ట్ చేయలేకపోతున్నాను, మాకు త్వరలో ఇంకొక అవకాశం ఇవ్వాలి అని చెప్పి ఆ రోజే చెప్పారు. దానికి మేము అందరం కూడా ఏకగ్రీవంగా ఒప్పుకొని సార్ మళ్ళీ చెప్పగానే వెంటనే మేము డేట్ని ఫిక్సప్ చేసాము. ఈ ప్రోగ్రామ్ని కండక్ట్ చేస్తున్నందుకు మేము మీకు ధన్యవాదాలు తెలియజేస్తున్నాం. ఈరోజు ప్రోగ్రామ్ కనుక మనం చూస్తే, హాల్ ఏలో ప్రోగ్రామ్ చూస్తే ఫస్ట్ ప్రోగ్రాము డాక్టర్ ప్రవీణ్ చింతపాటి గారు వాళ్ళు ఎంబీబీఎస్ స్టూడెంట్స్కి సైకియాట్రీలో ఇంట్రెస్ట్ ఏ విధంగా కలగజేయాలి అన్నది చెప్పారు. సో మన అందరికీ తెలిసింది ఏంటంటే ఈనాటి పిల్లలు రేపటి పౌరులు కాబట్టి మన ఎంబీబీఎస్లోనే సైకియాట్రీ గురించి వాళ్ళకి ఎక్కువ ఇంట్రెస్ట్ కలిగజేస్తే వాళ్ళు మిగతా దేశాల్లో సైకియాట్రీ పీజీ కోర్సులో సైకియాట్రీ ఫస్ట్ చాయిస్ లాగా ఏ విధంగా ఉంటుందో త్వరలోనే మన దేశంలో కూడా తొందరగా సైకియాట్రీ ఫస్ట్ చాయిస్గా అందరూ చూస్ చేసుకుంటారని చెప్పి నేను అనుకుంటాను. మిగతా టాపిక్స్ చూస్తే ట్రాన్స్క్రేనియల్ డైరెక్ట్ కరెంట్ స్టిమ్యులేషన్ అది ఎక్స్క్లూజివ్లీ ఫర్ డాక్టర్స్. తర్వాత టెలిసైకియాట్రీ ఈ కాలంలో ఎస్పెషల్లీ కరోనా రోజుల్లో టెలిసైకియాట్రీ అనేది చాలా పాపులర్ అయ్యింది. మనము పేషెంట్లు మనకి హైదరాబాద్కి కానీ దగ్గర ఊళ్ళకి కానీ పెద్ద నగరాలకు వచ్చి సైకియాట్రిస్ట్ని కలవడం కష్టము. అట్లాంటి అప్పుడు ఈ టెలిసైకియాట్రీ చాలా చక్కగా డెవలప్ అయింది. ఇంకా దీన్ని ఏ విధంగా డెవలప్ చేయొచ్చు, జనరల్ పబ్లిక్కి ఏ విధంగా మనం సహాయం చేయవచ్చు అని చెప్పి టెలిసైకియాట్రీ కూడా అరేంజ్ చేశారు. అదేవిధంగా అలీం చందాని గారితో మనకున్న క్లినికల్ స్కిల్స్తో ఇన్వెస్టిగేషన్స్ని కంబైన్ చేసి బెస్ట్ మెడికల్ కేర్ని ఏ విధంగా ప్రజలకి అందించాలి అని చెప్పారు. అదేవిధంగా స్త్రీలలో రీప్రొడక్టివ్ ఏజ్లో వచ్చే మానసిక వ్యాధుల గురించి మన సమన్వి తెలంగాణ సైకియాట్రీ సొసైటీ యొక్క ఉమెన్స్ వింగ్ సమన్వి తరఫున డాక్టర్ అనిత గారు, డాక్టర్ చైతన్య లక్ష్మి గారు మాట్లాడబోతున్నారు. లాస్ట్కి ఇప్పుడు మనము ఎంత చేసినా కూడా సైకియాట్రీలో ఎంత చేసినా కూడా రీసెర్చ్ అనేది చాలా ముఖ్యం. దాని వలన వచ్చే రోజుల్లో ఏ విధంగా మనము ప్రజలకి కొత్త కొత్త పద్ధతుల్లో హెల్ప్ చేయగలుగుతామని తెలుస్తుంది. దాని గురించి ఏ విధంగా రీసెర్చ్ చేయాలని చెప్పి డాక్టర్ ఆనంద్ గారు తెలియజేస్తున్నారు. ప్లస్ వెన్ వీ కమ్ టు ద హాల్ బీస్ ఫర్ ద జనరల్ పీపుల్, ఇప్పుడు సైకియాట్రీ అనగానే ఇట్ ఈస్ నాట్ ఎ సింగిల్ మ్యాన్స్ ఎఫర్ట్, ఇట్ ఈస్ ఎ గ్రూప్ ఎఫర్ట్. దాంట్లో సైకియాట్రిస్టులు ఉంటారు, సైకాలజిస్టులు ఉంటారు, సైకియాట్రీ నర్సెస్ ఉంటారు, సోషల్ వర్కర్స్ ఉంటారు, అందరూ ఉంటారు. అయితే దాంట్లో ఒక కాంపోనెంటు ఒక సభ్యులు ఎవరు అంటే నర్సెస్. సైకియాట్రీ నర్సెస్లో పిల్లలకి సైకియాట్రీ నర్సింగ్ స్టూడెంట్స్కి ఏ విధంగా సైకియాట్రీలో ఇంట్రెస్ట్ కలగజేసి వాటి గురించి తెలియజేయడానికి ఛాలెంజెస్ ఇన్ సైకియాట్రీ నర్సింగ్ ఫర్ నర్సింగ్ స్టాఫ్ అండ్ స్టూడెంట్స్ అని చెప్పి ఆర్గనైజ్ చేశారు. చాలా చక్కటి ప్రోగ్రామ్ ఆర్గనైజ్ చేశారు. తర్వాత మన యొక్క సమాజంలో అతి ముఖ్యమైన మానసికమైన వ్యాధి, చాలామందిలో ఉండే మానసిక వ్యాధి ఏంటి అంటే డిప్రెషన్. దాన్ని ఏ విధంగా తెలుసుకోవాలి, తొందరగా తెలుసుకొని ఏ విధంగా ట్రీట్మెంట్ చేయాలి అన్నది తెలియజేయడానికి ఈరోజు డిప్రెసివ్ డిజార్డర్స్ ఇన్ డే టు డే క్లినికల్ ప్రాక్టీస్ ఫర్ నాన్ సైకియాట్రీ డాక్టర్స్ కోసం అరేంజ్ చేయగలిగారు. అదేవిధంగా పిల్లల్లో పేరెంటింగ్ స్కిల్స్, ఈరోజు మన పిల్లల్ని ఏ విధంగా మనము చక్కటి వాళ్ళకి ఏ విధంగా పెంచితే వచ్చే రోజుల్లో ఏ విధంగా మంచి పౌరులుగా అవుతారు, వాళ్ళు భవిష్యత్తులో మంచి పౌరులుగా అవుతారని చెప్పడానికి పేరెంటింగ్ స్కిల్స్ గురించి కూడా చేశారు. తర్వాత అన్నిటికన్నా ముఖ్యమైనదంటే మీడియా అండ్ మెంటల్ హెల్త్. మనము చాలాసార్లు చూస్తుంటాము. ఇన్ఫ్యాక్ట్ కోర్టులో ఒకసారి ఇది కూడా జడ్జిమెంట్ కూడా వచ్చింది, ఆత్మహత్యలు ఎవరన్నా చేసుకుంటే ఫ్రంట్ పేజీలో వెయ్యకూడదు, మూల పేజీలో లోపల ఎక్కడైనా వెయ్యాలి. ఎందుకంటే ఒకసారి ఆత్మహత్య చేసుకొని గవర్నమెంట్ కానీ ఏమైనా సంస్థలు ముందుకు వచ్చి అట్లాంటి వాళ్ళకి ఆర్థిక సహకారం చేసినట్లయితే మిగతా వాళ్ళు కష్టాల్లో ఉన్న వాళ్ళు కూడా అదే విధంగా పాల్పడే ఛాన్స్ ఉన్నది అని చెప్పి వాళ్ళకి సర్టెన్ గైడ్లైన్స్ విడుదల చేశారు. మరి వాటి అందరికీ ప్లస్ మిగతా సొసైటీలో ఉన్న మానసిక వ్యాధుల గురించి మీడియా వాళ్ళకి తెలియజేసి, ఇప్పుడు నేను మాట్లాడిన పెద్దగా మీడియా పట్టించుకోరు కాబట్టి పెద్దవాళ్ళు ఎవరైనా మాట్లాడితే దానిని హైలైట్ చేసి మంచిగా న్యూస్ పేపర్లో పెద్దగా ఫ్రంట్ పేజీలో వేసి మానసిక యొక్క వ్యాధుల యొక్క ఇంపార్టెన్సు, దానిని ఏ విధంగా ట్రీట్మెంట్ చేయవచ్చు అని చెప్పడానికి మీడియా పెద్దగా రోల్ ప్లే చేస్తుంటుంది. వాళ్ళకి అవగాహన కోసం ఒక కార్యక్రమాన్ని అరేంజ్ చేశారు. తర్వాత now that Dr. Gangadhar is here, I would like to know, even though India is considered as equal to the facilities present abroad in other fields, like in other specialties like cardiology, cardiothoracic surgery and neurosurgery, why psychiatry treatment in India is considered as low when compared to the other countries, especially European countries? We have very good institutes, psychiatry institute like world-class psychiatric institute like NIMHANS and PGI Chandigarh. The psychiatrists from there are there almost everywhere in the world, but we are still considered as not equal when compared to the other countries, especially as far as treatment is concerned. Is it because of lack of other paraphernalia or any other reason? Probably Dr. Gangadhar is the best person to tell us. Finally, I congratulate Dr. Ashok Reddy and other members of the organizing program and the participants of top level psychiatry teachers, even though there is a corona pandemic, and it all shows their affection towards Dr. Ashok Reddy. Thank you very much. I wish the program all the success. Thank you. Now I request Dr. Minhas to give the report about the activities of IPS Telangana State Branch.
Thank you, sir. Respected Chief Guest, Padma Shri Dr. B.N. Gangadhar sir, Guest of Honor Dr. P.K. Joshi sir, President Dr. Jagannath sir, Chairpersons of today's CME Dr. Ashok Reddy sir, our Vice President Dr. Ram Subba Reddy sir, Dr. Vishal Akula, Treasurer, IPSTSB, Editor Dr. Sai Krishna, CME Scientific Committee Chairperson Dr. Swarupachari, Dr. Vijay Raj Pratik, Organizing Secretaries, and dignitaries of the dais, dignitaries and delegates of the dais and online. A very good morning to all of you. I would like to summarize the activities of IPS Telangana State Branch from 6th September 2020, our conference day when Dr. Jagannath sir took over as president. We had wonderful conference on hybrid mode with 150 delegates participated in SVS Medical College and IMH Hyderabad. We had Padma Shri Dr. Gangadhar sir and Dr. Murugesh Vaishnav sir for Oration Awards. Along with other awards, we had quiz competitions and other activities of our conference. We organized World Suicide Prevention Day with various competitions conducted all over Telangana state, like painting, essay writing, story writing competitions all over the state, along with CME on suicide prevention for practitioners. This was done with IMA Telangana State Branch, and myself, I was the speaker of this CME. On World Alzheimer's Day, along with IMA Telangana State Branch, we conducted CME for psychiatrists and practitioners with Dr. Bharat Kumar Reddy as speaker, and around 150 participants attended the program. On occasion of World Mental Health Week, a week-long series of webinars were conducted in association with IMN Telangana State, Hyderabad Psychiatric Society, Karimnagar Psychiatric Society, IMA Hyderabad City Branch, with eminent psychiatrists as speakers and chairpersons from all over Telangana states. We had around 7 sessions of CME every day evening, and we had around 100 to 150 participants in each CME. IPSTSB PG training program 2021 was held on 10th January 2021 by Department of Psychiatry, RIMS Adilabad, organizing chairperson being Dr. P. Kishan sir and Dr. Om Prakash as organizing secretary. Apart from this, we had webinar on communication in relationship by Dr. Neena Sawant, Professor, KEM Hospital, Mumbai, on 14 February, that is Valentine's Day for young adolescents, so that they can communicate and they have proper knowledge about things in relationship. Indian Psychiatric Society, Telangana State Branch 6th midterm CME was held on 28 February 2021 at IMH Hyderabad on marriage and psychiatry, and we had Dr. Praveen sir again there as speaker, Dr. V.K. Mundra sir from Bombay. Organizing chairperson was Dr. Uma Shankar sir, and organizing secretary being Dr. George Reddy. A cricket tournament was Sayata was organized a week before. We started a women's wing, Samanvi, for women empowerment in line with South Zonal branch, and we have 5 of our very strong women members. Dr. Anita is one of them in our Samanvi team. Amount of 1.16 lakhs was donated to Dr. Mrs. Leela Kripal Singh for her fight against COVID 2019. This was apart from supplying PP kits to government institutes all over Telangana state. On World Bipolar Day, a national level CME was held with around 200 participants. This was along with Society of Bipolar Disorder, Indian Society for Bipolar Disorder. Now a fund is being collected for fight with cancer for one of our colleagues. Till now around 3 lakh rupees have been collected for him. He is one of our colleague who is fighting cancer and has some financial difficulty. These funds are collected with our treasurer. Thanks to our treasurer for being generous and helping us out for this. Thank you, Dr. Vishal. Apart from this, our journal is moving ahead with Dr. Sai Krishna with all his efforts, and he has been working very hard. He has changed our publisher, and he's collecting funds for the journal, and he's asking for quality articles. And now we are here for the remaining part of our conference, annual conference, remaining CME, which was part of our 6th annual conference. Thank you, one and all. I wish the organizers very best for today's program. Thank you.
Thank you, Dr. Minhas. I forgot to mention the names of Mrs. Sujata and Mrs. Padmaja, the nursing lecturers of lecturers in Government Nursing College, Mehboob Nagar. We welcome you, ma'am, for this CME program. Now I request Dr. K.P. Joshi. Joshi sir, last time we have seen your hospitality and we all enjoyed. So when Dr. Ashok Reddy told us that we are going to come again, we thought we can again enjoy your hospitality.
Thank you,
now
sir.
I request to say a few words.
Sure. Yeah, so respected chief guest of today's program, Dr. B.N. Gangadhar sir, then Dr. Subbarao sir, Dr. Jagannath, Dr. Minhas, and Dr. Ashok Reddy sir, and all the dignitaries on the dais, and all dear students who has joined online. Good morning, everyone. First of all, on behalf of the institution, I would like to welcome our chief guest. It's really an honor for sir to have you here. And the next, I would like to congratulate Dr. Ashok Reddy sir for organizing such wonderful CME program and requesting sir and getting sir here in our institution. As already our managing director, who himself is a backbone for our institution,
And all our directors, our group of management, they always encourages such program here. In last 13 years, since I am here, since last 13, I can say there is no year has gone in which we did not encourage such program, conferences, CMEs, all other things we always do encourages, and especially Dr. Ashok Reddy sir, I think I remember every year, sir, at least 4 programs we do conduct, somehow for the benefit of the society, for the benefit of the students. So thank you so much, sir. And regarding the institutions, already our managing director, Dr. K.J. Reddy sir, has told that it is 21 years old and all these things we are having. So we do encourage such things to impart the knowledge for the youngsters. As far as concerned the theme, I am really happy. Why? Because I would like to share my personal experience regarding this, approach towards the psychiatric problem. Whether the youngsters, whether the medical students, whether the postgraduate students also. The problem lies that nobody feels that it is so important. They feel that it is lightly, they take it easy. Sarale, mira chuskondi, we can deal it in a light way. So such ignorance, definitely it has come down, or the awareness has increased with the time, like the time passes, if you say 10 years or 20 years before, now it has increased at such a level. But still there is a need, there is a need of hour, especially during this COVID time. Even the educated people, even the doctors, even the medical students, everywhere the people need the right knowledge regarding the psychiatric issues. Definitely all psychiatric problems don't need the medications that everybody knows. But rightly where they need to go, how they need to be counseled, where the need of the psychologist, where the need of the real psychiatric person, that has to be told. If everyone will feel that, okay, ignore it, that is what the main problem is that. This was the morning session was very important for the undergraduates, even for the medical students, even for any graduates, whether nursing student, any adolescent, any youngsters. So it is very important to encourage such programs where the audience, the stakeholders are more. All cadre of people are involved, and they will emphasize the importance of the, such kind of knowledge where they can at least feel that there is a need of a psychiatrist. You can refer somewhere. You can ask the help of the nearby person who is available over there. For that, awareness is the only way. You cannot go door to door, you cannot prescribe the medicine, you cannot see that. So the awareness, the only thing, you must have the right knowledge that where the person need to go, where is the need for that. Many times students comes to us, many times PGs comes to us, many times the parents comes to us with a very, complicated issues. If they would have been addressed earlier, that complication might have not come. So I think it is a very nice CME, a nice program. So I would like to congratulate whole team of Dr. Ashok Reddy sir and Psychiatry Department and this State Telangana Psychiatric Association for giving us an opportunity, and thank you very much for your comments, sir. It is all our management who gives trust to us to give the hospitality and care for the delegates. So we do our from level best. So thank you very much for the management again for giving us opportunity, and thank you so much for you for appreciating our efforts. We will definitely continue, and I hope this is stay. And this one-day CME program will be very fruitful for each and everyone. All stakeholders will enjoy it, and definitely at the end of the day, something will come out which will be very useful for the society and for our students. And thank you so much, sir, for giving this opportunity. Thank you so much, sir.
Thank you, Dr. Joshi. Now coming to the most important part in the inaugural function, the address by the chief guest. సార్ మీరు ఇంత కరోనా రోజుల్లో కూడా బెంగళూరు నుంచి ప్రయాణం చేసి మా తెలంగాణకి వచ్చి మీరు ఈ యొక్క కాన్ఫరెన్స్ని ఇనాగ్రేట్ చేయడానికి ఒప్పుకున్నారు సార్. ఇది మా యొక్క తెలంగాణ స్టేట్ మీద ఉన్న ప్రేమని, అశోక్ రెడ్డి గారి మీద ఉన్న అభిమానాన్ని తెలియజేస్తుంది సార్. మేమందరం ఆతృతగా మీ యొక్క అడ్రస్ కోసం ఎదురు చూస్తున్నాం సార్. నౌ ఐ రిక్వెస్ట్ డాక్టర్ గంగాధర్ టు అడ్రస్ ద గ్యాదరింగ్.
all the distinguished guests on the dais, all my dear friends in the audience, and those who are connected from different parts of Andhra Pradesh, Telangana, and other places. I wish you all the best. And I know in 48 hours we will be celebrating the new year of this place. And I wish you all the best and a very, very happy new year before I start my inaugural address. I'm indeed very happy that the Telangana State Psychiatric Association invited me to be in this function. As in the introductory remark, it was said that I could have well joined online, but the love for all of you attracted me to come over here on this Sunday and travel all the way to be with you, and I thank you once again for inviting me. Coming to this CME, as was said, the variety of topics that are very useful to our practice have been chosen, and whoever formulated the CME deserves to be congratulated. I must also place on record my deepest appreciation that the session started by a chairman who is none other than the professor of medicine. And this is the point I want you all to take the message correctly. Yesterday I was interacting with one of the psychiatric colleagues who brought me from the airport. He was telling me, why can't psychiatry be a subject, and why can't psychiatry be a paper in MBBS course? Why has it been left out? ENT is there, ophthalmology is there, orthopedics is there, pediatrics is there. Why did you leave out this? Now I had to recall the days when I did my MBBS. Those were the days when we began, there wasn't a department of psychiatry at all. Even if it was an assistant surgeon who incidentally also was a psychiatrist, was looking after the psychiatry in courts department. We as students don't recall having been posted there. The first time I got into touch with that is when I was an intern posted there for about 2 weeks in the department of psychiatry. And again, no faculty, it was only an assistant surgeon who was running the department. So I try to recall over time, and I have been seeing how did I learn psychiatry to become a doctor to begin with. I'm sure many of you seniors also will have the same experience. Many things about mental health, I am not saying psychiatry, many things about mental health were taught to us by our medicine professors, our gynecology professors, our teachers in surgery, and our teachers in pediatrics, and so on. I recall when I had to be, as a final year student, was asked to sit with the professor of medicine. He used to ask me to record the BP, do some tests, write down some notes, etc., etc. So I recorded BP in an individual, and the BP I recorded as 140/96. I told him, sir, it is 140/96. You know, there is a white coat effect. People can get very anxious coming into the examination room. You let them relax for some time, they will feel more peaceful. You should read effect of anxiety on cardiovascular system. So this is the first time I got to know that these are the effects that can be possible, and I recorded after about 5 minutes. Yes, the BP was normal. He said, this is very important that you need to give some relaxation effect when you are consulting an individual. I was in a gynecology posting, the obstetrics obstetrics department, OBG posting. there was a lady who was crying, and the gynecology professor told me that postpartum people are all very depressed. When you are talking to them, they're not depressed because they did not get the child of the sex that they wanted. That is not the reason. Irrespective of that, also postpartum women can be depressed. Yes, as a fourth or final year student, I did not know this. Although we would have read this postpartum depression occasionally mentioned in one corner of the textbook, but this lady taught me that all postpartum individuals, you should look whether they are depressed. And if they are depressed, you should listen to them, reassure them, and don't think that they are depressed because they did not get the child of the sex that they wanted. They are genuinely depressed, and it is a biological reason why they get depressed. The pediatrics professor taught me, whenever you are seeing a kid with many injuries, consider first ADHD, hypokinetic disorder. So I do recall that the influence that made on me about mental health, about learning psychiatry, was because some of the primary subjects that we have to answer in the examination, those teachers who, as an MBBS student, would be seen as the most influential teachers. Do understand, an ophthalmology professor or ENT professor did not influence us. We were influenced by those professors who had a longer contact with us, those departments who had a longer contact, those departments which used to have a 100-paper question, those departments which gave us a long case and a short case, those departments where the marks mattered when we went into the PG. PG did not have a common entrance exam those days. The marks we got in medicine, surgery, gynecology, and pediatrics mattered. So perhaps to an extent that influence still remains today. The medical students are largely influenced by these primary subjects. And how many psychiatry professors will be there in a medical college? If there is no PG in a medical college, please understand there is only one professor or one faculty in the Department of Psychiatry. Whereas put together these four departments, there would be easily about 50 faculty. A batch of about 150 or 200 students. Imagine psychiatry being taught by one professor. Vis-a-vis psychiatry is being at least alluded to or related to or introduced to in one or other way by 50 influential teachers. It can make a difference. And as the chairperson, Dr. Gandaya, was saying in the morning, majority of the psychiatry presentation in a general hospital would occur in these departments and not necessarily in the psychiatry department. And if you miss psychiatric presentations in these departments, you would have missed a lot of learning in psychiatry. So it is in our interest, yes, I agree that we may have a department of psychiatry, we may have a paper in psychiatry, but we must appeal to all our professional colleagues in these major departments to also be teaching some elements of psychiatry. In fact, those elements of psychiatry account for as much as 80% of the morbidity in psychiatric clinics as well. Because if you talk of severe mental disorders, they account for maybe about 10% of our psychiatric presentations. 60 to 80% of the presentations which will be largely non-severe mental disorders. That's why we call them common mental disorders. So these common mental disorders have variety of presentations, and general hospitals in particular, they present in these major departments, and it's a very important that professors of Dr. Gandaya and many other departments like surgery, OBG, pediatrics, they talk about mental health presentations to PG or UG students, which will prompt us to be actually attentive to mental health presentations. And of course, like Dr. Praveen mentioned, there has to be some introductory classes for psychiatry in medical course to preempt them to choose psychiatry. But it is very important to prepare all general practitioners, all MBBS level people into learning some useful tips of mental health practice. In fact, it is they who are going to be the frontline warriors in mental health, and they're going to be seeing a lot of presentations in their general practice and other specialty departments as well, and they would probably treat them and probably get them better there itself, and at least identify them and refer them to appropriate place, the Department of Psychiatry. So if this can happen, and if this message has been rightly pointed out in this CME, I must congratulate whoever thought of this, requesting a senior professor from medicine to chair the first session to set the ball in the right motion, and also a talk on how psychiatry should be appealing to medical students. Both these topics were extremely appropriately chosen, and I congratulate them once again. And in this context, there are many things that are happening. Psychiatry departments have not just one person. Most people are already starting psychiatry PG courses in their medical colleges. Psychiatry has been a sought after department, sought after profession in many medical colleges. In fact, some of the very good students chose psychiatry. I do recall, I can mention two names. One of them is Dr. Macheri Keshavan, who got a gold medal in medicine during his MBBS days. And those days we did not have an entrance exam. With gold medal in medicine in MBBS days, he could have chosen any specialty that he wanted, that he came from the Mysore Medical College. Any specialty he could have chosen, but he chose psychiatry. I know of one more person who recently got the SS Bhatnagar Award from NIMHANS, Dr. Venkat Subramaniam. He was also a gold medalist in several subjects, and he could well have chosen any other branch of medicine, but he chose psychiatry. These are two examples. I'm sure you, as other colleagues, would have seen many other your contemporaries, your colleagues, your students, who were very bright, have been choosing psychiatry. And if it can happen 20 years ago, and it could happen well now, and I'm sure you will attract more and more. What probably can attract medical students into psychiatry? One, of course, the influential teachers in the primary subjects talking about mental health, talking about psychiatry, and the departments of psychiatry showing a great academic role, modeling to the students that psychiatry can be an interesting science subject, which somehow gets missed out. Very often, psychiatrists, by virtue of the stigma it is attached, may already harbor some form of lowered self-esteem, and it could show in their poor performance in some departments, if not in all. But I'm sure many departments are doing extraordinarily good academic activity, training and interactions, and demonstrating clinical case material in a general case conferences of medical colleges, and they are the ones who will attract the psychiatry, the good students to do psychiatry. And in the days to come, I'm sure psychiatry will be the most sought after subject in our medical practice, and CMEs like this, which will showcase the need for having the liaison, a need for bringing primary medical specialty teachers into the fold of mental health teaching, can make this change even faster. Once again, congratulations to everyone, and I thank all of you, the Telangana Psychiatric Society, Telangana chapter of the Psychiatric Society, for having called me to this function. Once again, wish you all the best, and a very, very happy Ugadi in the days to come. Thank you so much.
Thank you, Dr. Gangadhar sir, for your address and telling us the various things that which we can follow. Now, coming to the presentation of mementos, I request the organizers to proceed, please.
I would just like to inform, in continuation with the theme, we have started what is called interdepartmental seminars in SVS Medical College. One seminar every month. psychiatry with medicine, psychiatry with surgery, psychiatry with orthopedics, psychiatry with pediatrics. We have already completed 5 seminars in this year. Every month, one seminar we are organized so that we sensitize all branches, work together, and give a comprehensive care to the patients.
Okay. I now request Dr. Jagannath sir to present a memento to the chief guest, Dr. B.N. Gangadhar sir. Thank you, sir. Now I request our chief guest, Dr. Gangadhar sir, to present mementos. First of all, to present memento to our president of IPSTSB, Dr. Jagannath sir. Thank you, sir. Now I request sir to present memento to Vice President IPSTSB, Dr. M. Rama Subbareddy sir. Thank you, sir. Now I request sir to present memento to organizing chairperson of CME program, Dr. K. Ashok Reddy sir. Thank you, sir. I request sir to present memento to our guest of honor for the day, Dr. K.P. Joshi sir. Thank you, sir. I now request sir to present memento to Honorary General Secretary of IPSTSB, Dr. Minhaj Zafar Nasirabadi sir. Thank you, sir. Sir, may I now request sir to present memento to Organizing Secretary of the CME program, Dr. Vijay Raj Pratik sir. Thank you, sir. Now I request sir to present a memento to a Chairman of Scientific Committee, Dr. R.S. Swarupachari sir. Now I request sir to present a memento to the Treasurer IPSTSB, Dr. Vishal Akula sir. May I now request sir to present a memento to the Editor IPSTSB, Dr. Sai Krishna Puli sir. Thank you, sir. Now I would like to hand over the mic to our President.
Now coming to the last part of the program, I request Dr. Vijay Raj Pratik, Organizing Secretary of the CME, to propose vote of thanks.
Good morning, everyone. A very good morning to Dr. Gangadhar sir and all the dignitaries on the dais and off the dais. I welcome all the delegates, speakers, chairpersons, and students also. It gives me immense pleasure to propose the vote of thanks for the inaugural event of 6th Annual CME program of IPS Telangana State Branch. Firstly, I would like to sincerely thank Indian Psychiatry Society Telangana Branch, Executive Council, and especially President Dr. G. Jagannath Garu for giving us this opportunity and permission to conduct the 6th Annual CME program at SVS Medical College, Mahbub Nagar. I would like to extend my thanks to other members of IPS Telangana State Branch, Vice President and President-elect Dr. M. Ram Subbareddy Garu, Honorable General Secretary Dr. Minhaj Garu, and Honorable Editor Dr. Sai Krishna Garu, and Honorable Treasurer Dr. Vishal Akula Garu for giving us this opportunity. Then I would also like to extend my sincere thanks to the management and administration of SVS Medical College, Mahbub Nagar, for giving us the permission, and we are very grateful to the college for providing us all the support and for the lecture halls, accommodation, hospitality, etc., and making our job easier. I would also like to thank Dr. K.J. Reddy Garu, Managing Director of SVS Medical College, Mahbub Nagar, for giving us the welcome message and which is encouraging to us to conduct more CMEs and more programs. Now I would sincerely thank the chief guest Padma Shri Dr. B.N. Gangadhar Garu, who is the President of Ethics and Medical Registration Board, National Medical Commission, New Delhi, for coming all the way here to Mahbub Nagar and gracing this occasion and also agreeing to chair the session for this CME program. I would thank him personally for showing his love and respect towards psychiatry and the our Psychiatry Telangana State Branch. I would also like to extend my thanks to our chief guest of honor, Dr. KP Joshi garu, who is Vice Principal of SVS Medical College, Mahbub Nagar, who is very active and dynamic person for giving us this opportunity and coordinating the activities between students, especially the PG students, UG students and the nursing staff and other persons also, and providing us all the inputs and on what to do regarding the hospitality and accommodation procedures. I would like to thank him very much for this support. I would also like to thank our esteemed speakers, Dr. Praveen Chintapanti garu, for introducing us to psychiatry, then the Dr. Chitranjan Andrade, Dr. Suresh Badamat sir, and Dr. Ashok Linchandani sir, Dr. Chaitanya Lakshmi garu, Dr. Anita garu, Dr. Anand sir, Dr. Rishikesh garu, and Dr. Jagdish Babu garu, and Mrs. Padmaja for agreeing to speak on the topics on the theme of mental health, a knowledge update to everyone involving in mental health care. Also, I would like to thank chairpersons Dr. Gandaya sir, Dr. Kishan sir, Dr. Chandrasekhar sir, Dr. D. Keshwara garu, Dr. Sudharani ma'am, Mrs. Sunita garu, and Dr. Suren sir for agreeing at such a short notice to be a chairperson and grace this event. At last, I would extend my sincere thanks, and I am immensely grateful for giving me the opportunity in organizing and conducting the CME program, especially the organizing chairperson, Dr. K. Ashok Reddy sir, and thinking about the theme and making all these scientific sessions and other things easier. The theme involving the knowledge update to every partner in mental health care. I like to thank him very much. This is the first time I'm organizing a CME, part of organizing a CME because of him. It would not have been possible in these difficult times, especially the COVID times, without him. Yeah. I would also like to thank the chairperson, Chairman Scientific Committee, Dr. R.S. Swarupachari sir, who is a professor of Psychiatry Department, for his valuable inputs and spending the time with us for conducting this event. I would also like to extend my thanks to all the delegates and postgraduates and other students and other doctors for attending these sessions. I would extend the thanks to the technical team from Anil Martin and his team for providing our, all the audiovisual stuff, the online arrangements and the offline arrangements. Thank you, and I would extend the thanks to the pharmaceutical committees for providing logistic support and hospitality support, especially Sun Pharma, Intas Pharma, Crescent Pharma, so PJ Pharma and Oxygen Pharma for their support. At last, I would conclude this thanking session for thanking all the postgraduates of our department, all our staff who have been supporting this occasion, conducting this occasion and the CME program. Thank you. Thank you very much.
Now coming to the last point, I request everyone to raise for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उत्सल जलधि तरंगा, तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाहे तब जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे.
Now I declare the inaugural function closed, and back to the organizing committee, please. We will shortly start the CME program.
Let us now take a short break for high tea. We'll be back in 10 to 15 minutes for the upcoming sessions.
High tea is served in the dining hall 1, just beside this. We'll just go there and we'll come back quickly. We are late by few minutes. We'll make up during the IT. And this IT is sponsored by PJ Pharmaceuticals. We are thankful to them. Hello. He's online, is it? He's on. Sir, good morning, Dr. Chitranjan Rade, sir. You are able to hear me, sir? Hello.
Hello, Ashok.
Sir, good morning. We have just concluded the organizing inaugural function. We are a bit late. We'll be joining in 10 minutes back, sir.
Actually, I was online for the last half an hour to 40 minutes when Dr. Gangadhar was speaking.
Sir, I could not hear properly. Please repeat, sir.
I was online for the last 30 to 45 minutes when Dr. Gangadhar was speaking.
Sir.
Can you hear me now?
I'm hearing, sir. I'm hearing, sir.
Am I loud enough for the talk?
It will be 45 minutes time, sir.
No. Am I loud enough? Am I sufficiently audible?
You are audible, sir. You are clearly audible now.
Okay. Because yes, you could not hear earlier.
Yes, sir. You are audible, sir.
Okay.
We'll start in 10 minutes time.
I will wait. I will wait over here.
Yes, sir.
Sir, can you start your video and share your screen, sir?
Yeah. We'll start the video.
Yeah.
Can you see me?
Yes, sir. Very much, sir.
Can you see my screen now?
Wonderful, sir. Done, sir.
You can see the screen, full screen?
Yes, sir. Very much, sir.
Okay, excellent. You can see me and the screen and you can hear my voice.
Yes, sir.
Okay, so we are all set to go. Let me know whenever you are ready.
Done, sir. Another 5 minutes we'll be starting it, sir.
Sure.
Yeah, good day, sir.
Thank you.
Hello. Okay, Good morning, everyone. Let us begin with the next section of the day. The topic that we will be discussing now is transcranial direct current stimulation and its applications in psychiatry. For the next session, I would like to invite Dr. K. Chandrasekhar, Director, Asha Hospital, Hyderabad, onto the dais. Dr. K. Chandrasekhar sir has done his MD Psychiatry and DPM. He is founder, director and current managing director of Asha Hospitals, Hyderabad. He is senior consultant psychiatrist and he is academic director and teacher for DNB Psychiatry program at Asha Hospital since 2006. His former president, IPS AP State and IPS South Zone, and he has a clinical experience of more than 40 years, and his areas of interest are geriatric psychiatry, neuropsychiatry and mental health legislation. For this program, I would like to invite the speaker, Dr. Chittaranjan Andrade, MD, Professor of Psychiatry, Nimhans Hospital, Bangalore, who will be present online and he will be sharing a session online. I request our chairman for the session to introduce the topic and to introduce the speaker.
I welcome you all for this session. At the outset, I'm thankful to Dr. Ashok Reddy and the organizing committee for having bestowed on me the privilege of chairing a session in which Professor Andrade is the speaker. Dr. Chittaranjan Andrade is Professor of Psychopharmacology at Nimhans. He has received several international awards and all the major awards of the IPS and IAPP. He has more than 500 publications and nearly 6,000 scientific citations. He is member of editorial board of several internationally acclaimed journals. He is listed in the top 2% of world scientists in psychiatry of from Stanford University, USA in 2020. Apart from the psychiatry, he has got very interesting hobbies of climbing mountains, composes and plays music, and he performs magic too. His areas of interest are psychopharmacology, biological treatments, and research. And today he is going to talk to us on transcranial direct stimulation and its applications in the various psychiatric disorders. As all of us know, in the practice of modern psychiatry, pharmacological management has been the mainstay. However, during the last 10-15 years, there is renewed interest in neuromodulation, and especially with reference to applying magnetic fields and applying small currents so that the therapeutic benefits are achieved. Mostly as of now, these techniques are confined to various academic and research institutes, and there's a lot of skepticism among the clinicians in the applications in their day-to-day practice. It could be RTMS, it could be TDCS. Probably, if you consider neuromodulation, ECT is one of the neuromodulatory techniques, probably that is the only one as of today which stood the test of time. However, these current neuromodulatory techniques, to what extent they are beneficial in the clinical practice and how long their therapeutic benefits are going to sustain in a given patients are very debatable points. I think we are going to have a very interesting talk by Dr. Chittaranjan Andrade on these issues, and probably he will clarify most of these issues to all of us. Now I request Professor Andrade to deliver his lecture. Thank you.
Mute. Yeah. Hello, am I audible?
Yeah, you're audible.
Can you show my slides? I will share my screen. Can you see my screen?
Yes.
Am I ready to go?
Sure, please.
In case at any point in time you cannot hear what I am saying, please let me know. Sure. Or if there's any problem with the slides, please let me know.
Sure.
Good morning, everybody. My presentation is on a brain stimulation procedure called transcranial direct current stimulation. TDCS is the poor man's repetitive transcranial magnetic stimulation, the poor man's RTMS. There are a large number of different kinds of brain stimulation therapies in neuropsychiatry, specifically electrical brain stimulation therapies, including ECT, RTMS, vagus nerve stimulation, deep brain stimulation, TDCS, what I will be speaking on, trigeminal nerve stimulation, transcutaneous electric nerve stimulation, Fisher-Wallace brain stimulation, and so on. Some of these are available only in hospitals like ECT and RTMS, for example. And some of these are even marketed over the counter in countries like the USA, like a Fisher-Wallace stimulator. Now, TDCS is something that gained popularity in the last 20 years. It is a brain stimulation technique which involves the passage of a very, very small electrical current. It's just 1 to 3 milliamperes. And this current is passed through electrodes, at least one of which is placed upon the head. The other electrode may be placed upon the head or on another part of the body, such as the shoulder. Now, the current in TDCS is direct current. Electrons flow from cathode to anode. It is not alternating current, as for example with sine wave ECT or with bipolar brief pulse ECT. In TDCS also, the current is passed continuously. There is no interruption in the flow of electrons. Current does not flow in pulses as it does with brief pulse ECT. With TDCS, the patient is completely conscious during the entire procedure. The patient does not feel anything. The patient can talk normally. The patient can perform usual activities. The patient, for all practical purposes, is completely conscious. Now, the history of TDCS actually dates back for centuries. Mild currents have been described being applied to the head of patients with mental illness for almost the last 200 years. However, brain polarization therapy, which is what TDCS was formerly known as, research on this subject dates back to roughly the 1960s. And as far back as in even the 1970s, brain polarization treatment devices were available in India. These had no stimulus settings, no readouts, no safeguards, and they had extra leads also, and practitioners didn't really know what electrode goes where and why. If I'm not mistaken, such devices are still available in India. There's a spurt in research in TDCS during the last 20 years. And now over 10,000 patients, including normal subjects, have been the subject of TDCS studies. The results have been published in thousands of papers. In a PubMed search, which I conducted earlier this month, there were more than 6,500 hits for the subject of TDCS. However, TDCS has not been approved in any country for any indication. The reason being, it is a treatment which cannot be patented. So you're not going to see regulatory standard RCTs of TDCS being conducted. TDCS is therefore an experimental tool for the treatment of neuropsychiatric disorders, predominantly refractory auditory hallucination in schizophrenia, but for a lot of other conditions also, which I will be speaking of. TDCS is also used as a technique for the study of brain functioning. Now, here are a few technical notes for you to understand what TDCS is. This is an example of what a TDCS device may look like. You have a switch which turns the device on and off. You have a little knob which sets the duration for which the current is passed, maybe 1 minute, maybe 10 minutes, maybe 20 minutes. You can even set it for 30 minutes on many devices. The current does not go up to what is set immediately. The current goes up gradually. There's a reason for ramping up the current rather than straight away starting at the current which is set. The reason for ramping up is that if current straight away goes to what is set, the patient experiences a little bit of itching underneath the electrode site, and this is uncomfortable to the patient. It is also responsible for a loss of blinding in RCTs. Therefore, for both true and sham TDCS, ramping up is done, the patient experiences maybe a little bit of itching and so on, blinding is effective. The current strength can be set at anywhere between 1 and 10 milliamperes, though usually it is around 2 milliamperes, rarely more than 3 milliamperes. The usual current strength is around 2 milliamperes and it shows on the display. And voltage, this is an unnecessary setting. These are unnecessary. They are basically for information. And you can also see sockets over here for the electrode leads. Now the electrodes are called anode and cathode. The anode is the positively charged electrode, and if you test it on a multimeter, it shows a positive deflection. The anode stimulates the underlying cortex. This is important for you to understand. So if the anode is placed on a site on the skull, when the TDCS instrument is switched on, the anode leads to an increase in the resting membrane potential of the cell underlying the anode. In other words, the interior of those neurons, the interior of the cortical neurons underlying the anode becomes less negative. You must know that the resting membrane potential is negative because the interior of the cell contains more negatively charged ions. So anodal stimulation leads to a reduction in the negativity inside the cell, which makes depolarization more easy. Depolarization occurs when positively charged ions rush from outside the neuron through the membrane into the neuron, and an action potential is generated. So effectively what anodal stimulation does is anodal stimulation facilitates the occurrence of action potential by making depolarization more easy. The cathode in TDCS is the negatively charged electrode. The cathode inhibits the underlying cortex by reducing the resting membrane potential, making the interior of the neuron more negative. In other words, cathodal stimulation causes sustained hyperpolarization, making it more difficult for depolarization to occur, making it more difficult for action potential to be generated. I'll skip this. Now, note that in TDCS, both electrodes are active. Sometimes one electrode is called the stimulating electrode and the other is called the reference or neutral electrode. This is because we want anodal or cathodal stimulation of a particular part of the brain, and therefore whether it's anode or cathode, whatever that electrode is that's doing the job that we want it to do, that electrode is called the stimulus electrode. The other electrode is kept at a place where it doesn't do where it doesn't interfere. For example, it may be kept over the right orbit. It may be kept over the orbit where the frontal bone is so thick that current does not penetrate. Or it can be kept over the shoulder. Sometimes the reference of neutral electrode is kept on the contralateral shoulder. Keep in mind that when electrodes for TDCS are kept close together, current is very often shunted not through the brain, but in subcutaneous tissues in the scalp. Similarly, if the reference electrode or the neutral electrode is kept on the shoulder, this current shunting can be increased with less current actually penetrating the skull and stimulating the brain. Now, common treatment parameters of TDCS are very reassuring. Usually, the current that is passed is 1 to 3 milliamperes in amplitude. 1 to 3 milliamperes is such a tiny current that if it passes through your finger or your head or any part of the body, you don't even know that it is passing. This current is continuously passed for roughly 20 to 30 minutes. It is direct current. It passes in only one direction. It's not alternating current where the direction of current changes at a high frequency. Many TDCS devices have a cutoff of 3 milliamperes, sometimes 10 milliamperes, to prevent too high a current being accidentally passed. TDCS sessions are conducted usually twice a day, 5 hours apart, but sometimes once a day on consecutive days. Usually TDCS sessions are conducted on 5 consecutive days in a week for 1 to 2 weeks, but sometimes for up to 1 month or even longer than 1 month. The power source for TDCS is a 9-volt dry or alkaline battery, such as the battery which you use in cordless telephones. There is no connection to the electrical mains, which is a huge source of reassurance to patients and to ethics committees. When patients see, or the ethics committee see a small battery powering a small TDCS device, they feel reassured. If they see a device like an ECT machine which draws electricity from the electrical mains, they feel afraid. So TDCS device using a small battery is reassuring to patients and to ethics committees. Now, what TDCS does is, it's, as I told you, causes either sustained hyperpolarization or sustained reduction in negativity of the resting membrane potential inside the neuron. No action potentials are generated. So what effectively TDCS does is produce tonic facilitation of depolarization or tonic hyperpolarization. This is why it used to be called brain polarization therapy half a century ago. But this sustained facilitation of depolarization or this sustained hyperpolarization results in stimulation or facilitation of stimulation or inhibition of the underlying cortex, causing neuroplasticity changes. Basically, TDCS modulates neural network activity under the stimulus electrodes, causing neuroplasticity changes in the brain. Note that TDCS does not cause excitotoxicity because it does not cause neuronal firing. It only facilitates or inhibits physiological activity of the underlying neurons. There is no local heating effect under the electrodes, and there are no indices of tissue or neuronal damage associated with the use of TDCS. What are the clinical applications of TDCS? So far, I've told you about technical aspects of TDCS. What are the clinical applications? The most important clinical application of TDCS is to treat refractory auditory hallucinations in patients with schizophrenia, and possibility to treat negative symptoms in schizophrenia, possibility to treat depression. There are a lot of other indications also for which TDCS has been trialed, including, for example, attention deficit hyperactivity disorder, stroke. There are more than 50 RCTs of TDCS in patients with stroke. TDS has also been studied in chronic pain syndromes, neuralgia, fibromyalgia, epilepsy, tinnitus, migraine, Parkinson's disease, and even in elderly persons with age-associated cognitive decline in an effort to improve cognition. To my mind, there is only one indication for TDCS in psychiatry or in neuropsychiatry, and that is to treat refractory auditory hallucinations in schizophrenia. For all the remaining indications, the benefits of TDCS are plus or minus. If they are plus, weakly plus. Now, I was probably the first person in the world to treat a patient with TDCS for refractory auditory hallucinations in schizophrenia. I started treating a patient in 2010, and the first case report actually for TDCS in refractory auditory hallucinations was published in American Journal of Psychiatry 2011. So if I had published as soon as I completed treating my patient and the patient responded, I would have been the first person in the world on record. Unfortunately, I delayed it. I'll come back to that a little later. So this paper, by the way, is available online, free, both full text and PDF for download. When treating refractory auditory hallucinations in schizophrenia, the cathode is the important electrode. Basically, we want to inhibit internal speech, which the patient perceives as auditory hallucination. The internal speech is generated from the speech areas. So cathodal stimulation over Wernicke's area, that is midway between T3 and P3 in the 1020 EEG system. Cathodal stimulation of the left temporoparietal cortex leads to inhibition of the Wernicke's area, leads to an inhibition in the perception of internal speech, leads to an inhibition in the experience of auditory hallucination. How did I get this idea? Previous research had found that low frequency RTMS, which is inhibitory, reduces auditory hallucinations when applied over Wernicke's area. So I had a patient who had been successfully treated with RTMS for refractory auditory hallucinations, and then RTMS was no longer available because of device malfunction, and the patient's hallucinations returned. So I knew that cathodal stimulation inhibits the underlying cortex. So I hypothesized that cathodal stimulation with TDCS over Wernicke's area would do exactly what RTMS does. And it worked in my patient. And so that was the first case of TDCS being applied for for refractory auditory hallucinations in world literature. Now, anodal stimulation stimulates the underlying cortex. So in schizophrenia patients, we can apply the anode over the left dorsolateral prefrontal cortex. That's between F3 and FP1. The purpose is to activate the left dorsolateral prefrontal cortex, leading to an improvement in executive functions. The executive cognitive functions depend upon the prefrontal cortex, particularly the left prefrontal cortex. So anodal stimulation could perhaps reduce negative symptoms and improve cognition in patients with schizophrenia. How did I get this idea? Because meta-analysis has shown that high frequency RTMS improves negative symptoms in schizophrenia. Now, for those of you who are not familiar with the 10-20 system, 10-20 stands for 10% and 20%. This is the nasion and this is the enion. And the distance between the nasion and the ilion going in the sagittal plane over the scalp is measured in units of 10% and 20%. So you get, for example, FP1, FZ, CZ, PZ. That's in the center. That's in the midline, right? And you have, the left side is represented by odd numbers, like 1, 3, 7, and so on. The right side is represented by even numbers, 2, 4, 8, and so on. So FP stands for frontoparietal, F is frontal, C is central, P is parietal, O is occipital. So this is the ear. The reference electrodes sometimes are connected to the ear. A1 is left side and A2 is the right side. So if you want to apply the cathode between F3 and P3, or between T3 and P3 for refractory auditory hallucinations, this is where the cathode should be located, over the ear and slightly behind the ear on the left-hand side. So if you're treating refractory auditory hallucinations in schizophrenia, the cathode should be between T3 and P3, that is above the left ear, maybe 5 centimeters above the left ear, and maybe a few centimeters to the right, between T3 and P3. The anode would be placed usually in the region of F3, that is somewhere in this region, or again on the left side. Please note that when you're keeping electrodes both on the left side, there's a lot of current which passes between the electrodes through subcutaneous tissue directly like this. So you must be careful when using saline-soaked electrodes that there is no saline bridge that forms between the electrodes. That is, saline does not link the anode which is placed here and the cathode which is placed here. If there's a saline bridge which is formed, all the current will quickly flow through the saline bridge and nothing will go inside the scalp. So this is the same 10-20 system with the electrodes marked for the left and the right side. So as I told you, the first case report was published in the American Journal of Psychiatry 2011. Subsequently, a randomized controlled trial was published in the American Journal of Psychiatry 2012, showing that TDCS produces significant reduction in auditory hallucinations. 40% of patients treated with TDCS showed a response, defined as at least 50% reduction in hallucination ratings. Negative symptoms also improved, but negative symptoms improved by only 12%. So you can see basically TDCS produces substantial improvement in auditory hallucinations, but only a very small improvement in negative symptoms. So this is the patient whom I was treating from 2010 onwards. By 2013, I had treated this patient for 3 years continuously with 1 to 2 sessions per day on a domiciliary basis. The patient's brother was a dentist. I trained him in the administration of TDCS. So he and his father together administered TDCS to the girl who was around 18 years to 20 years old at that time. And she was refractory to clozapine, to all antipsychotics, refractory even to clozapine. She had continuous auditory hallucinations in schizophrenia. They were disabling. She was not able to do any work. She was not even able to talk normally because of the continuous auditory hallucinations. TDCS worked in her like magic. She got her life back with TDCS. The paper was published in Journal of ECT. She continued treatment for more than 6 years, after which the hallucinations for all practical purposes stopped. I'm still following her up now. She does not need TDCS. After 6 years of treatment with TDCS, she has her hallucinations have about 90% remitted. Now, there are meta-analyses that have been published on the efficacy of TDCS for refractory auditory hallucinations. 16 RCTs have been published. TDCS is superior to sham TDS, but the effect size is only in the region of 1/3 of a standard deviation, which means that on average, TDCS produces only a small improvement in patients. It doesn't work in everybody, and in those patients in whom it works, it produces a small improvement. However, even a small improvement is better than no improvement at all, particularly for refractory auditory hallucinations. Patients who do not respond to antipsychotics, do not respond to clozapine, and for whom RTMS is either inaccessible or unaffordable. In our studies, we have also found TDCS effective in alcoholic hallucinosis. These are papers where I was a co-author and a paper published from NIMHANS. Another important indication for TDCS is in the treatment of depression. The anode is usually placed over the left dorsolateral prefrontal cortex because in depression, we want to activate the patient, and the left dorsal prefrontal cortex is responsible for negative symptoms, responsible for impaired cognition. So by stimulating the left dorsolateral prefrontal cortex, hopefully we are improving depression. Where should the cathode be placed? Perhaps inhibiting the right dorsolateral prefrontal cortex can help, because the right dorsolateral prefrontal cortex sends inhibitory connections to the left side. So if we inhibit the right side, it may further improve left side functioning, or the cathode, which is inhibitory, can be placed over the right orbit where it does not interfere with anything. Now, there was an early positive study published about 15 years ago in 10 patients with major depressive disorder. True stimulation was superior to sham stimulation. However, afterwards, a meta-analysis of 27 RCTs found that even though TDCS was superior to sham TDCS, the effect size was small. An effect size of 0.3 to 0.5 is considered to be small. And TDCS patients did not have higher response and remission rates than sham TDCS patients. What this means is that you might have a statistically significant reduction in depression ratings, but it is not clinically significant if response and remission are not improved. This is from a meta-analysis which was published a few months ago. Adverse outcomes, TDCS does not cause hypomania, although occasional cases have been reported. By and large, in the RCTs, hypomania has not been reported. TDCS is very well tolerated. Treatment dropout is no different between TDCS and sham TDCS groups. So what is my take on TDCS for depression? I would not recommend the use of TDCS for depression unless, for example, there is no other treatment that is possible. For example, the patient is a woman who is pregnant. You don't want to give her antidepressant drugs. For whatever reason, ECT is not possible. Or maybe the patient is very old and antidepressant drugs are causing problems. So please excuse me. So maybe antidepressants are causing problems. Maybe there is medication intolerance. Perhaps in these patients, TDCS may be considered, but not in other patients. It is possible that higher currents, it is possible that smaller or more focused electrodes, it is possible that twice daily sessions, treatment for continuous treatment for a month, these may be helpful, but this is difficult to do in clinical practice because it's hard to get a patient coming, for example, every day for a month and staying in the hospital for the whole day to receive 2 TDCS sessions 5 hours apart. So probably TDCS does not have much of a role in treating patients with depression. Another huge indication for TDCS has been for the treatment of stroke. By the way, my experience also has been poor in treating depressed patients with TDCS. What about stroke? There's a large volume of literature, maybe something like 50 randomized controlled studies which have been conducted, and another 1 or 2 dozen studies which are currently ongoing across the world. Most of these studies were conducted in patients with chronic stroke. Most of the studies addressed motor weakness, especially upper limb weakness. Some studies looked to see whether cathodal stimulation reduces plasticity. Some studies looked to see whether TDCS reduces dysphagia, whether TDCS improves aphasia, and very few studies examine cognition. Now in stroke, particularly if we are giving TDCS for motor stroke to improve motor functioning, the anode should be placed over the ipsilesional cortex, that is over the motor area on the side which has been affected by stroke. For example, if M is the motor area, if the patient has had a left-sided stroke, you place the anode over M1. If the patient has had a right-sided stroke, you place the anode over M2. The cathode is placed on the motor cortex on the opposite side, that is over the contralesional cortex. This is because, as I told you before, the opposite hemisphere sends inhibitory fibers to the ipsilateral hemisphere. However, if we are treating spasticity, the cathode should be placed over the motor area of the affected side to inhibit the motor area and to reduce spasticity. So TDCS general results have been TDCS produces an improvement in power, which is good. TDCS reduces spasticity, which is good. TDCS improves dysphagia, aphasia, which is good. It improves cognition, it improves activities of daily living. What is not clear is whether statistically significant findings in a group observed from an RCT are sufficiently large to be discerned in an individual patient. So what this means is that if there's 5% improvement in, let's say, motor power in every patient, that 5% improvement will not be perceived by the patient. But if you do statistical analysis in an RCT with, say, 50 patients receiving true and 50 patients receiving sham, those 50% patients, each with 5% improvement, would give the study sufficient power to show that TDCS is superior to sham TDCS. So this is another way of saying the effect size is sufficiently large to be detected as a statistically significant finding in a clinical trial, but it is not large enough for a patient to detect it as improvement. So do I recommend TDCS for patients with stroke? We have just finished a large RCT with 60 patients in stroke, and we found that TDCS delivered twice a day for 2 weeks was not effective. However, meta-analysis suggests efficacy, and my personal belief is that TDCS is not going to help. But if there's a patient with stroke and the patient is desperate, then there's no harm in trying TDCS twice a day, 5 hours apart for 2 weeks, 5 sessions a week for 2 weeks. There's no harm in trying. If there is benefit, TDCS can even be given for 1 month. So there's a meta-analysis which has shown a small effect size for improvement in upper limb motor functioning. TDCS versus baseline, small improvement. TDCS versus sham TDCS, small improvement. In a more recent meta-analysis in 2016, 32 randomized controlled trials, the effect size was even smaller, and the effect size confidence interval was very close to 0 at the end of follow-up. Activities of daily living outcomes no longer significant when only RCTs with good methodology were meta-analyzed. Again, discouraging results. So I'll skip this. Some studies have shown that TDCS produces an improvement in dysphagia. Some studies have shown that TDCS produces a reduction in aphasia as well. Some studies, including in a meta-analysis, have shown that there is modest improvement in spinal cord injury medication refractory pain. Meta-analysis shows, however, that the benefits are lost at follow-up and that there are no psychosocial benefits. The most recent meta-analyses have found negative results for TDCS for neuropathic pain. Some studies may show that cathodal stimulation over the ipsilateral cortex can improve focal epilepsy outcomes. But in patients with primary generalized seizures, TDCS is not helpful. TDCS has been found in a meta-analysis to reduce only distress associated with tinnitus. TDCS does not improve the loudness of tinnitus. The inconsistent results are probably related to the site of stimulation. It would make more sense for cathodal stimulation over speech and auditory cortex than for anodal stimulation over the left dorsolateral prefrontal cortex to improve mood. TDCS has been shown to improve cognition in the elderly. For example, in a meta-analysis with 25 RCTs, the effect size was medium. That is, TDCS improved cognition by about half a standard deviation. The benefits were observed across a wide range of cognitive tasks despite different electrode locations. Now, the problem is that all these studies were laboratory studies. That is, studies that were conducted using, for example, pen and paper tests or using computerized cognitive tests. We do not know whether there is actually improvement in cognition in everyday life. Also, we do not know whether there is a persistence of benefit. In studies that were conducted in patients with age-related cognitive decline, a meta-analysis conducted a few months ago found that there is no consistent benefit. There is a very wide confidence interval, and the net result is no significant advantage for TDCS in patients with age-associated cognitive decline. TDCS has been studied for childhood and adult ADHD. Temporary benefits are observed with cathodal stimulation over the left dorsolateral prefrontal cortex. Very small benefit, and the benefits do not persist. TDCS has been shown to improve working memory, but not other measures of cognition in healthy subjects. But again, the benefits do not persist. TDCS has been tried in patients with chronic pain syndromes like, say, fibromyalgia, and I mentioned earlier, patients with painful diabetic peripheral neuropathy, spinal cord injury pain, and so on. The benefits are temporary. While the TDCS course is being administered, the benefits do not persist. TDCS has also been studied in patients with migraine, not much benefit. What are the side effects of TDCS? Almost all patients experience some degree of tingling or itching or burning under the electrode. This occurs while the current is being ramped up. If this occurs during a session, it means that the saline underneath the electrode site is drying up And so saline should be re-injected over the electrode to make sure that the electrode skin interface is good. Otherwise, for all practical purposes, there are no adverse effects with TDCS. Patients don't drop out of TDCS treatment unless they find it inconvenient to come for 5 days a week and spend the whole day for 2 sessions a day, 5 hours apart, spend the whole day in the hospital. Some patients experience nausea if the reference electrode is kept near the ear. This is due to vestibular activation. This is why the reference electrode, unlike, for example, with the EEG, where, for example, we may clip the ear, in TDCS, the reference electrode or the electrode which is not important to us is not kept near the ear. It is kept over the prefrontal. It's kept over the frontal bone above the orbit, or it is kept over the shoulder. TDCS is otherwise almost completely free of adverse effects. TDS has been found to be safe in children and adolescents. I will stop at this point because I've been speaking for about 45 minutes and we are behind time already, and there would be need for question and answers. I have a lot of other slides, but these are technical notes which are used for teaching persons how to administer TDCS in their own setups. These are practical notes about electrode positioning, electrode size, electrode materials, use of saline, warnings about saline bridge, and so on and so forth. So since this is a sensitization program, I will not go on to speak about the practical matters. Thank you.
Thank you, Dr. Andrade, for a very precise and crisp presentation. I'm sure everyone enjoyed the talk. Now the session is open for questions. People who are online can type their questions. People who are there in person may ask their questions too. Yeah, I'm looking at it. There is one question here. Is there any absolute contraindications for TDCS? From Dr. Sanjay Kumar.
There is no absolute contraindication. However, be aware that if a patient has a metal plate in the skull, for example, after a craniotomy, the stimulating electrode should be kept far away from the metal plate. Otherwise, the metal plate will act as a conductor. Now, this means that in some patients, if you want to stimulate the cortex and the cortex is lying underneath the metal plate, you can't use TDCS. It's important to know this because the metal plate can act as a conductor to the extent that the underlying cortex receives a far higher stimulation than is usual when TDCS is placed over bone.
Yeah. Good morning, sir. Do psychiatrists require any formal training to do TDCS in their hospital setups?
TDCS is very simple to learn. You don't need accreditation. You take ECT, for example. ECT is more difficult to learn as far as pre-ECT workup, anesthesia protocols, knowledge about calculation of stimulus dose, stimulus parameters, knowledge about electrode positioning, knowledge about how to assess the seizure threshold, etc., is concerned. So ECT requires quite a bit of training. In contrast, TDCS is very easy to learn. In a 2-hour workshop, in a simple 2-hour workshop, hands-on training can be provided, which will enable any treating team to use TDCS safely and successively afterwards.
One more question, sir. You had said regarding wrong placement of electrode, which leads to side effects. Suppose if you keep electrodes in a wrong place, are we legally liable after TDCS?
So wrong position actually would mean keeping it in a place where TDCS probably does not have any benefit and may increase adverse effects. If you place the electrode over the ear, for example, over the mastoid, the patient may have nausea. It's not anything terrible. If you place TDCS, if you place the TDCS electrode, if you place a cathode in a patient with schizophrenia over the left dorsolateral prefrontal cortex, cathodal inhibition of the dorsolateral prefrontal cortex will make the patient's cognitive symptoms worse and make the patient's negative symptoms worse. So you see, for TDCS, you can't really do much harm. You can cause a few more adverse effects. You may cause temporary worsening if, because of lack of knowledge, you place the electrode in the wrong place. But you won't cause deterioration or a crisis or a serious adverse event to the extent that the patient will take you to court. So you won't be legally liable. There are no problems. TDCS will not cause any irreversible damage also. So legal liability issues are close to zero.
Any other questions? There is one question from Dr. Gauri Devi. Any trials on persistent delusions in spite of different antipsychotics?
So with the see, wherever TDCS is used, it is used when we know where to place the anode and where to place the cathode. For example, we know that the left dorsolateral prefrontal cortex is important for executive functions. And so we want to stimulate it using the anode in patients with schizophrenia to reduce negative symptoms, to improve cognition. Similarly, we want to place the cathode over the temporoparietal junction to reduce awareness of internal speech and hence to reduce refractory auditory hallucinations. But if you take delusions, from which part of the brain do delusions arise? Or which part of the brain should we inhibit with the cathode to reduce delusions? Or which part of the brain should we stimulate with the anode to reduce delusions? We don't have an answer to this. So at the moment, if at all you want to try something, you can try cathodal stimulation of the left dorsolateral prefrontal cortex in the expectation that the left dorsolateral prefrontal cortex is responsible for thinking. Thinking is responsible for delusions. So by inhibiting the left dorsolateral prefrontal cortex, we can inhibit delusions. But the problem is we may also worsen cognition and increase negative symptoms. There was one meta-analysis though published earlier this year, which found that TDCS reduced positive symptoms in general in addition to reducing refractory auditory hallucinations. However, that meta-analysis didn't look at delusions specifically. My guess is that TDCS will not benefit patients with delusions.
There's another question. Does ongoing mental activity during stimulation affect the overall response to TDCS?
So, what does a patient do during a 20 or 30-minute session while the current is being passed in TDCS? In most studies, the patient does nothing. The patient simply sits on a chair with the electrodes leading to the TDCS device, which is placed behind the patient so that the patient cannot see whether he is receiving true or sham TDCS. What does the patient do? The patient is doing nothing. So in recent years, TDCS researchers have begun to think that supposing we engage the patient in a task which we want to facilitate by TDCS, then TDCS could perhaps cause neuronal plasticity changes that improve that task. In other words, when the task is being done, the neural circuits for that task are activated, and TDS stimulation at that time can produce neuroplasticity changes that reinforce that neural circuitry activation. This is what is being studied presently. For example, if TDCS is being used to treat stroke, we ask a patient to try and move your fingers or move your hand while the current is being passed for those 20 or 30 minutes. If a patient is being given TDCS to improve cognition or to reduce negative symptoms or to in schizophrenia, we ask a patient to perform cognitive tasks on a computer screen. So yes, to answer your question, current research is examining whether actively engaging the patient with TDCS can improve outcomes while TDCS is being administered.
There are no more questions in the chat box. I think if there are no more questions from the floor, I think I will close this session. Thank you, Dr. Andrade, once more for a very brilliant lecture. Thank you.
Thank you.
Thank you once again, sir. As our speaker for the day, Dr. Chittaranjan Andrade, sir, is not physically present. I request our editor, Dr. Sai Krishna, sir, to please collect memento on his behalf. I request Dr. Chandrasekhar, sir, to please present the memento on behalf of Dr. Chittaranjan Andrade, sir. We will try to mail the memento to him. I request Dr. Praveen Kumar Chintapanti, sir, to present memento to the chairperson of the session, Dr. K. Chandrasekhar, sir. Thank you, sir. Thank you, sir, for chairing the session. Now let us move ahead with the next session for the day, Telepsychiatry, how to go about. The speaker for this session will be Dr. Suresh Badamat, and this session again will be a pre-recorded session that will be displayed. And I would like to invite Dr. B.N. Gangadhar, sir, to serve as the chairperson for the session. Let me give a brief introduction of Padma Shri Dr. B.N. Gangadhar, sir. He has done his MD Psychiatry in 1981 from NIMHANS Hospital and DSc from SYVASA University for research work of yoga and mental health. FAMS Fellow of National Academy of Mental Sciences 2006, Fellow of Academy of Sciences 2019. And he was a former faculty and director of NIMHANS, and he has several indexed national and international scientific publications, around 450 publications, and he is a guide and co-guide to greater than 50 postgraduate and PhD trainees. His research areas are yoga, schizophrenia, public health, and electroconvulsive therapy. He has received C.V. Raman Award from Karnataka government and Padma Shri Award also. He is currently President, Medical Ethics and Registration Board, NMC, Delhi. I request our chairperson to give a brief introduction of the speaker of the day and of the topic.
Let me introduce Dr. Suresh Badamat. He is a very accomplished faculty at NIMHANS, currently the professor of psychiatry. In addition to getting postgraduate degrees in psychiatry, he also has a PhD in law related to the Mental Health Care Act, on which he had researched and had been a resource person to many bodies with respect to formulating the regulations of the National Mental Health Care Act. He is been a visiting faculty at the National Law School, Bangalore, and he has been associated with the what is called as the Karnataka Judicial Academy, which conducts various forensic and psychiatry related courses to the judicial colleagues. He has published extensively over 200 scientific publications in national and international journals. He has received several awards. Notable among them is the Karnataka State Best Teacher Award given by the Karnataka State Psychiatric Society, and he also has received the Karnataka State's Young Scientist Award given as the Sir C.V. Raman Award by the Karnataka government. So I here present Dr. Suresh Badamat, request Dr. Suresh Badamat to give a presentation on the topic of telepsychiatry, and he has been very actively pursuing and heading the section or the department or the unit of telemedicine at NIMHANS, and he has developed it very well, and more recently the numbers of consultations thanks to COVID have tremendously increased on telemedicine, and he also has written the tele guidelines for telepsychiatry, which was presented to the then Medical Council of India. Here I am introducing Dr. Suresh Badamat. Suresh.
Thank you, sir. Thank you, sir. Hello, friends. Today we are going to discuss about telepsychiatry operational guidelines basics. I'm Dr. Suresh Badamat, Professor of Psychiatry, working at NIMHANS, Bangalore. Before I start my presentation, I would like to have a disclaimer. This presentation is for academic and training purpose only. If you want to have a legal opinion, please do contact an advocate. This presentation is not a substitute for legal opinion. At the same time, I request you all to go through the original telemedicine practice guideline released by Ministry of Health and Family Welfare on 25th March 2020. Telepsychiatry Operational Guideline 2020. This was prepared by NIMHANS, Bangalore, in association with Telemedicine Society of India and Indian Psychiatric Society. This guideline is available online free of cost. This guideline has 8 different chapters. First chapter is what was the need and the legality of telepsychiatry operational guidelines. Second one is advertisement and social media. Third one is technology of telepsychiatry. Fourth is the important chapter which we are going to discuss about medical records, especially with regard to telepsychiatry. Fifth one is stepwise operational guidelines for telepsychiatric consultation. That is, before the telepsychiatric consultation, during the consultation, and after the consultation, what the psychiatrist has to do. Along with this, we will be discussing the 6th chapter on teletriage. That is, basically first consult, follow-up consult, telepsychiatric consultation initiated by the family member, the next one will be healthcare workers, and proxy consultation. The 7th chapter is prescribing medication in telepsychiatry. Finally, telepsychotherapy will be discussed. Let's move into the first chapter, the legality of telepsychiatry. What was the need of this telepsychiatry operational guidelines 2020? Please do remember, Telemedicine Practice Guideline 2020 was released on 25th March 2020. Before that, we also had a legislation very specific for practicing psychiatry. So now, this telepsychiatry operational guideline is going to give you a roadmap to practice psychiatry online with regarding to taking into account of Telemedicine Practice Guideline and also at the same time Mental Health Care Act of 2017. And this guideline is not a standalone document. It has to be clearly read with all other documents. This guideline should be used in conjunction with any national standard operating procedures, clinical practice guideline, any other laws, procedures, ethical regulation, and telemedicine practice guideline needs to be followed. You cannot say that I'm just following telemedicine practice guideline. This is an addition to all other laws which are prevailing at this point of time. The psychiatrist shall observe the laws of the country when practicing telepsychiatry. Finally, my dear friends, all the laws which are applicable for in-person consultation in psychiatry is also applicable in telepsychiatry. You cannot just say that I'm following telemedicine and I'll not be able to follow Mental Health Care Act. It is you have to follow all other laws which are applicable in person is also applicable on telemedicine. Let's move into the chapter 2, advertisement, and telepsychiatry. Imagine immediately after COVID, you want to switch over to telepsychiatry consultation. How would you like to tell your clients or the patients that you are going to practice telepsychiatry? In this regard, how do you provide information on telepsychiatry consultation to the clients or else prospective clients or the patients? Please do remember, Indian Medical Council Ethics Regulation 2002, which is also part of National Medical Commission Act 2019. According to that, it clearly says that the code 6.1.1 clearly says that soliciting of patients directly or indirectly by a physician or by a group of physicians or by an institutions or by an organization is unethical. That means you cannot do advertisement. That means you cannot advertise telling that I am doing telepsychiatry practice, please come to me. Means soliciting of patient by any means of advertisement, either on social media, on internet, will be causing grave problem to your practice. But however, the same Indian Medical Council Ethics Guideline 6.1.1 also says that a medical practitioner is, however, permitted to make formal announcement in press regarding starting of a practice, starting of a change of practice, or a change in address, or resumption of another practice. So, if you look at the code 2, 3, and 5, they fall into the category that you are changing the type of practice from in-person to online. So, you can do once advertisement. At the same time, changing address. Of course, you are changing from in-person to online consultation, and online consultation address can be provided. That is basically your login ID and credentials. Resumption of another practice also comes into this phenomena. So you have to be very careful. Only during this change in from one practice to another practice, it is allowed. Otherwise, by any means, soliciting patients through advertisement is not allowed. Here it is allowed for providing information or change of practice, change of address, resumption of another type of practice. So under that pretext, you can provide information, not an advertisement. Advertisement is more of a commercial in nature, soliciting patients, and with a clear mandate to increase the number of patients, which is unethical. Providing information is giving information telling that I'm not doing practice in person, but I have switched over to online practice. So that is information giving, and it does not mean that you are soliciting patients. Informing patient about the telemedicine practice. How do we go about? The best way to go about is not to do advertisement. However, you have to be very clear. You will do publicity for the time period when you are changing from one practice to another practice. The best way is giving information on the prescription, or else on the visiting card, or by word of mouth is the best way. Do not do advertisement on social media, internet, and other ways of doing those things will definitely attract penal provisions of removing your license. Hence, be careful how you provide information on social media. At the same time, you need to keep a professional boundaries between your personal social media account and the professional social media account. Please do keep the social media account of yours personal versus professional social media account completely separate. You can have it two accounts where one of them is for personal reasons for your family and friends. One is very specific for professional purpose. Don't mix them both because the boundaries becomes very blur. At the same time, have a two different dedicated phone numbers, one for personal reason, another for professional reason. And whenever the patient requests for social media account, please do provide them the professional account, not the personal account. Because social media is a powerful tool to provide psychoeducation, providing information. At the same time, when you are available, when you are not available, those kinds of information can be provided through social media. And please do remember, World Health Organization has clearly said that social media is a powerful tool to reduce stigma, and improve education among persons with mental illness and their family members. At the same time, never ever share patients' data on social media with regarding their picture, clinical data, or maybe X-ray or any other clinical data on social media without the consent. Even if you are going to take a consent, it should be irrevocable consent explaining once the information goes out of your either laptop or the mobile, it is very difficult to stop them. For example, if you have taken a picture of the patient regarding an illness and you have circulated in the social media, either maybe WhatsApp, Facebook, Instagram, once it goes out of your mobile phone to the other accounts, it's very difficult to get back. You cannot stop the spreading of those maybe videos or photographs. Hence, you have to explain the patient and it is irrevocable. And the patient wants to stop it, the psychiatrist cannot stop the spread of those messages or maybe the photographs. And be very careful when you make comments on social media with regard to your colleagues, with your subordinates, about your students, and about your patients. Be very careful. So you have to behave very, very responsibly when you are in the social media. It is almost equivalent to the way you behave with the same person when he is in person, when you are talking to him. When in his absence, never make comments in social media, or else even if he is there, be very, very gentle and be very professional, either when you are dealing with the patient or with your professional colleague. At the same time, your online presence should not considered as advertisement. Be very careful. Do not ask your patients to rate you, asking for voting, asking for self-endorsement, and also patient writing. This is one of the best patient doctor I have come across. Those kinds of endorsement should be stopped because they all means you're advertising, you're endorsing your professional career, which can definitely invite for ethical dilemma or else a penal provision of removing your license. Let's move into the chapter 3. It is on technology requirement to start telepsychiatry practice. Please remember, it is not the technology, the hardware, the software, what the doctor can learn and use it. That's not the yardstick. The yardstick is the hardware and the software, what the patient can learn and use very freely and also very easily. That means user interface should not require much of training. As much as zero requirement of training would be the best. And even the requirement of hardware should be very less, and the yardstick should be the user's interface should be as simple, as easy, as cheaper or economical, and requirement of hardware should be very less on the side of the patient. That is on the user side. The doctor side also, if it is very simple and the doctor need not go any training and also does not require any higher amount of training, is the best software. Hence, the yardstick is the patient requirement. It's not the doctor requirement. The key requirement in telepsychiatry is internet connection. Have at least 2 to 3 service provider. A chance one of the service provider goes off, you can switch over to the another service provider. At least 512 kbps is required. And if you have 2 Mbps, I would request or recommend 2 Mbps. And preferably have both. One is cabled, another one is a Wi-Fi. Nowadays, Wi-Fi 2.4 and 5 GHz are available. If the router is kept very close, 5 GHz is the best. Regarding what is the best hardware to be planned or bought, invest in good HD camera. The camera which is very good in quality, plug and play was the best. Place the camera at the eye level. Don't keep it very high or low. So keeping at the eye level makes the eye contact very easily. Whenever you talk to the patient, don't look into the monitor. Please look into the eye of the camera so that it maintains eye contact with the patient. And looking into the camera is a very important skill which you should learn over a period of time. At the same time, invest in very good audio mic. At the same time, the room which you are going to use for telemedicine consultation or telepsychiatric consultation should be as much as soundproof, and also it should be quiet. If possible, isolated place would be the best. Headphones would be the best along with the cuff, so that nobody else will be able to listen to the conversation what the patient is speaking to the psychiatrist. Coming to the lighting, lighting is a very essential component with regard to telepsychiatric consultation. There should be enough of lighting. If possible, warm white LED should be there along with the Kelvin of somewhere around 3000 to 4000 Kelvin lights is very essential. Avoid placing the camera directly in front of the windows. It should be placed directly behind the windows so that the light falls on the psychiatrist's face. I would advise to have the lights which are artificial. That is basically you can control the lights. If you are relying on the natural lights for the provision of lighting, then it will be very difficult, especially if you are doing consultation early in the morning or in the evening. The best way to have a lights which are basically three in nature, which I'm going to discuss now. At the same time, having the background which is not shiny, which reflects back into the camera. The background should be non-reflective matted surface, which will give you very good non-reflective surface for doing telemedicine consultation. And having a 3-point lighting is very essential. Having the two lights in front of the psychiatrist will show the light on both the side of the face, so there is no shadow. At the same time, having another light behind the psychiatrist so that the background is well lit. So 3-point lighting is one of the best. Coming to the telepsychiatry chamber, where should be the chamber placed? The chamber should be placed near to the OPD, wherever the psychiatrist does the consultation. Never ever keep the telemedicine consultation chamber away from the OPD. Whenever the psychiatrist wants to do telepsychiatric consultation, he should not walk around 100 or 200 meters away from the OPD counter. It should be as much as near to the consultation, in-person consultation chamber. If preferably, I would request you to have a telepsychiatric consultation where the in-person consultation is also kept. Having the wooden furniture and the floor mats decreases the echo so that the sound quality will be very good. Having the camera faced directly towards the face of the psychiatrist will help you so that the patient who are coming for in-person consultation should not think that they are recording the consultation. At the same time, the telemedicine consultation chamber should be as real as possible to the in-person consultation chamber, as professional as possible. If you are doing telemedicine consultation from your home, please do make it as normal and as possible equivalent to your chamber, and wear professional clothes. Having a formal dress is very essential. Just because you are doing telepsychiatric consultation do not mean that you'll be coming with informal dress. Sitting shabbily should not be there. You have to be highly professional, and you will give as much as respect the way you do in in-person consultation. Same thing you will do. And one more important is having a spectacles with non-reflective or anti-glare is very essential. Otherwise, the light falling on the glasses will reflect on the camera, and that comes in the way of maintaining eye contact with the patient. Moving to chapter 4, that is medical records. As per telepsychiatry practice guideline and also telemedicine practice guideline, EHR, electronic health record, EMR, electronic medical records are not mandatory. You can write the notes directly into the patient's file, and you can do the telemedicine consultation either using audio, video, or else even email. And you can enter the data directly into the patient's file, that is the physical file, and keep the copy of the prescription whenever you do the prescription to the patient. At the same time, follow the prescription which is advised by telemedicine practice guideline. I'll be discussing this about the prescription in the next video. At the same time, never ever forget to follow Mental Health Care Act 2017, Section 25, which mandates every psychiatrist to keep the basic medical records of OPD. So that basic medical records need to be stored, and whenever the patient is requesting for it, and you have to provide it. You cannot refuse. as per Section 25 of Mental Health Care Act, it clearly says that it is the right to basic medical records is for patients, and you'll be providing those basic medical records only to the patient. This is how the basic medical record proforma looks like it, and this is as per the Rule 6, subsection 3, Form B. This is the OPD requirement, and it also says that you have to keep a hard copy of the format. And if you are able to have a cloud format, no problem, but the physical format is required. Access to basic medical record, or to get those medical records, the patient will give an authorization letter, and that letter will be as per the Section 25 of the Mental Health Care Act in the prescribed format. The patient record shall be given only to the patient, not to any other person. And you have to be very, very clear. Securing the devices of telemedicine practice is very essential. Especially the various research done in US and UK have clearly said that the data breach, or else the important information which are leaked into the social media or into the virtual world, is basically the psychiatrist or the doctor has lost his laptop which is used for providing services. Hence, whenever the psychiatrist is providing telepsychiatry consultation, he has to make sure those laptops which is using for consultation should be secured and it should be under his custody. Unauthorized access of these laptops or these instruments should be prohibited. At the same time, you have to enable secure disabling or wiping the hard disk if by chance if there is a theft of your laptop. And most of the time, the data breach occurs whenever the other person gets access to your laptop. Most commonly, it has also been seen the doctor is providing telemedicine practice guideline in the daytime. In the evening, his laptop is used by either his child or his family member or his wife. By mistake, they may transmit the data of the patient to somebody else. That should not happen. At the same time, you have to make sure the audio or video recording either of the client or of the doctor has to be occurred under the explicit consent. Under no circumstances, covert recording of audio or video is prohibited on both the side. At the same time, chamber consultation, keep the camera of the telemedicine consultation facing the psychiatrist, not towards the patient, because during in-person consultation, the patient should not see that there is a camera kept facing him, and many a time patient becomes paranoid thinking that they are recording the consultation. Hence, keep those cameras facing the psychiatrist away from the patient. Let's move into the chapter 5. That is telepsychiatric consultation. What will you do before the consultation, during the consultation, and after the consultation? During the pre-consultation, the consultation should be based upon appointment. It should be planned. It should not be random. And at the same time, when the telemedicine consultation or telepsychiatric consultation is done, alternate contact details, by chance if there is a change in appointment or if there is any technical glitches, has to be provided both side, from the patient and also from the psychiatrist side, because the technical glitch can occur at the psychiatrist or at the patient end. And also, please do explain about the emergency consultation before in hand. I will be discussing about emergency consultation shortly. At the same time, telemedicine consultation details has to be provided, and also you have to talk to the patient. Do's and don'ts has to be explained to the patient and the patient party. And at the same time, you can provide soft copy of the telemedicine practice guideline to the patient and the patient party. Consent form can be sent to the patient so that he can sign and come back when the teleconsultation is done. Also, you can also provide following documents to the patient. These following documents are optional. I will repeat, these documents are optional, not mandatory. This is how the first consult documents looks like this. If you look that, we have made it as optional. If the patient and the party are highly educated, you can send this pro forma to the patient and the patient party. Let them fill these information, including name, demographic details, what are the chief complaints, and where the location of the patient and the family member. You can also use these diagrams to locate the symptoms, and he can also provide past history, present history, and also marital history. The eighth point is very, very essential. The eighth point is you are asking the patient, please tell me, is there any legal conflict, or else is there any conflict with the law, or else you require any certificate. At the same time, remaining will be filled by the patient, the last part to be filled by the psychiatrist. This optional document is very helpful to get those records written by the patient or by the family members. Along with this pro forma, you'll be sending the consent form, which is very detailed, and the patient party is going to sign this. Please do send the documents of do's and don'ts for telepsychiatric consultation. You can also mention telemedicine consultation is only through either text, audio, or video, and if you are going to charge for audio and video or even for the email, can be clearly explicitly told. And you can also ask them to fill the pro forma and send it to you before the telemedicine consultation. Request the patient's party to upload the government ID. At the same time, to upload the previous treatment details, and also if they have taken any consultation with other psychiatrist or he has been admitted, those documents can be uploaded so that it is available for the psychiatrist before he does telepsychiatric consultation. At the same time, you'll also mention the duration of consultation is very fixed, and if he wants to have more time, he can ask for one more consultation. At the same time, you also need to make aware of them the limitation of telepsychiatric consultation. At the same time, patient has the right to choose in-person consultation instead of telepsychiatric consultation. The same right is also given to the psychiatrist. The psychiatrist can refuse to provide consultation on telepsychiatry, and he can request the patient to come for in-person consultation. That means on both the side, they have their rights, and they can call off the telepsychiatric consultation anytime and can request for in-person consultation. At the same time, it is the doctor's discretion to choose what kind of consultation he is going to do, whether it is audio, video, or else maybe the other platform if he is going to use. A copy of the telemedicine practice guideline should be sent to the patient and the patient party. And at every time when you do the telemedicine consultation, you need to talk to the patient and ask them whether they are comfortable when they are starting the teleconsultation. And every touch base, you are going to ask for the identity of the patient and also the government issued ID card. And also, presence of patient is essential for the first consultation. Coming to the follow-up consultation. Again, for the follow-up consultation, there is a pro forma which is made available, and that pro forma is also optional, is not mandatory. The patient family and the patient party are well versed, they can fill this pro forma and send to the doctor. Along with this, he can fill the demographic details. The doctor will verify the ID. Last in-person consultation has to be documented. Improvement, previous consultation and prescription can be added. Along with this, if the patient has any side effects, and also every follow-up, you are going to ask for any legal or any pending legal inquiry or else any departmental inquiry. That means any kind of conflict with law needs to be documented. If it is not there, you will say the patient denied of any legal issues. Family table, family marital discord, and any other information they wish to share can be used for this follow-up pro forma. Coming to during the consultation, what will happen? During the consultation, in case if there is any internet connectivity or technical glitches, the psychiatrist had to decide if there is a technical glitch either on the doctor side or in the patient side. In the initial part of the consultation will be aborted. A text message or else an audio call will be made to the patient, and a different consultation time will be given. By chance, if it occurs at the end of the consultation, then he can continue with the audio consultation and provide prescription. At the same time, once the consultation is over, please plan for a follow-up, and a new date will be given, and which will be marked for the patient and also to the psychiatrist so that the slot is fixed before in hand. Further, after the consultation, once the consultation is over, he will be clearly documenting, making the prescription. That prescription will be as per the Telemedicine Practice Guideline 2020 format. A copy will be retained. A soft copy will be sent to the patient either by taking the photograph or scanning the prescription. It will be sent to the patient. And when the prescription is writing, he should also make sure lifestyle changes can be advocated, like diet change, exercise, avoiding substance use. Those are the information can be provided. At the same time, the psychiatrist can use this feedback pro forma, which is again optional, which can be sent to the patient, and the patient will document this or by marking what was the video quality, audio quality, communication, prescription explained or not, side effect explained or not. Any suggestion can be used for the to be given to the patient, so that the patient will be providing the feedback how the consultation was. If there is any problem in the rating, the psychiatrist or his colleagues, or it may be his subordinates, can call the patient and ask, "You have made a tick telling that the communication was worst. Please do tell us, was the communication was so bad, whether whatever the discussion occurred, whether he understood or not. If he says it is not understood, please rectify it, and you can have one more consultation." Please remember, if the patient requires, once the consultation is over, online investigation can be raised and directly sent to the patient. Those investigation can be carried out by the patient from the in-person in the nearest lab. Please do remember, my dear friends, the requisitions sent online or by WhatsApp or social media to the patient, those investigation will be honored by the laboratories for the purpose of doing investigation. At the same time, if the patient requires general physical examination, the doctor can refer him to the nearest in-person consultation medical officer, or else even to the laboratories where the general physician is available. And please do remember, never ever forget, follow the clinical practice guideline when the prescription is written, or else any investigation has to be done before starting a medicine or before diagnosing. Those clinical practice guideline has to be followed by the psychiatrist. And coming to the last part of my presentation, which is emergency telepsychiatric consultation. By chance, if the patient says that he wants an emergency consultation and there is an emergency situation, in such a scenario, telemedicine practice guideline is very clear. It clearly prohibits the psychiatrist to engage a patient in emergency situation. In the emergency situation, the psychiatrist will advise first aid, will do counseling, and facilitate referral for in-person consultation. Please do remember, again I will repeat, in case of emergency, patient will be advised for first aid, counseling will be done, and facilitate the referral to in-person consultation. This has to be done very sensitively. At the same time, the doctor will record all his statement and advice in the document, and a referral letter will be given to the patient. Please do remember, the rule of thumb is in-person consultation is for emergency care, not telepsychiatry. So, whenever there is an emergency, please do refer them for in-person consultation with the nearest registered medical practitioner. At the same time, if the patient is seeking telemedicine consultation during odd hours, maybe in the night around 2 o'clock, 1 o'clock, or maybe in the early morning 3 o'clock, in such a scenario, the doctor can choose either to attend the call or not to attend the call. It is the professional discretion of the doctor to decide to give consultation or not consultation. Not attending the patient in the odd hours is not ethical violation. Let's move into chapter 6, telepsychiatry practice. In this chapter, we are going to discuss about first consultation, follow-up consultation, telepsychiatric consultation initiated by the family member, with patient, without patient. There is a third, healthcare worker consulting the psychiatrist through telemedicine. And this is usually by the home visit, and the consultation is collaborative video consultation. These are the issues which we are going to discuss in this chapter. Now we will discuss about first consult. First consultation means the patient has contacted the psychiatrist for the first time in his life. That is first consult. Also, if the patient had contacted the psychiatrist, if it is more than 6 months back, then also it is first consult. The third point is if the patient had contacted recently, again is contacting the psychiatrist for different health reasons, then also it is considered as first consult. For example, if the patient had contacted the psychiatrist for treatment of seizure 1 month back and again he is contacted now treatment of depression, there are two entirely different health reasons, then it is also called as first consult. Let's understand step by step. The patient is contacting the psychiatrist either by sending a message or by an email, or else he may even make a phone call or a video call. As soon as the patient contacts the psychiatrist, is implied consent. Once he has contacted, the psychiatrist will send certain formas, first consult pro forma, which is an optional. Do's and don'ts in telepsychiatry. Again, the information is given to the patient. And requisition for ID card will be placed. At the same time, past treatment details, investigation, anything required will be requested at this point of time. Once the patient fills the pro forma and sends to the psychiatrist, an appointment will be given. On the day of the appointment, the psychiatrist will prepare himself, and once the consultation starts, he will identify himself. At the same time, he will identify the patient by asking for various government issued IDs. Once the psychiatrist is satisfied about the patient, he will continue with the consultation. Immediately, he will check whether there is a emergency care is needed. If there is a emergency care is needed, first aid advice will be given, counseling will be done, and request for in-person consultation referral will be done immediately. If there is no emergency care is required, detailed assessment and investigation will proceed. Once the detailed investigation or the detailed assessment is done, then the management will be having health education, counseling, and medication list O will be given. Medication list O is nothing but over-the-counter medication. By chance, if there is a video consultation, then list A medications can be given by the psychiatrist to the patient. And if by chance the patient has done the consultation today, within 2 or 3 days, if the patient requests for one more telemedicine consultation, will it be considered as telefollow-up? No. It is still the first consult. It is not a telefollow-up consultation. For follow-up consultation, there should be an in-person consultation in the past 6 months. This is the mandatory requirement as per the Telemedicine Practice Guideline 2020. Let's understand about follow-up telepsychiatry consult, because it is very confusing to many of my colleagues. Follow-up consultation means within past 6 months, the patient should have contacted the psychiatrist for a treatment and he is doing telefollow-up by online consultation. That means within 6 months, in-person consultation is required. However, there are two exclusions have been placed. If the psychiatrist is unable to remember the patient, and also it will become first consultation. Or else, if the patient is contacting the psychiatrist online for a different health condition, then also it is be considered as the first consultation. Let's understand step by step. The patient is going to contact the psychiatrist either by sending a request by message or else placing for an appointment through online. You may also make a phone call or a video call. As soon as the patient contacts the psychiatrist, it will be considered as implied consent. Once it is done, the psychiatrist will send certain proformas to the patient to fill up. Do's and don'ts, ID card, previous prescription, any investigation if it has been done in the past 6 months will be requested to be uploaded. Once it is done, an appointment will be given to the patient. On the day of appointment, the psychiatrist will check all his devices, go through all the documents, and then he will initiate the telepsychiatry consultation. As soon as he initiates, he will identify himself and also will request for government ID card from the patient. Once the patient is identified and he is comfortable, the telepsychiatry consultation continues. In the next stage, the psychiatrist will quickly assess whether the patient requires emergency care. If there is emergency care is required, you will be given first aid advice, counseling, and in-person consultation referral will be given. If there is no emergency care is required, detailed assessment and investigation is done. And these are the management or tele-follow-up is done. First and the foremost, health education. Second is counseling. The refill of medication will be done. That is, whatever medications given during in-person will be refilled during the tele-follow-up. At the same time, medication list B can be given by the psychiatrist to the patient. By chance, if there is a new complaint is the reason for consultation online, then it will be considered as new consult. And if it is a video consultation, you can give list A or else list O medications can be given. Now we will discuss the requirement to come for in-person consultation to be on tele-follow-up is at least 6 months once. That means in the past 6 months, the patient should meet the psychiatrist in person, real face-to-face consultation has to be there. During that time, investigation is done, general physical examination is done, and the tele-follow-up will be given. This is kept mandatory because every 6 months, some of the conditions requires investigations. At the same time, the real touch between the patient and the psychiatrist should be there. Hence, there is a mandatory requirement of 6 months once, at least for in-person consultation, has to be done for tele-follow-up. Now let's move into telepsychiatry triage. Triage is nothing but here the patient care will be given based on the priority. Here now there is a proxy consultation has been requested by the family member. It's basically a family member has initiated the telepsychiatry consultation. Here the family member can be nominated representative or else any other person authorized by the patient for telepsychiatry consultation. For this to happen, there should be very clearly an authorized letter with the informed consent as per the Appendix 4 in the telepsychiatry operational guidelines has to be filled by the patient and handed over to the person who is going to do telepsychiatry consultation. That will be given to the psychiatrist. This is how authorization letter looks like. This has to be filled by the patient and will be signed by both the patient and the person, the NR, nominated representative, will be signing it, and that will be given to the psychiatrist. If the caregiver is initiating the telepsychiatry consultation, here the caregiver is a family member or any other person authorized by the patient to represent him. But however, here there are two situations. One is the caregiver has requested for a consultation along with the patient. Second one is the caregiver has requested for a telepsychiatry consultation in the absence of the patient. Again, that is followed if the patient is minor, less than 16 years, means the patient is a minor, the NR or the legal guardian will take the decision on behalf of the child. There, the telepsychiatry consultation can be done easily in the absence of the patient. However, if the psychiatrist wants to see the patient, definitely he can ask for in-person consultation, or else he would like to talk online, should be facilitated. Otherwise, the psychiatrist will refer them for in-person consultation. But however, the second important point is if the patient is incapacitated, is he has lost his mental capacity. This is a situation whether a caregiver can continue with the telepsychiatric consultation we'll be discussing. Let's discuss initiation of a telepsychiatric consultation by a family member when patient is present with them. This is how the telepsychiatric consultation is done when a family member and the patient both are there. When both of them are there, the psychiatrist will check for the ID of the patient, age proof, and also he will ask for any valid document establishing the relationship between the patient and the family member. If the patient is a child, is less than 16 years, and the clear-cut establishment of relationship is there, he is a guardian, legal guardian, or the parents, then the consultation will continue as per the will or the wish of the family member. If the patient is an adult, and if the patient is an adult, on capacity assessment, if the patient has capacity, then the consultation will proceed as per the will of the patient. During this process, the psychiatrist will assess whether the patient is comfortable discussing his issues in the presence of a third party. If he sees yes, the consultation will continue. If he places a reservation, the psychiatrist will request the other person, maybe caregiver or family member, to move out of the consultation chamber. By chance, if the patient doesn't have capacity, in such a scenario, if it is a first consult, then there will be a counseling will be done, and they will be requested to come for in-person consultation. By chance, if he doesn't have capacity, but at the same time it is a follow-up consult, in such a scenario, the psychiatrist will check for any advance directive, and he will follow the advance directive as per the wishes of the patient. And if he is very doubtful and he feels the patient is violent, the in-person consultation will be requested immediately. Initiation of a telepsychiatric consultation by a family member in the absence of a patient. All in-person consultation will be advised in the absence of a patient, and it is a first consultation. Please do remember this. Very important point. For all in absentia, first consult should be in-person consultation. Let's go through the flow chart. If a caregiver has placed for a consultation in the absence of the patient, if it is a first consult, in-person consultation should be advised. If it is a tele-follow-up consultation, check for the authorization ID, and the psychiatrist is able to establish the relationship between the patient and the family member. And if there is an authorization letter, tele-follow-up consultation will continue. If there are no proper documentation and the psychiatrist is not comfortable to give any consultation in the absence of the patient, can refuse and ask for in-person consultation. Now, let's spend time on discussing about proxy consultation and proxy prescription. Invariably, in all psychiatric settings, 30 to 40% of them will be proxy consultation and proxy prescription. But however, especially in telepsychiatric consultation, do not give prescription to a caregiver in the absence of the patient unless there is an authorization letter and there is a proof of ID of both the patient and the family member, and he is able to establish the relationship between patient and the family member, and there is adequate documentation. Then only the proxy consultation will be honored. By chance, if the psychiatrist is not comfortable by the reason of professional discretion, he will request them for in-person consultation. Family members are requesting for a parenteral injection because patient is refusing for medication. What should a psychiatrist do? In such a scenario, the psychiatrist should request for in-person consultation. Whenever patient is refusing medication and the family members are requesting for parenteral injection and you do not know the mental capacity status of the patient, in such a scenario, it is advisable for in-person consultation. Avoid all those patients who have poor compliance on telepsychiatric consultation. Further, for injection, the Board of Governors of Telemedicine Practice Guideline are very clear. They said that parenteral injection can be given only whenever the consultation is between a psychiatrist and another healthcare worker or with the RMP. It will be a collaborative video consultation. That means the healthcare worker will go to the patient's house. From there, he would have been doing the consultation. In such a scenario, when the healthcare worker is on the other side, the psychiatrist can issue the injectables. Otherwise, the psychiatrist is not authorized to give injection directly to the patient as a prescription because it requires a healthcare worker to deliver those injections. At the same time, please do remember, whenever such prescription is given to the healthcare worker and the healthcare worker is going to give the injection, the psychiatrist should remember about the vicarious liability. He should be confident about the skills of the nurse or the healthcare worker, and at the same time, he should clearly know that all the facilities are available when the parenteral injection is given. Now, one more important, which is very often requested by the family members of persons with mental illness. The patient is refusing to come to meet the psychiatrist or else refusing medication. In such a scenario, whether a healthcare worker can go to the patient's house and can he do a telepsychiatric consultation along with the psychiatrist? Of course, the healthcare workers are all those who are nurse, allied health professionals, mid-level healthcare practitioners, A&M, or any other health practitioners who are designated by the appropriate authority. And this healthcare worker can start a collaborative video consultation along with the psychiatrist, either from the home, or maybe in a community, or else from a satellite clinic, or from a mobile medical unit. They can initiate this consultation from any part of the community. But however, it can be consulted to a private psychiatrist or to a public psychiatrist. And here, very important is the healthcare worker should obtain an explicit consent from the patient. At the same time, if there is no informed consent, please refer them for in-person consultation. At the same time, healthcare worker and RMP, when the collaborative telepsychiatric consultation is done, both of them will ask for ID, identify them, and then the consultation will be given. This is how the process occurs. Healthcare worker in a community setting, he goes to the patient's house, will check for the ID of the patient, check for the information, will gather the information. At the same time, we will do capacity assessment. If the capacity is present and the patient gives a consent, we'll go ahead with the telepsychiatric consultation along with the patient. If the patient refuses telepsychiatric consultation, we'll stop the consultation because the patient has capacity. By chance, if the patient doesn't have capacity, and if it is a first consultation, it will be referred for in-person consultation. He will check for if there is an advance directive. If the advance directive is there, he will follow the advance directive. If there is no advance directive, the psychiatrist will take the consent from the NR and he will proceed as per the Mental Health Care Act for providing care for persons with mental illness. Telepsychotherapy. The psychiatrists have been trained in providing psychotherapy. However, because of pandemic, online telepsychotherapy is becoming very popular. And here, the psychiatrist can do telepsychotherapy at the same time can also prescribe medication. Or else, he can keep it separately. That is, he can do a consultation for medication and he may do a psychotherapy later. That is after 1 week down the line. But however, before you resort to these kinds of telepsychotherapy, please do check for whether the patient is fit for telepsychotherapy. Check whether there is impulsivity, whether there is emergency care is required. In such a scenario, in-person consultation will be advised. In every session, the psychiatrist should check for any emergency care is required. And in every session, the psychiatrist will ask for ID of the patient. Only after positive identification, we will do telepsychotherapy. Here, the telepsychotherapy has been advocated by telemedicine practice guideline by mentioning as counseling for specific clinical condition. So, cognitive behavioral therapy, wellness therapy, all those come under this category. At the same time, if you are going to have a caregiver during telepsychotherapy, please do take explicit consent from the patient. And again, all consultation should be pre-planned. Please avoid or refuse to provide emergency consultation. Please do inform them all emergency consultation will be given in-person consultation referral. In a scenario of an emergency situation, the psychiatrist will not be able to help them through telepsychotherapy or teleconsultation. Hence, in-person consultation is mandatory, and a copy of the telemedicine practice guideline can be given to the patient and the patient's family member. Please do remember about the basic medical record. Whenever the patient undergoes telepsychotherapy, the psychiatrist is mandated to keep a basic medical record. And whenever the patient requests for basic medical record on a case-to-case basis, and for every session, psychiatrist should do the documentation and session notes should be available for the patient. And this is how the proforma of the counseling reporting form is here. This need to be filled for every session and should be made available whenever the patient asks for basic medical record. And the consent form for the telepsychotherapy looks very comprehensive and should be used. Now coming to the prescribing medication online. For the different categories, how they are given. The prescribing list, there are 4 important: List O, A, B, and List C. List C is nothing but prohibited medication which cannot be given online. Coming to the List O. List O is over-the-counter medication like paracetamol, antacids, syrups, and vitamin. So these, for any type of consultation, List O can be given. List A is given for only video consultation for first consult and for any type of consultation or follow-up consult. That is mode I am talking about. Coming to the List B is a list of medication which RMP can prescribe in a patient who is undergoing follow-up consultation. That is, in the past 6 months, he has met the psychiatrist in person. In such a scenario, List B can be given for online consultation. Let's look into the matrix of permissible drug list. The first row is basically for the headings. The second row is List O. List O, any type of mode of consultation is allowed: audio, video, or text. The nature of consultation, it can be first consult or follow-up consult. Those are all List O, over-the-counter medication. List A. For List A, for the first consultation, video consultation is a must. But however, for follow-up, it can be audio, video, or text methodology. Coming to the List B. List B, any type of consultation, mode of consultation is allowed. However, the past 6 months, it has to be in person and only follow-up, the List B can be given. But however, remember, last one is prohibited. Under no circumstances, the psychiatrist will issue online prescription for these medications. Let's go into the List A. The List A has been clearly mentioned in the telepsychiatry operational guideline based upon the best logical explanation. The List A is nothing but essential drug list which are notified under the Mental Health Care Act of 2017. This notification was issued on 16th August 2019. All essential drug list under the Mental Health Care Act will become List A. These are the list. This is available in the web notification. Again, please do remember, injections, online prescription shall be given by a psychiatrist to an RMP or a nurse. Don't give prescription online directly to the patient, especially the injections. At the same time, please do not give prescription for zolpidem, lorazepam, or else injection risperidone or olanzapine. All these requires a healthcare worker, and especially injection risperidone requires presence of a psychiatrist. But however, with regard to clonazepam and clobazam, there has been an amendment by the MCI, and they have allowed clobazam and clonazepam, although they fall under the Narcotic Drugs and Psychotropic Substance Act of 1985. These are List A. The only reason for List A has been these medicines because they fall under essential category. However, the author of this telepsychiatry operational guidelines and his colleagues tried to classify many of the drugs into List A. Unfortunately, there has been any logical or reasoning was made available. It was difficult to think which will become List A and which will become List B. For example, For schizophrenia, the first line of treatment for a child is different, for an adolescent is different, a young lady is different, for a pregnant lady is different, for a elderly person is different. That means diagnosis is same. But however, depending upon the age, depending upon the pregnancy, depending upon various other factors, the first line of medication changes. The only prudent mechanism and the explanation of logically was understood by keeping all list A medicines coming under the essential drug list. Coming to the list B. List B are all other medications which do not fall under list A and list C, that is prohibited medication. However, the authors of the telepsychiatry operation guidelines have clearly mentioned other medicines for antipsychotics, other medicines for antidepressants, similarly for anti-craving, anti-dementia drugs, anti-ADHD drug, mood stabilizers, beta blockers, and injectables. Here, others means basically any new medication coming not require any amendment. They automatically come under this category of other medications. At the same time, please do remember there have been parenteral injection which comes under the list B, such as clofentixol, flufentixol, haloperidol, and aripiprazole. These medications will be given to another healthcare worker via collaborative video consultation. Don't give parenteral injections prescription directly to the patient when an online consultation is done. Coming to the prohibited list, there are two important things you should remember in the prohibited list. Those medicines which fall under Drugs and Cosmetic Act of 1940 and Rules 1945, such as amphetamine, methamphetamine, dexamphetamine, encyclidine, methylphenidate, and many other medicines. These do not prescribe online. They are completely prohibited. One more important category is NDPS drugs which are notified. Those medicines such as buprenorphine, methadone, codeine, tramadol, cannabis, benzodiazepines should not be again prescribed online. Both these groups have been clearly prohibited for online consultation prescription. But however, as I mentioned, there has been a clear MCI amendment with regard to phenobarbital, clobazam, and clonazepam. On 11th of 4, 2020, this notification was issued with regard to allowing phenobarbital, clobazam, and clonazepam can be prescribed for either the first consultation or follow-up consultation. And this has been done because many of the seizure patients require the NDPS medicines like phenobarbital, clobazam, and clonazepam that has been allowed under the MCI amendment on 11/4/2020. Let's look into the format of prescription. This is how the format of the prescription as per the telemedicine practice guideline is made available. Please do remember when the prescription is written, you have to write about the chief complaints, relevant history, examination, lab findings, and also suggested investigation. Don't forget to mention about provisional diagnosis. And if you're able to arrive for a complete comprehensive diagnosis, it's well and good. Please document about the medications and also special instruction which has been mentioned. And in the bottom, you have to mention about whether this prescription was issued online or in person has to be documented. Now, coming to the final part of my presentation, that is medical legal issues in telepsychiatric consultation. Medical legal issues in telepsychiatric consultation are now becoming very common. Hence, you have to take certain important precautions. Encourage telepsychiatric consultation through appointment only. Avoid emergency consultation. Verify the identity of the patient. Identify yourself to the patient. For every consultation or every session before any therapy, please do check for whether there is a patient requirement for emergency consultation. At the same time, psychiatrist should ensure there is a mechanism for patient to verify the credentials of the psychiatrist. Presence of patient is essential during tele, follow-up, or in-person consultation. Whenever the psychiatrist feels that there is something wrong, please ask for in-person consultation. Encourage the patient and the patient party to fill the Appendix 1 and 2 for first consultation or follow-up consultation. Although they are optional, insist for them to fill this. If they are able to fill, your documentation becomes very easy. Further, please do follow Mental Health Care Act. Don't think that just by doing telepsychiatric consultation, you can forego Mental Health Care Act. No. Even if you are doing telepsychiatric consultation, you need to follow Mental Health Care Act. Although it is even a OPD basis consultation. Patient has a right to choose in-person consultation over telepsychiatric consultation. At the same time, the psychiatrist is also have a professional discretion to choose to provide teleconsultation or else in-person consultation. However, the psychiatrist cannot insist only on telepsychiatric consultation. If the patient wants to come in person, is allowed to do that. But again, a reasonable degree of care has to be taken to secure the patient's privacy and confidential data. In all case of emergency, the patient must be advised for in-person consultation. At the same time, before you refer them, please do first aid advice, counseling, and at the same time, referral should be given. And psychiatrist as a professional, discretion to choose the mode of consultation. It can be text, audio, or video. And he can ask for in-person consultation at any stage. Issue prescription only after making a provisional diagnosis. Do not prescribe list C medications. That is prohibited list. Those medications which come under NTPS and also Drugs and Cosmetic Act of 1945. Explicit consent should be taken before you transmit the prescription to a pharmacy or to a third party. But however, this is one important area I felt that need to be discussed. A patient in conflict with law means patient has done something wrong and he is being required by the investigating agency. That is what we call it as in conflict with law. If a telepsychiatry is done and they are requesting for certificate, what has to be done? Person in conflict with law. Psychiatrists need to inquire for any legal issues in any consultation, either for the first consultation or follow-up consultation. As soon as he checks for emergency care is required, immediately he should jump into whether there is any legal requirement, whether they require any certificate, or else is there any FIR lodged against him. Those are the important information has to be sought out by the psychiatrist. It is the professional discretion of the psychiatrist to advise for in-person consultation or inpatient admission for a person who is in conflict with law, so that a comprehensive, complete assessment is done and appropriate certificate can be issued to the relevant authorities. However, please follow Mental Health Care Act before you issue a medical records. At the same time, if you have a doubt, consult a medical board before issuing any certificate on telepsychiatry. To conclude, my dear friends, before you start for a telepsychiatry consultation, identification of both parties are very essential. The psychiatrist will introduce himself. At the same time, he will verify whether the patient's ID matches with the patient. Proxy consultation, be careful. All proxy consultation for the first consultation request for in-person consultation. Authorization is a letter must for tele-follow-up in the absence of the patient. Legal issues are similar to in-person consultation. Just because you are providing telepsychiatric consultation, you cannot forego other laws. All in-laws which are applicable for in-person consultation is applicable for telepsychiatric consultation. Please do use telemedicine technology to provide psychotherapy. And don't forget to follow Mental Health Care Act. Thank you very much for giving your valuable time. Stay safe.
Friends, I must thank Dr. Suresh Badamat for an excellent and a comprehensive presentation. I'm sure there can be some questions, or the presentation has been extraordinarily lucid. Since we are short of time, I am requesting people to send in the questions to the speaker so that he can get back to you. Unless the organizers tell me that there is time for some questions. It looks like we have overshot the time by more than 20 minutes.
Yes, sir.
So, since the madam has come to the dais, I believe there are no questions entertained online here. I request people to send questions. Dr. Suresh Badamat has given his email address on presentation. Please go ahead, send the questions. And the FAQs are already present in his website address for all of you to look at these questions and the answers as well. Thanks a lot. Thank you very much.
I think there is a question. Vishal, sir.
5 minutes is there. Okay, sir, Keshwji. Suresh, there is a question that I probably will let you answer.
Sure, sir.
Thank you, Dr. Suresh. This is regarding the ordering admission of a patient. Now, the Mental Health Care Act says that you should have seen the patient in person in the last 14 days if you have to certify him for admission into a closed facility. Now, supposing you have known the patient earlier, but you have not seen him in the last 14 days and do a teleconsultation in the last 14 days, can you give a certificate for admission?
Sir,
without a physical consultation, but only on a teleconsultation.
So the wording is you have to see in person is the wording. If you look at the Mental Health Care Act, you should have seen the person. But unfortunately, when the Mental Health Care Act of 2017 was drafted, was released also, the telemedicine was in the main, was not in the mainstream. Most probably the amendment can be considered, but however, at this point of time, it should be in person, sir, for admission. So invariably for Section 89, it is one psychiatrist or a mental health professional or even RMPs. The two people have to examine him, then only we have to admit. And there is no, at this point of time, telemedicine was not considered in the Mental Health Care Act, sir. So it's a gray area if you ask me. At this point of time, I don't have answer for that, sir. I would rather consider for in-person admission only, sir. In-person examination for both because it clearly says that both should have independently examined and independently signed and given the certificate.
Dr. Praveen.
Beautiful presentation, Dr. Badamar. Thank you.
Thank you, sir.
I'm a private practitioner and I do teleconsults. And when you insist that I need a government authorized ID card, I honestly cannot practice. I'm sorry, it could be the same with many practitioners. And one. Two, now if I insist ID cards on telemedicine, will I need an ID card when they walk into my clinic as well? Two, which we don't do it on a regular day-to-day consults. Three, can I refuse because somebody hasn't given me an ID card? Four, how can I secure the ID data? I'm not authorized to keep Aadhaar data. I'm not allowed to ask for Aadhaar card details even, or any other ID for that matter. How do I keep it secure? And six, if I don't have an EMR system, I can't do a teleconsult given the current circumstances. And much of the EMR systems existing are not HIPAA. If there is a compliant system, who is the guardian of the data? And if there is a breach, who is liable? Will I be? And who owns the data? Will the patient own or I own the data? So multiple questions, but I think all around one issue.
Okay, coming back to this, sir, telemedicine practice guideline is very clear. Anonymous consultation is prohibited. Both the parties should identify each other, then only you have to provide teleconsultation. The main reason being here is the telemedicine consultation. Imagine if there is a conflict of law and somebody else does the consultation in somebody else's name. It's very common in telemedicine because even if you in person, if you see in our own community setting, what we had found the data, like patients, when the camp occurs in a place near district A, in a taluk, patients from that place, they don't go there. They go to the another camp which is away from the district because they want to have that secrecy or confidentiality. Similarly, here the patients want to have that anonymity and they don't want to share their name. It's very common. But unless there is currently the regulation mandates, both the parties should identify each other. For example, tomorrow a patient may come with a different name and tomorrow you give a certificate in that name and that belongs to somebody else. It will be a big problem we are going to end up. So that is the reason both the parties should recognize each other. It's not only for psychiatry, it's for every other system. Yeah. Be coming to that, should we store the consultation ID? Yes, you may have to store or you may have to write the number or the record or maybe see the way what happens is invariably when a person comes in person, we check their ID in the form of mole or some marks. Whereas here you have to mark the ID. This is their driving license ID or the Aadhaar number, which they have told that we are going to keep it. And for your kind information, sir, there has been a Supreme Court judgment which clearly has said that for the social welfare measures, the Aadhaar number or the government ID is required and it will be utilized. And even the telemedicine guideline authorizes to you to identify the person with the ID. So that is the second. Third, EMR EHR is not mandatory as per the telemedicine practice guideline 2020, not only for psychiatry, for any other subject. That is third. Fourth, suppose if you are going to keep the data online, suppose you have EHR, EMR, you have subscribed to a third-party application, or what we call it as aggregator, if we have applied to them, and telemedicine practice guideline 2020 is very clear. If there is a data breach occurs where the doctor is not responsible for it, for example, imagine it occurred from the patient end, or else it may be the cloud itself has been hacked by somebody else, then the doctor will not be held responsible. The wordings of telemedicine practice guideline is very clear. The doctor will not be held responsible if he is able to prove that he was reasonable in taking the securing his device and the cloud services. It occurred from the cloud services. Doctor will not be held responsible, sir. Hope I answered all your questions, sir. If anything is there, you can ask me. Sir, I am unable to hear your question. The mic is required for me.
I agree with the Supreme Court judgment is all about if I avail certain social benefits, I go to a public sector hospital and I ask for a concession, I ask for free service, or I go into look for I'm a farmer, I'm going to look for certain benefits. Supreme Court judgment applies there. Here I'm paying for a service, so that would not apply. I believe that's my interpretation. I know you're a lawyer, you're better read than me.
Yeah, I would definitely say that social welfare measures that is clearly a retired judge, Puttaswamy versus Union of India was the case. Whereas here, clearly it says that telemedicine practice guideline prohibits anonymous consultation. So in that scenario, we have to identify the patient. So identification doesn't mean that you have to store the data or store the information. If you are able to recognize the patient, that is the reason in telepsychiatry, when we started, we wanted to give the consultation for our old patient first. Over a period of time, when you know that this patient and the family, invariably every psychiatrist out of 100 patients they are seeing, 30 to 40 patients, they remember them usually because they are long-standing, they are follow-up. Those kind of patients we start first. Over a period of time, when the law, again, the telemedicine practice guideline which was released is hardly 1 year old. So over a period of time, we may bring in HIPAA compliancy. There is a law which is pending in the parliament, that is Data Privacy Act is there. And also that has been going on discussion is there. They are considering various way, and now they have very clearly, the very important thing they have brought in is under the IT Act, that the server we are going to use or the cloud we are going to use should be in Indian continent or Indian jurisdiction, so that we can make them accountable. So these are the small things are evolving, but at this point of time, sir, you have to recognize the patient. How you are going to recognize? That is the government ID is the one they are able to say. If you are able to recognize them because they are coming to you for many years, no problem, sir. You have to recognize them. One of the ways, government ID. That is the way they have said. If you are able to recognize them by various other way, no problem.
Yes, sir. I have a similar question which was displayed on the screen. So for the first time, the consultation was in person, and he was prescribed lorazepam or chlordiazepoxide. If for various reasons, if he chooses to have a follow-up consultation in telepsychiatry mode, so can we prescribe? And does it account for a first consultation or a follow-up consultation, because it is a different mode of consultation?
Yeah, sir, first consultation is in person and second consultation is telemedicine, will be a follow-up, tele-follow-up. That, let's be very clear about that. But no medications which fall into NDPS category can be prescribed online. It may be chlordiazepoxide, all those things. Only clonazepam is allowed online. The basic reason is this has been discussed in length. Even Professor B.N. Gangadhar sir also knows this, because we have learned from various other countries, these medications have been misutilized either by the patient parties or the family members, or else very rarely even many of our own doctors have been utilizing it. Or imagine, I can give an example, simple example, how it can be misutilized. A person who wants to use or supply medicine, or can be, because these NDPS drugs have a different rules for different states. For example, in Punjab, for NDPS medicines, even clonazepam, benzodiazepine fall into that category, which have been listed there. Imagine they have to take a state permission to prescribe, and the permission is given only when the patient comes for OP consultation in person. And if I'm sitting in Karnataka and if I start sending medications which are NDPS medicines, and the patient will consult me on the same day, it is easily doable, and he will consult you also, and he will consult many other person for buprenorphine, and he will have a valid e-prescription around 7 or 8, which he can buy it and parallelly can sell it. This is a well-known phenomenon which is occurring in US, and many doctors there they have come up with tracking the prescription with a patient ID has been formed there. But unfortunately, we have not gone to that level for tracking which person has issued the NDPS medicine there. But now we may, in a period of 3 or 4 years, we may come to that where psychiatrist will may be given a permission to prescribe those medicine, but that system has to evolve, sir. Under that, we are most probably in another 2-3 years we may come to that. But at this point of time, please don't prescribe NDPS medicines, including benzodiazepine online. Only medicine which is allowed under NDPS Act is clonazepam and clobazam, that too because NIMANS Professor B.N. Gangadhar sir and the IPS Dr. Dalal sir wrote to the NMC. Then only they gave permission considering weighing the risk and benefit, and they've given 3 medicines online prescription. Yes, sir.
Great, I think we should. It's been a good discussion, and you stimulated a lot of questions. I'm sure there could be some questions on the Q&A. Go ahead and send your answers. I'll ask the organizer to take over from now on. Thank you, Suresh.
Thank you, sir.
Due to shortage of time, if there are further queries, you can mail to sureshbm@gmail.com. I would again like to thank Suresh sir for the wonderful presentation. As sir is
Thank
not
you.
physically present over here, I would request Vishal Akula sir to connect Momento on his behalf. We will try to send it by mail to Suresh sir as soon as possible. I request Chandrasekhar sir to present Momento to the chairman of the session, Gangadhar sir. With this, I would like to end this session. Let us take a short break for lunch. Let us head to the dining section. The lunch is being organized by Crescent Pharmaceuticals, and I request all the chairpersons and the speakers of the sessions which have been already completed to collect their certificates and the plant links from the registration counters. Let us reassemble in this hall after about 30 minutes. Thank you. afternoon, everyone. Good afternoon, everyone. Let us go ahead with the next session. The topic for the next session is optimizing and balancing clinical skills with investigations in delivery of mental health services. For this session, I invite Dr. D. Keshav Rao sir to the dais for chairing the session. I would also like to invite the speaker for the session, Dr. Ashok Alim Chandani sir, to the dais. Let me give a short introduction of the chairperson of the session. Dr. Keshav Rao Duvalapalli sir has done his MD and MRCP psychiatry, and presently he is a consultant psychiatrist at Chetana Hospital, Secunderabad. He previously worked as Associate Professor of Psychiatry at Deccan College of Medical Sciences, Hyderabad, and locum consultant in child psychiatry, adult psychiatry in NHS, UK. He has special interest in ADHD, autism, CBT, and motivational interviewing. He is a fellow of IMA and Indian Psychiatric Society. He is past president of HPS, IMH Alumni Association and Telangana Psychiatric Society. I now request the chairperson to give a short introduction of the topic and introduce the speaker for the session.
Hello. Yeah. Thank you, madam. At the outset, I thank the organizers for giving me the opportunity to chair this session, where the speaker is Dr. Alim Chandani, who was my first teacher in psychiatry at IMH. It is a real honor to preside over this session. The topic chosen for today, all the topics are excellent topics, and this one in particular has a lot of practical significance. It is very difficult how much to investigate, when to investigate, the costs involved. There are so many factors in deciding what investigations to be done, both physical and psychological investigations. And the organizers could not have chosen a better speaker than Chandani, who combines vast theoretical clinical knowledge and at the same time a lot of clinical experience too. We are very fortunate to have him today. And the investigations in psychiatry are, most people say, what is there to do in psychiatry? What investigations you will do? But the first condition in psychiatry is we have to exclude all medical causes before going for a psychiatric diagnosis. That is always there. So this is what I think a lot of postgraduates may be listening to this, and it should be emphasized that excluding medical causes is a very important thing. And so also substance abuse also. If you look at DSM-5 criteria, they will automatically include these things, right? So let me introduce Dr. Alim Chandani in a more formal manner. Can you put the slide, please? Slide. Okay, I can talk without asking him. Dr. Alim Chandani graduated from Kakatiya Medical College, Warangal. He was about 3 years junior to me. And then he took MD Psychiatry as a choice. Those days, not many were doing psychiatry. I think he was the second batch of alumni from IMH Hyderabad. First few MDs from IMH Hyderabad. And he worked as assistant professor for quite some time. About 10 years ago, he left the government service and joined the private sector. Presently, he is working as a consultant psychiatrist in Apollo. Fortunately, the Apollo started psychiatric PG services, so now he is head of Department of Psychiatry and is back to his teaching, and his stamp of teaching is always there. Thank you, and I request Dr. Ashok Chandani to give his talk.
Thank you, Dr. Keshav Rao, for your kind words. I would like to begin by thanking the IPS Telangana State Branch and the organizers, Dr. Ashok Reddy, for asking me to come and deliver this talk. In a way,
Ashok Reddy was insisting that this is a kind of a comeback talk for me, because I'm coming back into the loop after a long time. And the topic he has selected, I think all the topics of the session, as Dr. Gangadhar was mentioning in the morning, have been very nicely chosen and very topical and relevant. And this particular topic that he has, this particular topic that Dr. Ashok Reddy has chosen, I understand it was Dr. Gauri Devi's idea. This is not something we routinely discuss. In fact, to my knowledge, at least in Telangana, this is the first time we are taking up any topic like this. But it is certainly relevant to our times. See, if you go back into history and see how psychiatry has evolved, originally it was non-medical. It was actually run by businessmen who used to run psychiatric institutions. But slowly, and then philosophers, all kinds of persons, psychoanalysts used to rule the roost here. But somewhere down the line in the early 20th century, when it became apparent that psychiatry was also one more medical specialty, and we have come into the mainstream. Now, the practice of medicine and the practice of psychiatry are not very different, in the sense that both follow the similar process of assessment of the patient. There's a particular protocol which has evolved over a period of time and which has stood the test of time, where you talk to the patient, assess the patient, and then take the history, do examination, and so on. But somewhere down the line, the technology has exploded, and there has been an explosion of medical knowledge. Medicine has come to become more and more reliant upon the laboratory investigations as more advances keep occurring. More and more you're depending on laboratory tests for coming to a diagnosis. This is, however, the psychiatric interview, it actually differs from medical departments in many ways. See, there is an expectation that in the future, all medicines, doctors may be redundant. You may have computers taking over. You just give a blood sample or something, and you'll get your diagnosis and the treatment and all that. Artificial intelligence, whatever you call it. There's even talk of chat bots. That is, robots will do a chat with you and do some counseling services for you. But in spite of all that, there's many things you need to remember about the psychiatric interview. For that, I would like to take you back to the basics. I think I've kept the talk very simple and very basic. Yeah, right. See, we tend to forget that sometimes when you become too investigative oriented, we tend to forget certain basic things. First and foremost, we need to always keep in mind that a psychiatric interview is patient-centric. It is not disease-centric. This is true of in all departments of medicine, but particularly true in psychiatry, because the patient doesn't have the resources to understand himself, his illness, and knowing the person is also equally important as knowing his disease. So whenever we are trying to evaluate a patient, we should keep in mind that we can never be too much dependent upon investigations, that investigations only add on to our knowledge about the patient and help us in this way. The first goal of the psychiatric interview essentially is to make a formulation of the biopsychosocial database for arriving at a diagnosis and a treatment planning. So all this is important, the biological part, the psychological part, and the sociological part. So when you're assessing the patient, depending too much on investigations may not be that useful. It is also important that you foster a therapeutic alliance and for a long-term relationship that you need to maintain. And along with this, your goal should be to have the patient to gain a better understanding of himself and of his illness, right? So having said this in mind, I think investigations should only be add-on to this and cannot be a substitute for that. In spite of that, of course, as Dr. Keshar was mentioning, we need to do testing in laboratory testing in psychiatry. I'll be first talking of laboratory tests, and then later on I'll be going on to cover the pattern of psychological tests, and then lastly I'll touch a little bit upon practice guidelines and their importance in psychiatry. Now, laboratory testing is required for us to come to a diagnosis. As we all know, there are a lot of overlap between psychiatric illnesses, medical illnesses. Our goal is always to rule out organicity first, as Dr. Keshar was pointing out. So that is why laboratory testing is required. Lab testing is essentially an extension of the clinical interview. So in that sense, it is also a part of the clinical interview is what you need to realize. So when you are doing lab testing, you need to be logical and systematic in ordering the tests in order to arrive at a diagnosis, whether medical diagnosis. So you are aiming at arriving at diagnosis. Also, we tend to forget that we are not just treating the psychiatric illness, but the person also comes with a baggage of medical comorbidities and medical illnesses. So when you are testing, you also have to keep in mind that you're not just aiming at diagnosis, but also have to test the patient as a whole. And for that, you have to select the appropriate treatment. We need to make a balance between unnecessary testing and inadequate testing. Well, it's easier said than done. In reality, there are so many factors. It depends upon the setting in which you are, where you are practicing. If you are practicing in an academic institution and you have a lot of resources available to you, you can go for all kinds of testing to get it. But in real life situation, in your practice, in a small individual practice in the districts, it may not always be possible to go for all the tests. Nevertheless, we always tend to have that dilemma whether to test or not to test. Now, beside coming to a diagnosis, we need to do laboratory tests for many other reasons also. Physical health monitoring of the patient. To just give an example, now you prescribe olanzapine left and right, such patients. Now, if you do not monitor his metabolic parameters, his blood sugar, or his lipid profile, you will end up with a person having a lot of problems. The patient is coming to you regularly, so it is your duty to also monitor physical health of the patient in the course of your treatment. That could be one of the reasons that you go for laboratory testing. Now, we also have to monitor during the course of the treatment for any complications that might come up. For example, if you are a patient on lithium, you need to monitor his serum TSH and creatinine. This is a well-known fact. But then how many of us do it in real life? You might always argue what's the big deal, most of the time it will come normal anyway. Some people will argue that it's so rare that renal problem, so why should I do the creatinine, why should I regularly subject him to that assessment. Now, see, in real life you do come across patients once in a while. I'll just give you an example. I had a patient who was on lithium for 20-25 years. Somebody, some psychiatrist in Nellore had prescribed. I told him that you need to take it lifelong. He had 2-3 episodes of bipolar, and he continued to take it for many years. He came to Apollo just to ask me, I've been taking this medicine for 20 years. I've been okay all these years. Should I take this medicine or no? Incidentally, I said, you just get your serum creatinine done and you show it to me. It turned out to be 2.8. Now, whom do we blame? Do we blame us, the psychiatrist who has not given him adequate information? So it's important that during the course of the monitoring also we need to do testing. For instance, apart from lithium, for say sodium valproate you are doing. Now we very often tend to neglect and just go on giving sodium valproate infinitely. We need to also test for the serum LFT, the liver function test, especially SGOT, SGPT. So if you do it, you will be able to detect in time before the person develops complications, hepatic complications. I remember Dr. Vijay Sheshadri telling in one of the meetings that, so many, he did a small study of sorts, and he found that so many, almost some 15-20% of patients receiving sodium valproate in the long term had elevated serum ammonia levels. That's because the liver was impaired, and we tend to neglect. We don't bother about it. So during monitoring, during the course of treatment is also something we need to be cognizant of and keep doing from time to time. Now, another reason that we need to keep in mind is the drug level monitoring. This is an important aspect of our monitoring of laboratory testing investigation that we need to do from time to time. Now, drug level monitoring, lithium, which is well known, of course. Most of us don't bother to do about it. One of the reasons could be that the lab reports of lithium are generally so unreliable that we tend to just give it a go by. And also, after initial evaluation of the serum lithium, it doesn't tend to change unless there are some changes in the renal functions or other functions. So by and large, remains constant. But then, sodium valproate, for instance, drug level monitoring, the patient is not responding to a certain treatment. you go for the drug levels, and then you know these inadequate doses are being given. So drugs like sodium valproate, even carbamazepine, lithium, you need to do the drug level monitoring depending on what the clinical situation. And of course, these days even even for clozapine also, it is now being said that clozapine, we still do not have it universally available, easily available in India, though I understand one or two places you are having clozapine levels to monitor. Of course, there's a lot of controversy about this clozapine monitoring. The purists who say that only clonazepam should be given, they said that a level of 100 to 200 nanograms is required. But then if you see the other guidelines, we say where clozapine is given as an add-on to the other antipsychotics, then the question of clozapine levels, even if they do not reach that required therapeutic level, there is some improvement in the patient. Practically, we are seeing. So we are sometimes left in a dilemma whether to do or not. But nevertheless, drug level monitoring is something should be in the back of our mind during the course of a long-term treatment of our patients. Next, I'll just talk briefly about urine and drug screening for substance abuse. Now, normally, screening for substance abuse is normally done by World Anti-Doping Agency for athletes before Olympics and all that. So, to detect if somebody is taking drugs surreptitiously, it is a good thing to do. But what a trend we are noticing, I have seen at least in a lot of places, it has become a sort of a routine thing you are doing without applying your mind. Every patient, even if the patient says, I'm taking cannabis, I've taken meth 1 week ago and I took cannabis, you still send for a urine screen as a sort of protocol. There's no logic in sending for this kind of a thing. Of course, if the patient is just come out of a rehab center and you want to know whether he is surreptitiously taking or not, then a random screening of his urine would be appropriate. When we see the results, we also have to keep in mind there are a lot of false positives and false negatives for urine screening especially. And also we tend to forget that, you know, it is, there's only a certain period the drug will be available. If the patient has taken, say, cannabis 7 days ago, it is not going to reflect in his, in the urine test. Or if certain drugs, it is even as less as 1 or 2 days on the half-life, depending on that. The plasma half-life is something. So the false negatives, false positives, and the fact that the timing of the test is also important. To just give an example of a false positive, I'll give an example of a patient we had in Apollo. She was about a 23-year-old girl. She was found unconscious in her house in the morning by her brother and brought to the hospital. And he was suspecting that she had a seizure. Now she was brought to the hospital, and then the intensivist did a urine screen for any overdose of any drug, for any drugs of abuse. He did a screen, and it came out positive as for benzodiazepines. The patient recovered subsequently. Then it was found the EEG was showing epileptic activity. And when I talked to the patient, she said she was not able to sleep well. So she took her father's sleeping tablet, and it turned out to be clozapine. Now, the clozapine, 1 tablet of clozapine she took. There were no benzodiazepines available in the house. And if she had taken benzodiazepines, why would that EEG be showing a seizure? Now, it turned out that she had taken that clozapine tablet, and that had reflected in the urine, because basically clozapine is a dibenzodiazepine. It's basically a dibenzodiazepine. So false negatives and false positives also something you need to be cautious about when you're interpreting such things. Now, apart from drug screens, we also need to do testing for safety before starting a drug. In our busy practices, sometimes we tend to neglect it. I think time has come and need to be a little bit more cautious, considering that people are also getting to know more about from the internet, and so safety protocols cannot be taken lightly. Safety for before starting drug, before you're starting any drug, say about 45 or 50 years, we don't bother at all to do the ECG even if you're starting lithium or quetiapine or any drugs which can prolong the QTC intervals. I think it's time we started taking up safety protocols for doing such elderly patients and particular drugs that might be, the safety might be compromised. Now, beyond this, then among the other tests that we do in psychiatry are protocol screens. These are something I think we need to incorporate into our practices. Say for dementia, a protocol is there. A person has come with dementia, you want to roll out whether he's got any treatable causes. So you automatically do those 6 or 7 tests, the blood urea, the serum B12 levels, HIV screening, whatever. This is not done very often by many of our practitioners. I think we need to be conscious about and start doing things properly. For example, a delirious patient is brought to the casualty. You should immediately do a delirium screen. You should have in the back of mind A, B, C, D, E, a protocol-based delirium screen you need to do. So this kind of practices will go a long way in improving the quality of our practice. I was actually searching the internet for the literature for studies on investigations, and in India I found a very interesting study. I think it's very interesting because it is actually reflecting the reality, what is happening in our ground reality in our practice in India. This study was done in Sri Ganganagar by D.K. Gupta et al., reported in the Indian Journal of Psychiatry. And what they did was, he has taken a team of people have gone to different psychiatric facilities, including a psychiatric hospital, a private psychiatric hospital, a medical college psychiatric OPD, a private medical college psychiatry OPD, and a private psychiatrist. And they pulled up all the patients just to see at the time of the patients who attended what investigations they had been subjected to. Very interestingly, 47% of the patients had had investigations done. Now, surprisingly, out of this, they found that 37% had had an EEG. Does this sound familiar? See, because it reminds me of a joke, they said about Edmund Hillary when he said, why did you climb Mount Everest? He was asked at a party. He is said to have joked, because it is there. I think some of us tend to do this EEG, this is being done just because it is there. In reality, how useful is EEG in psychiatric, that to 37% of the patients being subjected to EEG? I don't think even in a neurology OPD, 37% of the patients would be subjected to EEG. But okay, doesn't matter. 20% had been subjected to CT scan, that is still reasonable, and 8% had been subjected to MRI scan. See, I still remember Dr. Keshavan's lecture during the South Zone, when he had said that, for schizophrenia, you do a CT scan, why you are not doing, you should do. He was comparing it to, it's like a mechanic, you taking your car to a mechanic and him not even opening the hood to see what is inside and straight away proceeding to diagnose your car. It will not be acceptable to you. So CT scan, I can understand. But see the unfortunate thing, the last line, only 1.8% had had blood tests done. Now, we would expect that, in a psychiatric patient, at least you screen for thyroid, you screen for, you do a basic blood picture, something at least. Only 1.8% had this one blood test done. This is very unfortunate. So, why is it that, sometimes we are either investigating excessively, sometimes we are investigating inadequately. Maybe there are certain reasons for it. You can't blame the practitioner. Sometimes you have to do it just for a better credibility of your psychiatric diagnosis. Try to give an aura to the psychiatric diagnosis by doing a test. At least patients have begun to expect these tests to be done. In fact, I think all of you have experienced those kind of patients who come to you for a second opinion after having gone somewhere else. First thing they'll come is they'll take out the CT scan from the bag and they'll show you to, sir, is CT scan chudandi, even before telling the history or giving any complaints. They think that doing a CT scan is everything. So at least for that sake, to improve the credibility, some doctors might be doing it. And the perception among people that investigations are the gold standard. There's an expectation has come in psychiatry. We are still a far way from the point where investigation can substitute our clinical acumen. But nevertheless, this is happening. Very often it is a cover-up for inadequate clinical assessment. If you're not doing clinical, not having the time, you just send them, okay, you get this done. Instead of doing neurological examination, okay, you send for peripheral nerve testing and so on. Of course, the one factor that is probably responsible is aggressive marketing by these private laboratories. That in subtle ways it influences our thought process in ways that we may not be aware, and we end up writing just for the sake of whatever benefits you're going from that. Sometimes as a defensive medical practice, you are excessively cautious and you are want to be very careful, you end up doing too many investigations more than necessary. At the other end, at the scenario of where you are not doing inadequate tests, one of the important reasons could be that you are in a busy OPD, you are having to see about 50, 60 patients in the course of a day, and you are not spending enough time with the patients to even think of a diagnosis beyond your immediately apparent psychosis or whatever. You do not spending enough time to even think about ruling out organicity or whatever. Lack of awareness. Many the advances that are coming and the tests that are available. And of course, there's subtle bias in favor of lucrative tests that I already spoken about. Economic reasons. This is one reason many psychiatrists quote when you ask them why you're not doing enough testing. Why should I subject, is a poor fellow, is a village patient, how can you afford 500,000 for the test every time? See, it's easy to say that, but then when, if at all, God forbid, the patient has a problem, he develops renal failure because of lithium. The amount of expenses that he will have to spend on that, the anguish he will go through for that, is it worth it? Can we not give the patient the choice, okay, this is an expensive test, but this is good for you, you need to do it. So whenever economic factors are installed, it's a very tightrope situation. You can discuss with the patient and tell them, okay, these are the reasons, you still need to go ahead and get it done. And lastly, of course, reluctance of patients. Very often you write the tests, and by the next visit the patient is already better, so the tendency to just ignore the test. Now, how many of us have the guts to tell the patient, no, I will not renew your lithium prescription unless you get your creatinine done. It's already 1 year, you're not done your thyroid, you're not done your thing. Please get it done. Will you do it? No. But I think somewhere we need to be a little bit more firm in such matters. So, at the end of the day, should we do a test or not to do? I think this is one single question should be uppermost in our mind whenever you are ordering a test. Will the test alter the management? To just give an example, now a PET CT scan is available. Okay, for Alzheimer's dementia, it is not 100% pathognomonic, but you can get it done. But then you already done the urea levels, B12 levels, everything, MRI is done, and just because the PET CT scan is available, you are not going to do it. It's not going to change the management of the patient even if you do the PET CT scan. However, supposing the patient has got you are suspecting a depressive pseudodementia, whether this is a depressive pseudodementia or this is a Alzheimer's, in which case it's worthwhile to go for a PET CT scan. It is because it's going to alter the management. But every patient of suspected Alzheimer's, you're not going to ask for a PET CT scan. So this is the key question that we need to ask every time if you are in a dilemma about a particular test. Now, I'll just talk for some more time on psychological tests. Sending for psychometry is also important aspect of our psychiatric workup in the course of our regular practice. Many times, many doctors don't have access to that, they're not easily available, whatever it is, and the number of clinical psychologists is actually less than the number of psychiatrists in the country, and the quality of them also is not of uniform standard. Standards vary. So it's a, it's a difficult decision to take whether to send or not. But then, wherever it is required, you should not hesitate to send for psychological tests because it helps in clarifying the diagnosis. Just to give an example, supposing you have a 45-year-old businessman who's fairly successful, and then one fine day suddenly decides to wind up his business, and then he tells, no, I'm going to go into this particular new line of business which requires a lot of capital investment and all that. He seems very supremely confident, and he's very sure that he's going to succeed, and he has the sudden change in his behavior. Now the patient is also having, is not wearing his deteriorated personality, and he says, yeah, how did you come to know this? Yeah, this brainwave came to me and that's why I got it. So now you want to know whether it's manic episode, grandiosity, or whether it's a delusional episode. Such kind of situation, to help in clarifying the diagnosis, it is useful to send for a psychometry. Also to identify personality disorders, because access to disorders or whatever we call them, subtle organic problems. And more importantly, apart from helping clarifying the diagnosis, sending for psychometry very often gives us certain hints for doing psychotherapy by ourselves. No, if a particular patient is in front of you, the patient has not spoken. The psychometrist report will tell, yes, the patient is having a lot of troubles with her boyfriend or with the mother-in-law or with the exams or whatever. So these will give you hints which will help you in the course of your therapy with the patient, because therapy, even if not elaborately done psychotherapy, a little bit of therapy all of us do with our patients. So we can get some hints for that also from psychological tests. Sometimes we need to send them for quantifying the problem. For example, when you want to know the precise IQ of the person that you are assessing. So how do we go about referring for a psychological testing? A few thoughts in my mind that came to me, what is the best way to refer to a clinical psychologist? What is the best way to get bang for your buck, in other words? The maximum utility of psychometry that you can go. See, very often we seen a lot of people just signing psychometry, refer to clinical psychologists for psychometry. That is hardly an appropriate way to do it. See, clinical psychologists spend a lot of time with the patient. They are themselves busy, and so they also need to know what is the specific problem that you want for. So whenever you are referring to a clinical psychologist, it is good to pose a specific question. What is it you want from that particular psychometry? Yeah, I am looking for this patient has got an element of psychoticism. See, under our colleagues in medicine, they will prescribe, LFT, I want this test, I want that test. We can't tell the clinical psychologist, I want Rorschach, there are some psychiatrists who do that also. I want Rorschach, I want this, I want that, projective test or whatever. Rather than that, if you pose a specific question, what exactly you want from him, whether this is a delusional thing, what are the conflict areas that the patient is having, these kind of specific questions if you pose to the patient, the cognitive resources to stand for a trial, etc. This will be more useful, and a good report that will come from a clinical psychologist will not only formulate the assessment done, but at the end of the assessment, he will tell what all tests were administered and how the patient behaved in those different tests and what are the results that came out. And then he will give a good specific question to your, specific answer to your question with recommendations, what needs to be done. Now, very few clinical psychologists do this, but then the ones who do this, you know that you can rely upon them and you can trust them. They're very useful if you send for such kind of things. There are some clinical psychologists who give only scores. I mean, that really doesn't help us. Yeah, what's the use of knowing that the depressive HDRS score is 21 and this score is 17? It doesn't make sense. But we are seeing those kind of reports. So if you have liaison with a clinical psychologist who can give you this kind of proper report and you have a proper liaison with him, it's very useful in the course of your practice. Now, rating scales. Many of us, we are seeing the increasing use of rating scales all around us. On the net also, you have a lot of, you have, for example, a patient coming to you, he'll begin his statement with, doctor, he'll be a software engineer, he'll start with telling, off late, I'm having trouble with concentration. He'll begin that, and within 3-4 minutes, he's going to tell you that he thinks he has got ADHD and he wants a drug for ADHD. He will not be aware that, he's probably got depression or anxiety or something else. But the rating scales are becoming common, and thanks to the net, they are universally available everywhere. And even there are now wellness centers, the so-called wellness centers. Whenever a patient goes, just administer some rating scales, and the HDRS score is 21, refer to psychiatrist. This is not really going to help us. We have to understand that rating scales are primarily designed as a research tool for comparison purposes. When a drug is being tested or between two classes across time, before treatment, after treatment, what is the reduction in the score? That is not a diagnostic tool at all. But very often, unfortunately, it is beginning to be seen that way. MMSE scores are being given as if it is going to diagnose dementia. It is not. Of course, some psychiatrists are beginning to use this as a kind of a force multiplier. If you are having a busy patient, you are not able to spend much time with the patient. It's okay, OCD patient comes, okay, you're telling you fill in this Y box score while you're waiting. Patient's also happy with this, and you get to get some rough estimate. Though it's always better if you spend a few minutes with the patient and talk to him and know where exactly he's standing, then you can give him specific advice regarding those particular obsessions also, how to handle them, rather than knowing the overall Y box score or a Young's mania rating scale or whatever. So, no doubt, doing these rating scales will give patients a sense of participation in their in the clinical process, but I don't know. It's of really limited value, I feel. Though I do remember Dr. Majid Khan had once mentioned in one of the HPS meetings, and at that point of time he was saying that in the future is going to be in rating scales for all insurance purposes, for quotes and all that. You need to rate. So every patient who comes to your clinic, you'll have to do a rating scale for different tests. I don't know, personally I wouldn't agree with that, and my personal opinion is that rating scales have got limited use in the clinical setting. So a few words about practice guidelines. So at the end of the talk, I think we are nowhere where you want to decide what is adequate, what is not adequate. This is where practice guidelines begin to come into the picture. Now, practice guidelines are seen only in the last 30 years or so. They're not there before that. I think the with all the kind of advances that are coming and the knowledge that keeps on coming, it's difficult for an individual practitioner to keep up with the latest subject, and often that the reports coming in the literature are very conflicting. Sometimes it says one review says like this, one particular research says no, that is not true, this is correct. So we are coming to the era of evidence-based medicine, and evidence-based medicine is taking increasing importance in the era when insurance is going to come into the picture, courts are coming into the picture. The future will lie in evidence-based medicine, and you have to justify everything you are doing. Psychiatry also has come under the purview of insurance now. So in future, insurance companies also will be dictating terms. Why did you do this? Why did you not do that? Already we are seeing, I think this morning we were discussing about COVID, there was a WhatsApp message about COVID in one particular hospital. Too many tests were done which are not as per the government guidelines. Insurance companies have questioned. Now that is going to happen in psychiatry also. So that's where practice guidelines will come in useful. They assist physicians, also patients also in shared decision making. Now, how are these practice guidelines made? See, a lot of thought goes into the making of the practice guidelines. There's so much of explosion of literature. Somebody is assessing that medical knowledge is doubling every 30 months or something. The amount of research papers that are coming, that is a kind of explosion of knowledge that is coming. So how do you go about bringing all that into something clear-cut for the practicing person? The professional society, like the American Psychiatric Association or the Indian Psychiatric Society, they form committees and work groups. Oh, when you talk of committee, of course, small aside here, it is said that the arts college in Usmania University, the bottom line is, the bottom tier is built with the South Indian architecture, the middle layer is the European Greco-Roman, and the top story is done in the Saracenic style. So somebody is supposed to have joked and they must have put a committee to form that building. So committees can be very confusing at times because different persons have different opinions, and they have certain conflicts within the committee. Nevertheless, they come to a consensus, and that is present to the clinician. The problem with practice guidelines is, of course, they also, the actual guidelines will also mention the review of evidence, so it will end up to be such a voluminous document that the average psychiatrist sometimes finds it difficult to go through all to that. But nevertheless, we have to keep ourselves updated with practice guidelines for the sake of some standardization. Most of the practice guidelines are disease specific, and that is one of the limitations. Sometimes there may be problem specific, like what to do in the case of a, say, suicide attempt or something. Now, just to give a sample of what these guidelines can be, how they can be confusing for the average practitioner. Now, the guidelines for a major depressive disorder would say that you will have to do a diagnostic evaluation, you have to do a safety evaluation, you have to evaluate the functional impairment of the patient, you have to determine the treatment setting, where he needs to be treated, whether inpatient, he needs to be in a closed ward facility, can be treated at home, does he have enough supports at home. Then educating the patient's family, you're also supposed to educate the patient's family. You're also supposed to talk to him in a manner to enhance his treatment adherence and also help him with the early signs of relapse. Now, this sounds like a very tall order, but then this is how practice guidelines are. Somewhere if they come out with some even synopsis of this practice guidelines, it will be probably more useful for the practitioner. Now, there are certain advantages to guidelines. It at least raises the bar and ensures a minimum quality of care. That means people who are less competent, if they follow the practice guidelines, you are assured of a minimum quality of care. And there are variations in the practice from one person to another. A certain amount of standardization it takes place. It reduces stigma also, because very often if you tell the patient, now supposing a patient comes with depression, you want him to take the medicine for a longer period of time, says, no, I think 1 month I've taken, it's enough for me. If you tell him, no, the practice guidelines said you have to take for minimum 6 months and 2 years, it's become easier to convince him. And patients also can go and check the guidelines. In fact, I believe the NICE guidelines, Dr. Kesharo should tell me more about that. The NICE guidelines, when they are formulated, it's not just psychiatrists who are stakeholders in formulation of the guidelines, but the government groups, the patient support groups and all that. It can be a khichdi, but then it becomes easier to convince patient to take medicines. So it reduces the stigma having practice guidelines. But then there's sort of limitations also for practice guidelines. As I said, practice guidelines are such a elaborate process forming the guidelines that you can't do it every 6 months or every 1 year, whereas knowledge is all the time increasing. Comorbidities are not factored in. To just give an example, no, I've had a patient of depression. She has been taking treatment for the last 20 years, 60 years old, 20 years, she has been a recurrent depressive disorder, she is doing fairly well. She comes from a district. Now, somewhere, towards that, after a lot of time, she was not responding to the medicines. And so somewhere, one visit, then second visit, I noticed she is coming with a little bit of psychomotor with a bradykinesia and a mild tremor. Then I realized that she's got Parkinsonism. Now, if I were to stick to the practice guidelines of depression, I would have been stuck. The moment I saw, okay, so I give it a shot and said, let me try pramipexole instead. With pramipexole will not figure in the treatment of major depressive disorder anywhere, but we know that is useful for both depression and Parkinson's. And the patient has a dramatic recovery within 2 weeks. So the comorbidities are not factored in, practice guidelines being disease specific. So there are a lot of limitations. And also most important, they stifle innovation. They become a sort of, you become a prisoner of those guidelines, then you are in trouble. Because there might be certain knowledge you have read or something you have personally experienced in the past, which is not exactly in consonance with what the guidelines are saying. So you can do some out-of-the-box thinking to help an individual patient. That is not possible when you are stuck to the practice guidelines. So that is one thing. The biases of the committee members have seen a difficulty in implementing. So this is a few lines, a few words I thought I'd share with you about practice guidelines and the future of medicine. But at the end of the day, I would still like to say that we should not be too investigation oriented. And to quote George Engel, he's a person who has given us the term biopsychosocial model of disease. All of you know that. The clinical interview in medicine is virtually indispensable for the physician-patient interaction. The well-constructed interview may truly be regarded as the most powerful, most sensitive, and the most versatile instrument available to the physician. So with that, I'll conclude my talk. And before I conclude, I would like to thank the organizers for this opportunity, and also like to thank Team Apollo, Dr. Spandana, who has helped me in making the slides. Thank you.
Hello. Yeah. Thank you, Dr. Chandani. As expected, a very practical talk with a lot of experience sharing with us. And of course, time and again, he focused on the patient as a whole and the clinical interview. That message was given again and again. So though the investigations are important, a thorough assessment is not a substitute for more and more tests. And Dr. Chandani also mentioned about some practice guidelines also. Thank you very much. If you have, I'm not able to see the online thing, online questions. If there are any questions from audience, we'll take first.
No questions online.
No questions on the online. Yeah. Yeah. Any questions from within the group? All experienced people only. I think they have. If they are actually
more for the young
more for young practitioners,
students rather than for experienced
and
practitioners.
just I want to share one experience. My use of online scale. Actually, PHQ 9, which has 9 questions. It is available on app. I often give it to the patients in my clinic, and they score, and when the score shows 17, 18, your job is much easier. You don't have to convince that because it shows depression moderate. The person automatically agrees with the diagnosis. Otherwise, if the person may think the doctor has some interest in diagnosing me depression or keeping me in practice. So it might be helpful for some people to do a PHQ-9 which comes freely available. It is available in Hindi, Telugu also actually, print version. Okay. So, yeah. Because it is by
so
themselves.
we should make use of that.
Yeah. I also order, sir, 1 minute. I also do this ADHD rating scales from parents and teachers, because otherwise they may think somebody else will say, oh, the doctor, they always make a diagnosis of ADHD because they want to put you on treatment. But if the scale is done by them and by the
Then it's
teachers,
easier to convince them.
and a separate psychologist gives the report, then they will come, okay sir, we agree with you. So there are some advantages in doing this kind of tests also. Sir.
Actually, a lot of things you have talked about. I just want to share an experience that non-psychiatrists, they also use a lot of our rating scales, and they come to quick conclusions. For example, the community medicine colleague, assistant professor, published a paper that he has used HDRS. And then he found that some 23 or 33% of the medical students have depression. So is that not alarming? So the problem is that I'm sure that most of us
I did mention, certain wellness centers also using this scale and then coming to the conclusion that they are depressed.
Yes.
Somewhere it's
unless people are trained and their rating is known, I think they should not use it.
They actually use it as an inventory rather than a rating scale. They don't realize that HDRS is a rating scale.
Yes.
But it is just given as a questionnaire to them.
But publishing a paper on that, because the editor has not processed the paper, most probably, they have come to that conclusion.
So if there are no more questions, we conclude this session. Thank you, Dr. Chandani, once again.
I would like to thank Dr. Ashok Chandani sir for comprehensively and clearly depicting the balance between clinical skills and investigations in delivery of mental health services. I now request our chairperson, Dr. Keshav Rao sir, to present a memento to the speaker, Dr. Ashok Chandani sir. May I now request Rama Subba Reddy sir to present a memento to the chairperson, Dr. D. Keshav Rao sir. Thank you, sir. I would like to thank the speaker and chairperson of the session as well. Now let us proceed with the next session for the day. The next session is Holistic Approach to Management of Psychiatry in Reproductive Age Women. It will be a symposium. We have two speakers for the session, and I would like to invite Dr. Sudharani ma'am to the dais to serve as chairperson for the session. Our speakers will be Dr. R. Anita, MD, Professor of Psychiatry, Osmania Medical College. I would request ma'am also to please come on the dais. I would also like to invite the next speaker, that is Dr. K. Chaitanya Lakshmi ma'am, Consultant Psychiatrist, Gayatri Clinics, to the dais. To begin the program, let me give a brief introduction of Dr. K. Sudharani ma'am. She's MD Psychiatry, Professor of Psychiatry at IMH Hyderabad. She has done her MBBS at Kurnool Medical College and MD Psychiatry at Osmania Medical College. She has 10 publications in various journals. Her areas of interest include women mental health. Now I request Sudharani ma'am to introduce the first speaker of the day, Dr. K. Chaitanya Lakshmi ma'am.
Hello. So thank you very much for giving this opportunity. So today's speaker, Dr. Chaitanya Lakshmi, is a consultant psychiatrist of Gayatri Clinics, Hyderabad, and she did her DPM and MD from and MBA Hospital Administration, and she also had awards like second prize in post presentation in IPSOCON 2015, and Dr. S.M. Chennabaswanna Spandana PG Quiz Award, and her areas of interest are addiction psychiatry, psychiatric problems in women, and ketamine in psychiatry. So now I request Dr. Chaitanya Lakshmi to present her presentation.
A very good afternoon, all the delegates on the dais and off the dais. I would like to begin my session by thanking all my psychiatric teachers for giving all the psychiatric knowledge to me. So I would be dealing with biological management of psychiatric disorders in reproductive age women. So I'll be dealing up with the biological management. So why are we talking about women in specific today? That's because what happens when women are affected, it's the whole family that gets disturbed when women are affected. This is how the family would be. And what do statistics say? This is just about only about perinatal psychiatric disorders. It has been found that 10 to 25% of perinatal women are affected by psychiatric disorders, of which only 25% of them are appropriately diagnosed and treated. So we need to identify them early and treat them in order to reduce the disease burden. So this can be done by training the gynecologist to identify these psychiatric conditions early and refer them when needed. So during the reproductive age, which begins from the menarche and ends with menopause, any woman can face any psychiatric disorder, but today I would be covering only few psychiatric disorders that are seen very commonly. These are the conditions I am going to cover. So these are the reproductive time events where a woman is prone to fluctuations in her hormonal levels, and these are the phases where she is more prone to psychiatric conditions. So one is the phase of menstrual cycle, that is during the luteal phase she is prone to have premenstrual syndrome. She can have any psychiatric conditions during pregnancy like depression, psychosis, anxiety or OCD. Similarly during peripartum period, during breastfeeding, while she is on contraceptive pills, on infertility treatment or after hysterectomy where she would be devoid of her normal hormones, in gynecological cancers, and also in the perimenopausal period wherein the estrogen levels are reduced. So what to do when a woman comes to us? How do we approach a woman when she comes to a psychiatrist? So apart from the regular history that we take from any psychiatric patients, certain things which we have to focus here are, so the symptoms have to be taken in relation to the phases of menstrual cycle, whether they are more in the luteal phase, whether they are subsiding after the menses, or are they continuously present, and whether the symptoms have been present even before pregnancy, or have they started during pregnancy, or have they started after the delivery, and the time if they have started following miscarriage or abortion, or if they have started only just before menopause. and also about the history of sexual trauma or any physical abuse, because if that is causing the psychiatric conditions, we need to attribute those conditions, or else the psychiatric conditions will persist. Also, if there are any gender identity issues in her, also about the sexual history. So coming with with the onset of menarche, so women start menstruating. So what are the conditions that she faces? So mainly premenstrual syndrome and premenstrual dysphoric disorder are the two common things that women face. So these are the common symptoms that they face. Though they might be mild enough in most of the women, but they are not causing any distress to all of them. So only when it is causing distress to the person, we have to treat them. So in PMS and PMDD, they have both physical symptoms as well as psychological disturbance. So as the hormones change, similarly serotonin levels also tend to fluctuate in women. So just before the onset of menses, that is during the luteal phase, there is a fall in the serotonin levels. So the serotonin levels fall before the menses during the luteal phase, and again with the menses the serotonin levels normalizes. So as the serotonin levels fall, they tend to become depressed, anger or anxious. So with the onset of menses, so since the serotonin becomes normal, the symptoms will subside. So what to do when a woman comes with premenstrual complaints? First, we need to rule out any other medical conditions. These are the common medical conditions which might cause symptoms similar to premenstrual syndrome. So we need to rule out endometriosis, fibrocystic breast disease, migraine, where the headache tend to be more common during the time of menses. Use of caffeine, alcohol, nicotine, they tend to worsen the psychiatric symptoms. Even hypo and hyperthyroidism can also cause diabetes, chronic fatigue syndrome, and anemia. So based on the proper history and necessary investigations, we can rule out these medical conditions. After ruling out the medical conditions, if they look for any other psychiatric condition, underlying psychiatric conditions. If the symptoms are not cyclical, then we need to find if there is any other psychiatric conditions. So how do we chart? We ask her to chart the symptoms on either of these scales. So usually we need to chart the symptoms over at least 2 cycles to diagnose it as premenstrual dysphoric disorder. If the symptoms are present continuously without any relation to menses, then it should be considered as an underlying psychiatric disorder. Of course, there can be premenstrual exacerbation in many psychiatric conditions. But if the symptoms are present only during the premenstrual phase, predominantly if they are physical symptoms, it should be considered as premenstrual syndrome, and we need to treat with conservative approach. We'll deal later. If they have both mood and physical symptoms which are severe enough to interfere with the functioning, and if they improve with the menses, consider it as premenstrual dysphoric disorder and treat accordingly. So these are the non-pharmacological treatments for premenstrual dysphoric disorder. We advise them to reduce consumption of caffeine, alcohol, salt, increase consumption of complex carbohydrates. Also, we ask them to take smaller quantities of carbohydrates frequently. Coming to pharmacotherapy, so in PMDD, the drugs can be given either continuously or intermittently. Continuous treatment is just like any other psychiatric conditions. This is preferred when she has a comorbid depression, anxiety, or if she is non-compliant to intermittent treatment, or if the symptom duration is variable, if she is not able to localize the symptoms properly. The advantage with this is more effective, but we are exposing her to drugs for a long period of time, thereby making her prone to adverse effects. In intermittent luteal phase dosing, we start the drug during the luteal phase, that is the 14th day of the cycle, and stop it with the onset of menses. In this way, we can reduce the adverse effects. In PMDD, symptoms usually improve within 2 to 3 days of treatment, unlike in depression. So what drugs can be given? SSRIs are usually given. American College of Obstetrics and Gynecology, they suggest first line of treatment to be SSRI. And the dosage of drugs is similar to that of major depressive disorder. And the FDA approved drugs are fluoxetine, paroxetine and sertraline. Recent data also support the use of desvenlafaxine in dosage of 50 to 200 mg in divided dose. What if SSRIs don't work? We can go for second line treatment, that is GnRH agonists, which is also here the symptoms are because of ovulation. So we are creating an anovulatory cycles by giving GnRH agonists. So this reduces the levels of estrogen and progesterone. So this can be done by giving intranasal buserelin in 400 to 900 milligrams per day, or intramuscular leuploride in 3.75 to 7.5 milligrams. It's given as a once in a month injection. So by giving these medications, she'll be devoid of estrogen. So this will cause symptoms similar to perimenopausal period. So if those symptoms, postmenopausal symptoms are appearing like hot flushes, then we need to give add-back therapy with low-dose estrogen and progesterone. Other option that we have is danazol into 400 to 400 milligrams per day. In those women who also want contraception, oral contraceptives can be given, which helps in improving PMDD symptoms, as well as they also work as contraceptives. Ethinyl estradiol in dosage of 200 micrograms combined with drospirenone in 3 milligrams. It's usually given in 25/4 regimen, where the drug is given for 24 days and a gap of drug-free gap of 4 days is given, and again drug is restarted. These improve both physical as well as emotional symptoms. So as we have previously seen the scales, this is one of them. This is called as Calendar of Premenstrual Experiences scale. Here the woman starts scoring her symptoms with the onset of she starts chatting from the day 1 of her cycle, and she has to rate her symptoms on a scale of 0 to 3. So the score on the days 3 to 9 is considered as the score for follicular phase, and the score on the last 7 days of cycle is considered as luteal phase score. So we take a total of it. So if the follicular phase score is more than 40, then it indicates some continuous psychiatric disorder. Whereas if the follicular phase score is less than 40 and the luteal phase score is more than 42, it is suggestive of premenstrual dysphoric disorder. Usually we find that in PMS and PMDD, the luteal phase score is more than 30% of that of follicular phase score. So if they don't improve with SSRIs or with contraceptives or GnRH agonists, we can combine both of them. If even that doesn't help, the final option would be oophorectomy. If she is okay with that, after taking consent of the patient and her husband, we can go for oophorectomy if they are very troublesome symptoms. So if a woman with PMDD is on treatment with SSRIs, is going to plan for pregnancy. So meanwhile, we need to discuss the effect of these drugs if she becomes pregnant. Of course, we'll stop them with pregnancy, but what would be the effect? So we need to discuss the risks and then continue the medication. So when the woman is approaching menopause, the cycles will become irregular. So we can't identify when is the ovulation and all. So there we give symptom onset dosing. That's about premenstrual dysphoric disorder. Now coming to pregnancy. Here whenever we are treating a pregnant woman with psychiatric disorders, we need to keep in mind both the mother and the baby while giving the drugs. So what are the general principles for prescribing during pregnancy? So usually it is said that when they have mild to moderate illness, it's better not to start her on any medication if that's possible. Go with non-pharmacological methods. Only if she is having severe illness, then weigh the risks from the medication and benefits of taking medication, as well as the risk from the illness, and discuss this with the patient and her husband. If they agree, only then start the medication. As far as possible, avoid all drugs during the first trimester. And when we are starting the drug, start with lowest effective dose, minimize the number of drugs. If she is on medication and if she is not improving adequately, or if you suspect any toxicity, go for plasma level monitoring of the drugs. fetal screen, if the drug is prone to cause teratogenic effects, go for fetal screening by 2D echo and anomaly scan at 20 weeks of gestation. And also we need to monitor the baby at the delivery for any withdrawal effects. And all decisions when we are treating a pregnant woman have to be documented to avoid any legal problems in future. So treatment in case of pregnancy and delivery, it has to be collaborated with the obstetrician as well as the pediatrician who is going to attend the baby at the time of delivery. So collaborative care approach is very much important in these cases. So when a woman with psychiatric disorder who is on treatment is planning for pregnancy, this is the ideal time where we can discuss the kind of treatment that she accepts or asks for, to be continued during the pregnancy. So this is preconception counseling. So during the preconception counseling, what do we discuss with the patient? First thing, we should explain the risk with any natural pregnancy, that is 1 to 3% risk of anomalies is possible. We should also explain the risk if we don't treat the illness and the risk with the treatment. And the risk with the medication has to be explained in terms of frequency, not as percentage, but simple terms where they can understand easily as 1 in 100 or 10 in 100 based on the drug. So if she is already pregnant and if she is maintaining well and there is less chance of relapse, then we can stop treatment. However, if there is a past history of relapse with discontinuation or if she is not yet stabilized, then we need to continue the treatment. In case of antepartum depression, if she has been previously treated, it's always preferable to use the same drug for which she responded previously. If it is a new episode, in mild to moderate cases, psychotherapy would be sufficient, whereas in severe cases, we have to start her on antidepressants. However, American College of Obstetrics and Gynecology guidelines suggest use of antidepressants even in mild cases. So, among SSRIs, sertraline is preferred because it has least placental exposure. Others can also be used except paroxetine, which is prone to cause cardiac anomalies when it is given in dosage of more than 25 milligrams per day during the first trimester. And always a hospital delivery is a must in these cases, and the neonate has to be observed for at least 3 days after the delivery in a hospital. So what are the risks with SSRIs? One is poor neonatal adaptation. So after delivery, the baby might be having excessive cry, feeding difficulty, or sleep problems might be there. And other one is preterm delivery. So one good article by Dr. Chitranjan Andade where he says that with SSRIs, the chance of preterm delivery is there, but usually it is only a few days earlier. So we need to weigh the risk of delivering a baby a few days earlier versus not treating the woman. So he says ideally it's better to treat even though the baby is delivered just a few days earlier. And when SSRIs are used in the 3rd trimester, there is a chance of primary pulmonary hypertension in the baby, low birth weight, postpartum hemorrhage, and preeclampsia. Coming to tricyclic antidepressants, nortriptyline and desipramine are safer because they have low anticholinergic adverse effects. Doxepin and MAO inhibitors have to be avoided in total. So we can see that SSRIs and TCS can be used except doxepin, MAO can be used, and in resistant cases we can go for ECT. Only if ECT doesn't work, then only we can go for combination therapy. Categories where all SSRIs are category C except paroxetine. Among TCS, they also belong to category C. Bupropion belongs to category B. Coming to antepartum psychosis, when a woman comes with symptoms of suggestive of psychosis, we need to ask her for any past history of similar complaints during earlier pregnancies, family history of antepartum and postpartum psychosis, and her personal history of antepartum as well as postpartum psychosis, because they are prone to have high risk of relapse and they have to be treated seriously. During pregnancy, the antipsychotics that are safer are quetiapine, olanzapine, risperidone, and haloperidol. However, with these 2nd generation antipsychotics, there is a chance of high birth weight, gestational diabetes. So she has to be monitored for gestational diabetes by oral glucose tolerance test. Avoid depot preparations and anticholinergics during pregnancy. And depot may be used only if that's the only chance we can keep her well in the perinatal period. First generation antipsychotics can also be used, but they can cause neonatal dyskinesia, neonatal jaundice. So antipsychotic discontinuation after delivery can lead to crying, agitation in the baby, increased suckling. So even with antidepressants with discontinuation after delivery, there can be withdrawal effects. So how to deal with that? So once the baby is delivered, the amount of drug the baby is exposed from breast milk is less than that the baby was exposed while in the womb. So we shift from breastfeeding to mixed feeding, and then we shift to top feeding. So that will cause gradual decrease in the levels of drug exposure to the baby. So these are the pregnancy categories. We can see most of them to be category C. In case of bipolar disorder in pregnancy, here antipsychotics are preferred over mood stabilizers because most of them are teratogenic. If at all lithium has to be used, it's preferable to avoid in the first trimester because of the risk of Epstein's anomaly. However, recently it has been found that though it was previously not used much, but the risk is minimal, can be used if it's possible to monitor properly, and if at all it is used, go for a 2D echo at 20 weeks of gestation, and lithium level monitoring is necessary. It has to be monitored once in a month up to 36 weeks, then weekly up to the end of the labor. And it has to be stopped with during labor, and check the serum levels 12 hours after the last dose. Immediately after the delivery, we can start with pre-pregnancy dose. With lithium, baby can have neonatal goiter, hypothyroidism, lethargy and arrhythmias. And carbamazepine and sodium valproate totally has to be avoided. France has banned the use of valproate in all reproductive age women. If at all the woman can be stabilized only with carbamazepine and not with other drugs, then we should be ready for vitamin K prophylaxis to both mother and baby after delivery. If the woman comes in acute manic episode, then we should give her injectable antipsychotics, or we can go for ECT. In bipolar depression, combination of cognitive behavior therapy along with SSRI or lamotrigine. Lamotrigine is safe, but its levels have to be monitored because the clearance increases during pregnancy and it reduces after delivery. Coming to the postpartum period, so the baby is now delivered, so it's the mother we are treating, and also because the baby will also be exposed to the drug through breastfeeding. Here we need to compare the risk between feeding the baby versus giving the drug. So during this period, it is advisable to give only those drugs where the relative infant dose is less than 10%. So it is the ratio of the concentration of drug in the baby's plasma versus maternal plasma. It has to be below 10%. It's always safer to continue the drug that was used during pregnancy to avoid withdrawal effects. If the drug is contraindicated during breastfeeding and that is the only drug which is suitable for the mother, then continue the drug and stop breastfeeding. But we have to discuss this with the patient, and only with her consent we can do that. And always use drugs which have a short half-life. Similar to pregnancy, avoid polypharmacy, use lower effective dose. So we need to monitor the infant carefully when the mother is on psychotropics. So the things to be monitored are hydration status of the baby, feeding of the baby, weight gain of the baby, and sedation if it is excess or not. Also, if necessary, if we are suspecting any toxicity, monitor for infant plasma levels. This is the table showing Hale's lactation category of antidepressants. L1 and L2 categories are considered to be safer compared to L3, L4 and L5. When a woman comes with depressive symptoms after delivery, how do you approach the case? So you know that she is having depressive symptoms, and then we need to see how severe are the depressive symptoms. So we can go with scales like Edinburgh Postpartum Depression Scale, also Postpartum Depression Questionnaire, and if you suspect any symptoms of mania or hypomania, go for Mood Disorder Questionnaire. So if she just has mild symptoms of depression and which are not disturbing her much and are of short duration, and if it comes under the diagnosis of postpartum blues, here we need not start any medication, just support is enough. Also educate her family members that providing adequate support to the mother in the baby care and reassuring her would be enough. And also we need to monitor her if it is progressing into unipolar depression or bipolar depression. If the symptoms are severe enough and are beyond 2 weeks, then it is considered as postpartum depression. If it is a unipolar depression, the drugs which are safer are sertraline, paroxetine and nortriptyline. Paroxetine is one drug which can't be used during pregnancy but can be used after delivery. If it is a case of postpartum bipolar depression, here we can use a combination of mood stabilizing antipsychotic along with antidepressant, and lamotrigine can also be used here. Postpartum psychosis. It is a psychiatric emergencies. Here there is a risk to the baby also. Some cases the woman is harmful to the baby. So here early identification is needed, and here hospitalization is a must. And we need to rule out organic etiologies like Sheehan syndrome, postpartum thyroiditis, pregnancy related autoimmune disorders, HIV, intoxication and withdrawal from drugs. So we need to do the necessary investigations and rule out these. Then if it is an acute case, you can use antipsychotic. And postpartum psychosis is considered under the spectrum of bipolar disorder. So mood stabilizer is also needed here. Olanzapine and quetiapine are safer during lactation. American Academy of Pediatrics suggests valproate and carbamazepine to be compatible to breastfeeding. So these can't be used during pregnancy but can be used during lactation. Lamotrigine can be used, but we should be very cautious because it can cause high plasma levels in infant. Lithium is generally discouraged during lactation because if the baby develops fever and dehydration, toxicity chances are very high. If at all she is very much agitated and she needs to be controlled early, we can use lorazepam injection or haloperidol injection to calm her. Other antipsychotics which can be used during breastfeeding are chlorpromazine, haloperidol and risperidone. For rapid improvement, ECT can be used. If it is a first episode psychosis, the treatment has to be continued for 1 year. If it is a second episode, then long-term treatment might be needed with mood stabilizer. In refractory cases, we can go for ECT. If the woman seems harmful to the baby, then advise her not to breastfeed the baby and keep the baby away from the mother. Whereas in cases of depression, where the chances of harm to baby is less, the mother and baby have to be kept together, whereas here they have to be separated. Also, we ask those women to avoid breastfeeding at night because sleep disturbance can worsen psychosis. If at all she is using lactation suppressants, which are usually dopamine agonists, be careful that there can be aggravation of psychosis. Course and prognosis. If it is an affective psychosis, which is brief psychosis, prognosis is good. This has a very high chance of relapse. Relapse rate in subsequent pregnancies is 25 to 40%. So we need to educate the woman after delivery, at the end of the treatment, that in subsequent pregnancy there is high chance of relapse. Early treatment within 1 month has very good prognosis. This is a summary of drugs that can be used during pregnancy and lactation. During pregnancy, sertraline, nortriptyline and desipramine can be used. Among antipsychotics, olanzapine, quetiapine, risperidone and haloperidol. Among mood stabilizers, antipsychotics are preferable. Among sedatives, promethazine is preferred. If at all that's not helping, we can go for short-acting benzodiazepines. In lactation, antidepressants that can be used are sertraline, paroxetine. Among antipsychotics, olanzapine and quetiapine can be used. Mood stabilizers, valproate and carbamazepine. And for sedation, short-acting benzodiazepines. So previously we had the FDA labeling. So recently in 2015, the new labeling has come. This is pregnancy and lactation labeling rule, where additional third category, section 8.3 is added. So in the first two categories, first section it's about pregnancy exposure registry, And the risk summary has to be given, the clinical consideration, and human and animal data from research data has to be provided. In section 2, lactation related data is provided. In section 3, if at all the drug has any effect on fertility of male or female, that has to be mentioned here. Also, if there is any need for contraception or pregnancy testing while using the drug, that has to be mentioned. So all the drugs which has manufactured after 2015, they have to follow this. Coming to the perimenopausal period, so that's the period where the woman's reproductive function is almost coming to the end. The estrogen and progesterone levels are coming down. So here she is more prone to develop, and also apart from the hormone levels, there are multiple stressors in the family life also. This is the period where her children leave her, so that would be an additional stress, and she is prone to more psychiatric disorders. And commonly they are prone to depression, sleep disturbances, anxiety. But there can be chance of exacerbation of mood disorder and also psychosis. Apart from the regular history, we should also take about the history regarding the psychiatric symptoms during the other reproductive events, any recent stressor, her strengths and liabilities. So in menopausal women, a cycle of symptoms take place, that is vasomotor symptoms which lead to sleep disturbance, that in turn leads to mood symptoms. So we need to break this cycle. So how do we manage them? SSRIs and SNRIs are preferred treatments. Among the available drugs, desvenlafaxine, duloxetine and escitalopram are beneficial. These have been supported by many studies. Antidepressants reduce both vascular symptoms as well as psychological and somatic symptoms. Whereas we can, apart from SSRIs, estrogen replacement can also be done. Estrogen reduces only the vasomotor symptoms and sleep disturbance, but underlying psychological disturbance are not addressed with that. If only antidepressants don't help, we can give a combination of hormone replacement therapy and antidepressants. This reduces depression and improves the quality of life. So in refractory cases, we go for combination therapy. How long do we ask them to take the medication? So they have to take these medicines for at least 6 to 12 months period of wellness. For sleep, we can use zolpidem. So I conclude by saying that regular screening of antepartum and postpartum women for psychiatric illness is needed by simple questions, which can be done even by the obstetrician and gynecologist. We have to train them for that, and early initiation of treatment is needed for all those at risk. And collaborative care approach is very much important and needed. And for perimenopausal symptoms, desvenlafaxine, duloxetine, escitalopram are beneficial. These are my references. And Maternal Mental Health Week awareness is May 4th to May 9th. See, this picture says that these women are discussing that they were not prepared for the complications that arise after delivery. They were just told that you will deliver, you have to take care of the baby. But what to do if baby doesn't sleep? What are the psychological problems they might face? All these things have not been told by the elders in the family or by the treating doctors. So lack of preparedness makes them more prone to psychiatric illnesses. So apart from treatment, prevention is important, for which preparedness of the woman plays a major role. Thank you everyone for patient hearing. I would like to thank organizing committee for taking me for this session, and a special thanks to Gauri Devi madam who has suggested my name. Thanks everyone.
Thank you ma'am for the comprehensive presentation. I would now request the chairperson to introduce the next speaker of the session, Dr. Anita ma'am.
Thank you, Chaitanya Lakshmi. You have presented a very brief and focused presentation, including all the areas of women mental health, starting from adolescence to menopause. Now I introduce Dr. Anita Rairala. She is a professor of psychiatry at Institute of Mental Health, Hyderabad. She did her MBBS from Usmania Medical College and MD from Institute of Mental Health, Hyderabad. She had several years of teaching experience, and she is a recipient of Podur Ramamma Chinna Reddy award paper in consultant category in the year 2018. And she is involved in various public awareness programs like TV programs and
column writings in papers and all. Her areas of interest are forensic psychiatry and neuropsychiatry. I request Anita to present her.
Firstly, I would like to thank the organizers for giving me this opportunity, and special thanks to Dr. Ashok Reddy sir and also Gauri Devi madam for entrusting this topic on me. Can I start? Yeah, I was asked to talk about psychosocial. I was asked to talk about the psychosocial management of psychological disorders in reproductive age group females, and also a special focus on legal implications. used in pregnancy. So in this method, it is usually delivery without analgesics and anesthetics. Oh, it's gone. Yeah, it is delivery without analgesics and anesthetics. Nowadays, we can't even imagine delivering a baby without analgesic or an anesthetic, but it is possible because it is followed in many countries. Like the women will be fully conscious during delivery, because before delivery, during the antenatal period, they are trained with breathing exercises and relaxation practiced by both prospective parents. Both husband and wife come for the counseling sessions and they practice this relaxation techniques during the classes. And they are allowed to deliver the baby without using analgesics and anesthetics. And women report minimal pain during labor and delivery. They have found that it is very, very effective, and women are delivering without any problem. And there is one more technique called Bradley method, where husband coaches the wife to give childbirth. So husband will be trained and also made to be with the wife in the operation theater, and husband will ask his wife to relax and then deliver the baby. So this is found to be very effective, but I don't know this will be practiced in India. And the caution here is, you should not use this technique when the husband itself is a stressful factor for the women. Please don't use this technique when she is stressful about the presence of husband. And second important therapy is cognitive behavior therapy. So in this therapy, usually in pregnant females or after delivery, they have a lot of negative views. Okay, like negative thoughts like I'm a terrible mother, or I should know how to comfort my baby, and my baby doesn't like me. So there can be negative views of self, or negative views of others, or about future. So these different types of negative views can be there. And the cognitive behavior therapy is focusing on these thoughts, which are cognitive distortions, because these negative thoughts result in negative feelings, and these negative feelings result in abnormal behavior, and this abnormal behavior again causes negative thoughts. So it is a vicious cycle. So CBT focuses on these three important areas. So say for example, after delivery, there is a life situation, like she's a new mother, for the first time she delivered a baby, and the baby is very, very fussy, and it is very difficult to feed her and difficult to put her to sleep, and the partner doesn't give support because he is working for long hours. So what is the, and she goes into a state of depression because there's no support for her and she's unable to handle the baby. Those are the main important factors which are pushing her to depression. So the thoughts associated with this situation is, I'm a terrible mother. So she ends up having a thought that she's a terrible mother. And then the associated emotions are, she feels sad, empty, trapped and hopeless because she went into depression because of that. And because of that, she has behaviors like social withdrawal. She doesn't talk to anyone, and she's not motivated to work, and thereby causing body responses like fatigue, heaviness, low appetite, and low sleep. And again, this results in a thought that she's a terrible mother. So it's a vicious cycle. So unless a cycle is broken, she will not improve from this negative thought. So there are some cognitive distortions which are commonly seen in depression. Cognitive distortions are nothing but cognition is thought and distortion is abnormal thought. Okay? And these distortions are repetitive in her life. Say for example, there are some 20 or 30 cognitive distortions, but there are some distortions which are commonly seen, like negative mental filter. So a woman can have a negative mental filter where she picks up only negative situations or negative things which are going around her, and she in fact doesn't care about positive things going around her. So it is called as a negative mental filter. She picks up only negative thoughts. Or it can be overgeneralization, like I can't feed my baby properly, that's why I can't do anything right. That is overgeneralization. Or sometimes labeling. and should statements like I should do this, I should do that, or else I'm a failure. So these kind of should statements are also one kind of cognitive distortions. And then mind reading. So people might be thinking that I'm a terrible mother because my baby is not falling asleep properly. That is a mind reading. You are reading the mind of others. Whether they are thinking like that or not, you don't know, but you feel that they are thinking like that. So that is mind reading, which is also a cognitive distortion. So there are other cognitive distortions. There are many, many cognitive distortions. Say, for example, there is a thought that I'm a terrible mother. It is a labeling. Labeling is terrible is a label you are giving to yourself. So it is labeling. So if you label, you start believing it and you feel very bad about it, you go into depression. So this labeling should not be done. And another thought is, I should know how to do that. She is my baby. So should statements. This should statements, I should know this, I should know that, or else I'm bad, I'm failure. So this should statements is the thinking trap. Thinking trap is nothing but cognitive distortion. So should statement is a cognitive distortion here. And then I can't satisfy my baby properly. I don't know how to do it anything right. This is overgeneralization. Because I can't do one thing, I think that I can't do anything. So these are so first we should identify the thought, and then we should identify the cognitive distortion which is associated with the thought. So after identification, what are you going to do? You know that she's having negative thoughts, you know that she's having some distortions. How do you deal with it? Okay, so we have to turn that cognitive distortions into healthy thinking. How are you going to do that? How are you going to do that? Number one is catch your depressive thoughts and get them down on paper. You have to write all your thoughts, negative thoughts on paper, because they give objectivity, and you can always check and recheck whether you are doing it correctly or not. So put them on paper and then identify any thinking traps or cognitive distortions in your recorded thoughts. So you have to identify what exactly the cognitive distortion you are having. Next, challenge the depressive thinking and replace it with more healthy thinking. So after identifying, you have to replace. Okay, for example, there is a big bad bedsheet in your house. What will you do? You throw the bad bedsheet and you will replace it with a good one. The same thing. So you replace a bad thought with a good thought or a healthy thought, and make healthy thinking a habit. So if you repeatedly do the same thing and again and again and again, it becomes a habit. So slowly you will develop a good habit or a healthy thinking pattern. So this is how it looks. This is a chart. Okay, the woman is asked to write on this chart. Number one, first we should ask her to write about a situation, then depressive thoughts, what kind of thoughts she is getting, and what kind of cognitive distortion she is having, and how to question or challenge this thought, and what are the healthier thoughts. So for example, this you see, I'm a terrible mother. So here what is she using? She is using labeling as a cognitive distortion. She is labeling herself that she is a terrible mother. So you have to challenge the thought. So here the challenge is, I need to ask myself, what impact does calling myself names have on my mood, stress level and motivation? So is it helping me in any way, this labeling? I am in fact pushing myself more into depression. So it is not helping my mood, it is not helping my stress level and motivation. So it is better for me to stop this thought. Then I have to replace with a healthier thought. So what is the healthier thought? I have learned a lot of things. From the beginning, after delivery, I have learned many things. I didn't know how to feed the baby, but now I have learned. I didn't know how to wash her clothes, but now I learned. So there are a lot of things which I have learned. So you have to emphasize. She should emphasize that she had learned a lot of things after the delivery. And I do a lot to care for her. I care for her, which takes a lot of effort and love. So with effort, I will learn more things. So this thought, like terrible mother, is being replaced with a healthier thought with a positive note that in future, I'll develop more skills and I will become a good mother, or I'm not a terrible mother. So this healthier thought she puts. So after repeatedly doing this, the old thoughts will go off and they are replaced with new thoughts. So that is all about CBT. And CBT is found to be very, very effective in depression and anxiety associated with pregnancy or lactation or postpartum blues or depression. So in all these conditions, CBT is found to be very effective. And the second most effective therapy is interpersonal therapy. The beauty of interpersonal therapy, it is very discreet. We don't need to spend, years and years together on this. And it is time limited, structured, and focus on current relationships. So if you talk to a woman, she may be telling about her, childhood, how her mother was, like how her mother-in-law was during her marriage, what problems she faced, all this they must be telling you. But in interpersonal therapy, you focus on the current situation and the current problem. So we need not talk about the old problems. So there are interpersonal therapy is based, focused on 4 problem areas. So whatever like condition you take, whatever depression or anxiety you take, every person will have this, they fall into one of these 4 areas. Like it can be grief, the problem area could be interpersonal dispute, or it can be a role transition, or it can be an interpersonal deficit. These are the 4 only problem areas given by which you have to focus in interpersonal therapy. Okay, grief. What is grief? Is death of a loved one. It is usually prolonged grief, which we are going to address in IPT. So sometimes the grief can be without the loss of a loved one. The grief can be loss of virginity. The grief can be because now she has lost her youth because she's pregnant now. Some people take pregnancy as negatively, so they think that they have lost their youth. That is also one kind of grief. Or sometimes it can be, I have lost my, I have lost my femininity because I am now menopausal. So these are all the grief things. So it's not only death, it can be loss of something very significant to her. So the grief can be anything. So we have to focus on the grief. And then interpersonal disputes. Okay, say for example, husband and wife, they can have different kinds of expectations on each other, and they are not satisfied with their expectations, and they develop disputes. This is interpersonal disputes. And it can be, depression can be because of role transition. Like before I'm single, I don't have any responsibilities, suddenly I become mother, I have to take care of the baby, I have to take care of my family. So this role transition from single, being a just married person to a mother, this transition can make somebody to go into depression. So this adjustment and to life change that requires an alteration of behavior from old role to new role. And then it can be an interpersonal deficit. Sometimes, say for example, a single mother raising her kid, there is no social support, husband expired and in-laws are not cooperative. Then it is interpersonal deficit. She doesn't have anybody to take care of her or her problems. So it is an interpersonal deficit. So these are the 4 areas basically where interpersonal psychotherapy focuses on. So what are the goals in grief? So it is very, very simple. It is like facilitate the mourning process. Everybody mourns after the grief. So just to facilitate and help the patient reestablish interest on a substitute. Okay, it can be a family member or can be another significant person. That lost object should be substituted with another object of interest. And in role disputes, the goals are help to resolve the conflict. As I've told you before, this role dispute is because of problems between 2 people, because of expectations or because of some faulty communication. So we have to focus to help resolve the conflict. And identification of the communication patterns. If you talk to them, you will identify what kind of faulty communication they are having. It can be always complaining. One spouse will be always complaining on another, or sometimes blaming all the time, or overgeneralization, like she does nothing good. So these kind of faulty communications you have to identify and then try to resolve. And you have to teach new communication skills and generating solutions to dispute. That you do in role disputes. And third important focus area is role transition. Role transition is when you attain a new role and lost the old role. So in this, the goal is to help patients relinquish old roles. We should not, keep on thinking about the beauty of the old role. So we have to tell them, just forget and let go. Okay, so you should help patients relinquish old roles, accept new roles. So take it as a challenge for the new role and develop a sense of mastery in the new role. Okay, for example, a lady is not able to feed the baby, but once or twice she's trained, and if she does it repeatedly, she will develop mastery. Not all will be born with, you know, a lot of skills. పువ్వు పుట్టగానే పరిమళించేది అనేది I don't think it applies to everything. So we have to train ourselves to develop mastery. So practice makes women perfect. So that's how we should tell that. And interpersonal deficits. So here interpersonal deficits is because of lack of interpersonal relationship with others. So here we have to improve interpersonal relationships, explore repetitive interpersonal problems, teaching skills for building and maintaining relationships. They don't know how to maintain a relationship. That's why they are having inadequate interpersonal deficits. So we have to teach them skills for building and maintaining relationships and reinforce positive communication patterns. So that is about interpersonal therapy, and CBT and IPT are the most effective treatments for depression and anxiety, particularly even in reproductive age women. So another technique which is of much importance, in particularly after traumatic birth, is psychological debriefing. So this is a technique therapy used after the death of baby during delivery or some trauma to the mother or the baby during delivery. So why do we need to do this? It is done because we want to prevent the development of PTSD. If the trauma is so significant, she will develop PTSD during that event. So we have to prevent this PTSD and all other negative sequelae associated with PTSD. That is the reason why we should do psychological debriefing. And the symptoms of psychological trauma are horror, helplessness, fear, and loss of control. And they also develop fear of future pregnancy because they are like very much shocked and they can't think beyond a point. So here the technique is like 1 to 2 brief sessions. Sometimes only one session is enough to debrief the women. It is structured. It should be done within 72 hours of delivery. After that, it is not going to be effective. And it can be even done by midwife. Midwife can go and do psychological debriefing. It can be done in the house or hospital. And it need not be done on a regular basis. 1 or 2 sessions are enough to manage that condition. So there are some steps. The first step is engagement. Just developing rapport with the person and engage in the talk itself. Number 2, facts. You have to ask the facts. What happened during delivery and what did you, like what exactly the reason for trauma and all. And what are the associated thoughts? How did she think like? Some people might have thought that it's better for me to die rather than going through this trauma and all. And feelings and reactions. How did you feel? How you feel shocked, sad, depressed or anxious? So you have to ask the associated thoughts. And normalization. You should tell her that it is normal to feel this way when you are undergoing trauma. Everybody will go through the same phase when they're traumatic. So you have to normalize the feeling and then educate her that it is not going to be repetitive or it is not long lasting, and then disengagement. In disengagement, you slowly tell that we are going to end this session and what her future prospects and what are her future thoughts about her future pregnancy we should ask, and then disengage with her. So that's how it is done, and it should be done within 72 hours of traumatic delivery. So quite often we don't know like most of the women who went through traumatic delivery, they don't even recognize their feelings and they still develop PTSD and all. It is the responsibility of the treating doctor to identify what she is going through. So another technique which is becoming very, very popular nowadays is mindfulness. So mindfulness is very clear. We have to be mindful in the present moment. As I'm doing now, I'm practicing mindfulness when I'm talking to you. I know what I'm talking, what I'm seeing and all. So I'm mindful of what I'm doing right now. So I'm present in the moment. Awareness is present. Acceptance. Whatever is happening around me, I'm accepting. Okay, so that is acceptance. Non-judgment. This is an important, crucial thing in mindfulness. You get a lot of thoughts. Sometimes you get positive thoughts, you get negative thoughts. You should not judge that this is negative thought, why I am getting it, I'm a bad person or what. Many people don't get it. So these kind of judgmental attitude should not be there in mindfulness. And mindfulness means paying attention in a particular way on purpose in the present moment and non-judgment. That is all about mindfulness. So there is one technique which is very popular. There are a lot of techniques in mindfulness like breathing exercises, there are yoga and meditation. But this body scan meditation, I thought it is like very relevant. And here the person can lie down or she can sit very comfortably. And she has to ask her to close eyes and focus on breathe. So first focus on breathe and bring awareness to a specific part of the body. It can be head or chest or abdomen and limbs. Imagine spend 20 to 60 seconds noticing sensations. You have to notice the sensations. And then imagine tension decreasing with each breath. And release your focus on that part of your body. Move to the next part of the body. So at each part, you wait for 20-30 seconds and see what is happening around that part, and then move to the next part. And then if your thoughts wander, then gently bring your awareness back. So it is very, very natural, like when we concentrate for a long time, our thoughts wander. But we should see that our thoughts are again refocused on the body part and breathing. And after several scans, let your awareness travel across your whole body. Then you have to focus on your whole body. Release your focus and come back to your surroundings. This is how mindfulness meditation body scan can be done. So what are the benefits of this mindfulness? It relieves stress, reduces anxiety, improves mood, happiness, increases your concentration and improves self-esteem. So you need not be a patient to practice it. Just to develop your positive mental health or improve your quality, you can practice this mindfulness. So it is found to be very effective in women who are undergoing anxiety, depression, and sometimes just to have a positive outlook, they can do this mindfulness. And there are some small, sometimes even women are apprehensive about breastfeeding. Like they don't know how to feed the baby when they are being delivered for the first time. So this is also can be trained. Like there are 1 or 2 sessions where she can be trained and said about the advantages of the breast milk and breastfeeding, its benefits for the mother and the infant, and how to express milk and store milk. And it can be done by the nurse. At least 1 hour they should spend time with mother, and then they can be trained in breastfeeding. So for all these techniques, you can provide with a manual or some book or sometimes even telephonic counseling, and online counseling can also be done for all these techniques. So another simple therapy which can be used is problem solving skills. So what are the problem areas and how to solve the problems? There's just, I'll just give the overview. So for example, there is a problem that I can't do my work at home because there are a lot of pending work. So I have to make a list of specific problems which I'm facing right now. Review a list and there are 10 problems I'm having right now. So I should pick one problem at a time and then write down possible solutions to the problem. I have to write what are the solutions for the problem and do a pros and cons list for the solutions that seem most promising. Say for example, she's unable to do work at home because of the newborn baby. There's a lot of pending work at home. She has to list out all the problems and then she has to write the possible solutions. She can employ a maid, she can buy a washing machine, or she can take help of somebody for 1 hour, or she can take the help of the husband. So these are some solutions which I can think of when I have a problem. Then I have to write the advantages and disadvantages of each solution. For example, I want to employ a maid, I have to spend some money on that, whether I'm having that money or not. So the disadvantage is money, advantages, I'll have a full-time maid. So for each and every solution, I have to write the advantage and disadvantage, and then I will think of most feasible solution. So for me, the most feasible solution would be asking my husband to do work after he comes back from office. So this can be the most feasible solution. So that's how You have to choose a solution to make a plan and to make it happen. Putting your solution into action. So just making solution is not enough. You have to put that solution into action and checking up on your progress. Every time you have to monitor whether it is working or not. That is how problem solving can be done. And then coping skills. How do you train a person to develop coping skills? There are two different types. One are helpful coping strategies and other categories are unhelpful coping strategies. Like helpful coping strategies can be humor, looking for social support or relaxation, doing exercise and physical activity, changing your expectations. These are all positive coping strategies. And negative coping strategies are avoiding using alcohol or drugs, blaming yourself for everything, forgetting about your strengths and focusing on your weaknesses or negative coping strategies. So we have to identify the negative coping strategies and then ask her to convert them into positive coping strategies. And another important thing is social support. For many women, just giving social support is enough to handle her problems. You don't need to give any trained psychologist or psychiatrist to give her IPT or CBT. Just social support is enough to handle the problems. Social support can be like emotional support. You have to make a list of people who are emotionally supportive to her, like friends, family members, with whom she can talk to when she needs. Okay, that is emotional support. And practical support, like some work is pending at my home, I need to get my groceries or something like that. Who will help me during that time? So practically, who is supportive to me? I have to make a list of people of them and I have to seek support from them. That is practical support. And social support network, like group social support, like I can go to a temple and get support, or I can go to my relative's house, or some social activity groups will be there. So we can get enrolled into that social group and then get support. So these kinds we have to note down and then put them into action. Or information support. Sometimes we just need some information. So we have to know from where we can get information from. So these 4 important social support techniques we can use. So what are the psychological conditions? I have just given an overview of all the treatment therapies. So for menarche, it is just psychoeducation is enough, and postmenopausal, premenstrual dysphoric disorder, psychoeducation. For infertility, CBT, IPT, supportive therapy. Stillbirth, they specifically mentioned that they should not hold the baby. Okay, the baby had died, but the mother is not allowed to hold the baby, because the more they get attached or more they see the baby, it is very difficult for treatment. So it specifically mentioned that she should not hold the baby. And menopause, CBT, IPT or mindfulness, these are not researched. It is just people are practicing, that's all. There are not specific research or guidelines that they are very effective. But NICE guidelines have given some specific interventions which are found to be effective. This is the most boring slide, but I'll just keep it for 1 minute. First, multiple risk factors. If a woman is having multiple risk factors, interpersonal problems, cognitive errors, and then death of a baby or previous anxiety and depression, if there are multiple risk factors, then multimodal therapy. You can give her IPT, CBT, and then social support, education, all this should be given to her. And subthreshold, mild depression, IPT, CBT, most effective. And moderate to severe depression, if you have to add on to the existing antidepressant. You have to give CBT and IPT to the existing antidepressant. For PTSD, there are some specific techniques for that, CBT, EMDR. And traumatic birth, debriefing, 1 session is enough. And for sleep disturbances, sleep hygiene. These are the various interventions, social interventions, psychological interventions, which are given by NICE guidelines, which are found to be effective during these conditions. And apart from that, nutrition, exercise, sleep and rest, time for herself and support as an add-on. So that is about the psychosocial interventions which are found to be effective. And just a word, just few situations of some legal implications. So coming to some legal implications of postpartum in the postpartum or in reproductive age women. Mental Health Care Act has a special focus on women on some of the important things, like Section 20 says provide access to items needed for menstruation. So we have to give her sanitary pads in mental health establishments. And Section 27 says women should not be discriminated on the basis of gender. And Section 21 also says that a child under the age of 3 years of a woman should not be separated. So a 3-year-old old child should not be separated if the mother is put in mental health establishment only under one situation where there is a harm to child. Then only you should keep the child away from the mother, or else you should keep the child with the mother. Okay, even if you separate the child, the child should be accessible to the women, because the child should be kept in the mental health establishment along with the staff or with the family members. So whenever she wants to see the child should be made accessible to the mother. So in one such situation, I have come across a patient who developed postpartum psychosis. So she delivered for the first time. And after delivery, she was psychotic. So what husband did was, he took the baby and gave the baby to in-laws who stay in different place. And when I talked to the mother, the main important focus, every time when I talked to her, she said that my child is being snatched away from me. My child is being snatched away from me and I feel very suicidal. So this kind of thing is very unfortunate, but I have reminded her that she has every right to take care of her baby, every right to see her baby. So then I told the husband to bring the baby. At least the baby should be accessible to her whenever she wants to see her. So we have to see that in the mental health establishment, there is a provision to keep the baby so that the mother can access her anytime. So the decision, if at all the baby is separated because of the harm to her, because of the mother, this decision should be reviewed every 15 days. Every 15 days, after it should be terminated as soon as the mother is able to take care of the baby. So that is the Mental Health Act, Section 21. And sometimes the mother is continuously psychotic for, say for example, 30 days. And we can't give the baby to her. Then we have to take a special permission from the respective authority. We should take the we should take permission from the district mental health board that we are keeping the child away from the mother because of so and so reason. So after 30 days, we should communicate to the concerned authority. So, and Section 87 says that in case of minor girls, a female attendant should stay with the patient during admission. We can't admit a minor girl without a female attendant. That should be taken care of. And Section 95 says sterilization should not be performed on the woman. So there are some instances, like we get some patients, like husband comes and says, recently we got married and my wife is very slow and she's not able to do any work at home. This is a common complaint we get. And we call wife's parents. They say that no, my child is all right till marriage. After marriage only she's being slow. So different versions we get. But when we examine, it can be because of borderline intelligence. So what is the status of the woman who is borderline intelligent or mentally retarded after we check her after marriage? What is the status of the woman? So the Special Marriage Act, or for the sake of, like for any other marriage act, there is specific mention that if a person is suffering from mental disorder of such a kind or to such an extent as to be unfit for marriage and the procreation of the children, it is considered as null and void marriage. Even she is married, we should think that the marriage has not occurred at all, because she is having some mental illness for which she is unfit for marriage. Sometimes what happens is family members give consent on behalf of the women and she gets married. After marriage, she is found to have mental retardation. So we have to check whether she is fit or unfit. So it is very, very delicate situation and very critical situation for a psychiatrist. How to say that whether she is fit or unfit? So we have to check we have to call the family members, take full proper history, milestones, check for any physical signs suggestive of mental retardation, stigmata of mental retardation like low set ears or microcephaly. There will be a lot of signs. So we have to check. And then activities of daily living, whether she's able to do certain activities or not, we have to ask the family members, and then go for IQ testing and activities of daily living. All this after checking, then only you can say whether she's fit or unfit. If she is unfit, then her marriage is null and void. So that's how we give usually moderate mental retardation and severe mental retardation, they are unfit for marriage, whereas borderline intelligence and mild mental retardation, they can perform their duties, so they are not unfit for marriage. Divorce. This is also one condition where people approach for divorce. Like say for example, a woman suffers from postpartum psychosis. So on that note, a husband comes and says, now she developed some psychotic illness. Because she developed psychotic illness, I want to give her divorce. So, but the divorce, the Marriage Act says that a person, if she is incurably of unsound mind or has been suffering continuously or intermittently from mental disorder of such a kind and to such an extent, the petitioner cannot reasonably be expected to live with the respondent. So if it's so severe and so persistent, then only we can say that he can get divorce. Usually in postpartum depression and postpartum psychosis, these are temporary conditions. It is not a permanent condition. Postpartum psychosis usually gets resolved within 6 weeks to 6 months. So this is not a permanent condition. So on that grounds, on the grounds of postpartum psychosis or depression, they cannot get divorce because it is not a persistent illness and it is curable. So we can't give unfit, that she is unfit for continuing her marriage. And these are all civil matters, whereas there is one condition which is very, very serious and which is a criminal matter. Criminal case is infanticide. Infanticide is killing the baby within 1 year of delivery is infanticide. So usually the causes of infanticide can be psychosis, depression, or unwanted child or revenge. There are various factors, but these are the more common causes of infanticide. And 4% of women with postpartum psychosis commit infanticide. It is very, very alarming, but there is some research saying that 4% of women with postpartum psychosis commit infanticide. And what are the rules governing whether the women will be guilty or not guilty? Say for example, if she killed the baby during postpartum psychosis, then she will be guilty or not guilty. So then we have to put McNaughton's rule. McNaughton's rule is equivalent, like we have IPC section 84, which specifically talks about who will be not guilty by reason of insanity. And McNaughton's rule says that the person should have mental disease, that is unsoundness of mind, that is otherwise called as medical insanity. Along with that, she is not in a position to know the nature of the criminal act. She doesn't know that it is a criminal act, or she doesn't know that it is wrong. So then only it becomes a legal insanity. So she doesn't know because of the unsoundness of mind. She doesn't know that it is wrong. She doesn't know that it is a criminal act. She doesn't know that it is illegal. So in that situation only, she will be proven not guilty by reason of insanity. If a mother kills a baby because of revenge on father, or because she doesn't want the child and she killed the baby, she knows that it is wrong, she knows that it is illegal, but still she kills the baby, then she is guilty by reason of, she is guilty because she doesn't have insanity. So here, postpartum psychosis can be grounds for not guilty by reason of insanity. But however, there are no infanticide laws in India. We are following IPC section 84 to say whether guilty or not guilty. So my take-home message is, like, not only focusing on biological treatments, all women should be given psychosocial treatment also along with biological treatment. Sometimes only psychosocial management is enough to treat her. And everybody should focus on the biological factors, psychological factors, and social factors, and try to manage giving psychosocial management. Thank you for patiently listening to me.
Thank you, Anita, for your detailed description of the psychological management of the women during her sensitive periods like pregnancy, lactation, menopause, and menarche. So I invite questions, online questions. Mike.
After the marriage, after 6 months of marriage, the wife gets severe depression, and the husband goes and says, my marriage should be nullified. What will be the answer for that?
It can't be nullified, sir, because null and void arises at the time of marriage, whether she is able to give consent, number one, whether she is mentally unsound to be fit for marriage, to be unfit for marriage, or she is having recurrent attacks of insanity at the time of marriage. During marriage, she is mentally sound. She developed after marriage. Then she should be treated. If
At
she
the
is
time of marriage, she should be unsound.
Yeah.
Not after the marriage. Then it goes for divorce, not for nullification. Right.
Any contract becomes null and void if she is found to be before the contract.
What is the fitness for marriage in a case of mental retardation, as you said?
Yes, sir. We have to take many factors into consideration, sir, like history, proper history from the family members, then examination and milestones and evidence of like IQ testing, and then activities of daily living, whether she is able to perform her day-to-day activities at home, cooking, cleaning and all, whether she can understand the concept of marriage, the procreation of children, all this we have to ask her. And if she is able to tell and if she is able to perform some activities, and if you find that she is fit, then we can give fitness, sir. Sir.
Fine. And you feel that she is not that severely mentally retarded, and therefore she is fit. This is what you are trying to tell us.
Yes.
My question, what about the genetic aspect? What is the guarantee that the children will not have mental retardation?
That part, the laws don't take into consideration, sir. Yes, sir. Just whether she is able to... No. Yeah. There are a lot of biological aspects which are not taken into consideration, like a husband can be impotent and infertile, or that part is not at all taken into consideration because in the law it is only if she is unfit for marriage, it is null and void. Sir? Mental age is 12 years.
Supposing.
She is not fit for marriage, sir.
Then it's null and void.
Null and void, yeah.
Chaitanya, you have covered almost all topics in the reproductive age group, and between menstruation and pregnancy there is important topic called psychosexual issues, especially like frigidity and rejecting marriages for unknown reasons. Nowadays we are getting patients, they are not called as patients, young females, they are rejecting marriages for unknown reasons. Multiple sexual partners, extramarital relationships, they are important areas to throw light in coming presentations. And postpartum blues is very, very common. Even I faced the situation when my wife had first child. The gynecologist asked me, did you scold your wife? That is the question I faced. At that time I was doing my final year MD at IMH. And I request all the female psychiatrists, especially we have formed Samanvi, you got at least 50 numbers of gynecologists and maintain co-relationship with them and educate them so that they can get wonderful knowledge of perimenopausal or anything reproductive age group psychiatric issues. Thank you.
Yes, sir, I have not covered the topics.
One thing I want to add, sir. So most of the time, the gynecologist, they just simply say what is the problem and all. One patient, she came to me with severe panic attacks. Actually, her problem is her HB was found to be 10.5 grams. So gynecologist immediately told that the HB is very low. Go and take some medication now. She was very afraid that 10.5. She went and verified in her net that normal is 14 grams and it is only 10 grams. So tomorrow my baby is going to die, and she developed panic attacks. But when I explained that it is simply the WHO standard is 10.5 grams in India to call it anemia. If the patient is a pregnant woman is having less than 10.5, then only it is called anemia according to WHO. So that counseling is very important from a gynecologist and obstetrician point of view. The similar thing happened in case of hysterectomy, sir. One patient, she underwent hysterectomy at her second delivery because of uncontrolled postpartum hemorrhage, and she was not counseled properly, and she thought that it is sexual life is abandoned after hysterectomy, and that created a lot of psychosocial issues because she was very young, 25 years at the time of hysterectomy. Till now, when I interviewed her, she was around 50 years. So all these years she was avoiding that sexual intercourse, and she has to face a lot of problems. So I think counseling is very, very important in gynecology and obstetric situations, starting from menarche to menopause. Yeah.
I think one point what Dr. Chaitanya has told about genetic conditions in mother, like are there any, we have to think seriously which genetic condition in a mother is going to guarantee that all the children born to the mother are going to have the problems. I don't think any condition is there because the genes are going to come from both the sides. Probably it's not 100%. Yeah. Maybe I'm not sure. Maybe there are one or two conditions which are where guarantee is there. The mother has the mental retardation because of genetic condition. All the children who are going to born will be going to mental retardation. Only those conditions probably you have to take it seriously. Otherwise, I don't think law will think about it. And one question to Dr. Chaitanya is, from your presentation, one important clinical or medical responsibility is to train the gynecologist because they will be available at the time of postpartum, at the time of delivery. We won't be available then. So we have to ask several questions at the time of delivery so that we identify the postpartum conditions as early as possible and treat them. So I want to know whether there is any standard questionnaire which has to be given to the gynecologist so that they can just tick this questionnaire for all the patients at the time of delivery, so which can act as a screening questionnaire.
So there is one questionnaire, sir, WOLE questions, only 3 questions to identify depression. WOLE, W-O-L-E-A-Y, WOLE's question, only 3 questions. That is very simple, and they can apply for each, after 24 hours of delivery, they can apply and they can identify whether they are in any depression and all. For depression? Only depression. Psychosis, that is only for depression. So, any questions? If there are no more questions, I will end the session. Thank you very much, Chaitanya and Anita, for your presentation. Thank you.
Thank you, ma'am. Now I request Chairperson Dr. Sudharani ma'am to present mementos to the speakers. I first request her to present memento to Dr. Anita ma'am. Now I request ma'am to present memento to Dr. K. Chaitanya Lakshmi ma'am. Now I request Dr. Ashok Alim Chandanani sir to present memento to the chairperson of the session, Dr. Sudha Rani ma'am. Session 6 is here only. Session 6 is here. With this, we end the session. Now we move forward to the next session for the day. I would like to announce that there is a slight change in the program. The valedictory function will be held in the same hall after the upcoming session. That is, the valedictory function will be in hall A itself. The topic that we will be discussing now is laying research pathway towards publication. For this session, we have two chairpersons. I would like to invite Dr. R.S. Swarupachari sir to the dais and Dr. Sai Krishna Puli sir to the dais. And I would also like to invite the speaker for the session, Dr. B. Anand sir, to the dais. Chairpersons, two chairpersons. I would like to begin the session by a brief introduction of the chairpersons. Dr. R.S. Swarupachari sir is currently Professor of Psychiatry at SVS Medical College, Mehboob-Nagar. He is also a consultant psychiatrist in Mehboob-Nagar. He has completed his MBBS from SVS Medical College, Mehboob-Nagar, and his MD Psychiatry from Mamta Medical College, Khammam. He has more than 12 publications in various index journals. His areas of interest include psychiatric research. The next chairperson, Dr. Sai Krishna P. sir, has done his MBBS from PIMS, Karimnagar, and MD from KIMS, Narkatpalli. He is trained in medical education training from JIPMER, Pondicherry, 2012. He is currently Professor of Psychiatry at PIMS, Karimnagar. He is Honorary Editor, Telangana Journal of Psychiatry from 2019, and his areas of interest include addiction psychiatry and sexual medicine. I now request one of the chairpersons to introduce the speaker and the topic.
Good evening to all. I am very thankful for the organizers for giving us an opportunity to chair our teacher, Dr. Anand sir. Anand sir needs no introduction, but I will give a brief introduction to Anand sir. Anand sir had done his DPM from NIMHANS and DNB Psychiatry. He is having a certification course in statistical methods from Indian Statistical Institute, Kolkata. Currently, he is designated as Professor of Psychiatry from Mallareddy Institute of Medical Sciences, Hyderabad. Sir has retired as Professor of Psychiatry from IMH, Eragada. Sir is having experience. He worked as Senior Resident in Psychiatry at JIPMER, Pondicherry, as Research Associate in Neuropsychology Unit at NIMHANS, Bangalore project. He was awarded Jairam Award in South Zone Conference for the year 1999. His areas of interest are data analysis and research in mental health. Sir is having up to 45 publications till date. Now I hand over the mic to my co-chair.
Good afternoon, everyone. I would just like to make an introduction about the topic, that is laying research pathway towards publication. It is through systemic scientific research that we divest ourselves about our preconceived notions, superstitions, and gain an objective understanding of the world. Research improves services and treatments. It helps in developing new tests for diagnosis, treatments, and processes that could eventually help the future generations. Writing a research journal is the most important means of communicating the scientific work. Research and publication complement teaching and training, clinical care, and public health works. Publication in peer-reviewed journals gives international recognition for an individual, department, as well as for his institution. Having a robust body of published works helps in advancing your career as you are considered for academic appointments and promotions. Publishing helps you to establish as an expert in your field of knowledge. Thank you. And with this, I give the mic to Dr. Anand sir to proceed with the lecture.
A very good afternoon to all of you. At the outset, I thank Dr. Ashok Reddy and the organizers for asking me to present this topic that is laying a research pathway towards publication. We have heard previous speaker talking about that there is lack of research. Most of the guidelines, if you see that they are nice guidelines and some other guidelines. So we have IPS guidelines, we do have, all of us know that, and we need to modify them also according to the new research. She said that there are some of areas are there which are not researched well, but who is going to do an Indian research? Only we, one of us have to do that. Okay. I thank the chairpersons, especially our TJP editor, Dr. Sai Krishna, is putting a lot of efforts, I know that, to bring out a journal. I was also the editor long time back of AP Journal of Psychological Medicine for 2 years and Indian Journal of Social Psychiatry for 2 years, along with Dr. Krishnamurthy as assistant editor, and I know how difficult it is. Now, at least with the digitalization, even then it is not easy, I know that. But previously it was, you have to go and check manuscript and then go for the printing and all that. So, coming on right to my topic is not about how to formulate a research, how to formulate a research question, what are the designs of the different studies and all that. As requested by Dr. Ashok Reddy, I am going to the second part actually. What is the second part? As you see on this slide is, what are you interested in? To publish in a journal? Then there are two ways. One thing is that you are doing a project and then you want to publish it. And second thing is you have a dissertation, your MD dissertation which you have already done, and you want to publish it. I have dissected, if you see that, dissertation. It can be your dessert, the cake which you eat, or the sweet which you eat, or if you don't do anything about your dissertation, you are left in a desert. Okay. So, it is up to you to take up this or not. Why I am talking about this is that at least about 35 to 40 research thesis guides, I know that many of them are not published from IMH. Okay. So, the candidates themselves have to take interest in publishing their works. Otherwise, how will people come to know? So, what is the need for scientific research is articles to provide a method for scientists to communicate with other scientists about the results of their research. And the true value of any research is only realized when the results are subject to peer review and then published in journals. We are not living in an era of Galileo and Copernicus. You can understand their intense passion that they could sacrifice their lives. At least Galileo was killed for just saying that Earth is not the center of the universe, but Sun is the center of the solar system. So, do we have that passion? Let us think about, whenever we do some project, let us think in those terms. There are people who never had any chance to express themselves. But now we have a lot of chance to express ourselves. But the only thing is that this, what we express, has got to be peer reviewed. So, people around us should evaluate our work and then they give their judgment. So, what I am going to do is that the presentation will be about these particular points. That is, why should we publish? And as I have told you already that we have got a project or we have got a dissertation. So, but when it comes to a paper, you cannot publish your entire dissertation. So, you have to choose something out of that and publish. So, what are the components of an article which you are going to publish? Then things like what is citation and what is referencing. What do the editors look for in the journals when you send an article? Don't think that you send an article to Sai Krishna is just going to publish it just like that. There are a lot of things which are necessary to curtail. They have to cut a lot of things and ask you to actually do it again and then send it back. And some important things are like plagiarism, which you should be aware of. Especially this is something which I am addressing people online who are not present here, all the young budding researchers. And I would like to pose a small question here, that is, are you aware that there are something called as the real journals and predatory journals, which you will come to know? And do you also know that there are some journals which charge you, which are called as article publication fees? And finally, how the journals are measured, which is called as journal metrics. So generally this is what happens, that why you want to publish an article is definitely because to get a job, or to keep a job, or to get promoted, or to get funding. So this is the practical aspect of it. But I think this is not the only thing. You should have the passion to contribute something to the society. At least Erickson's last stage, where your ego integrity, that means you need to actually do something for the society. So this is for the PGs. As you know that the NMC National Medical Commission says that you should have at least one poster presentation and one publication. So at least all of us should be aware that some of you would have already put out posters and got your certificate, and people who do not know can follow this, and probably this slide can be circulated. These slides can be circulated later on for you to look into that, as to where all the things should place, what are the dimensions. And then regarding the publication, definitely you should have a tag with one of the authors. It is not necessary that you should publish alone or in an indexed journal, at least as far as I know, for students, for PG students. So better to get tagged with them. But then that is not the end of it. You are going to pass beyond that and go into different faculties where you need to be publishing articles, and then you will be judged based upon your publishing articles. So what is the logic in that? In the scientific article writing is, it should be very clear what is the problem, and you should present the evidence for this problem, and whether what you have presented is valid or not. What are the strengths and weaknesses, and what is the other evidence for and against, and then you should conclude. So these are the basic simple things which are too complicated also. To state that it is very simple, but this is the logic in scientific article writing. Well, this can be slightly elaborated in what you call it as a process of empirical research. Empiricism is important here. You need to observe, note the findings, do an evaluation, and present it. Well, of course, what do you mean by non-empirical? For example, Einstein said some 100 years back that there are something called as gravitational waves. He did not do any experiment. It was not possible for him, but mathematically has shown that. But after 100 years now, people have shown that there are something called as gravitational waves. So the difference between hypothetical and empirical research. So you have to define a research problem and research question, which itself requires a 1 hour discussion, but already you have written your thesis. So you know what is a research problem and what is a research question. Then you formulate hypothesis based upon the theory which is prior to the research, and then what are the difficulties in that. So design research study to collect your problem, what you are addressing, conduct the research, analyze the data, and present it. So we'll go into some of these types of articles which are generally published. Now if you come to see that, let us start from the basic thing is the case report. I am not going to details about all these things. The second thing is technical note. Like for example, you are doing some experimentation like in a lab or something like that. So the technical note is necessary there. For example, you are doing some EEG analysis or some imaging analysis, the technical details are important. Or you can write a letter to the editor. Okay. Now, even the letters to the editor, they have a digital object identifier, DOIs are there. So, they encourage you to write letters. When you have a short article, they'll say you put it as a letter, some of the journals. And some journals say that you write a letter on what is already published, the published article. So, journals differ on that. Then if you are an editor, then you have to write an editorial. Then of course the most important thing is the original article. Now these days the NMC says that you need to have an original article. If you publish a case report, it's still not accepted for your promotion. Okay. Or you can do a review. Now review can be in the form of, especially according to NMC, will be a systematic review and meta-analysis. So right now NMC accepts both this original articles and review, which is not a general review, but definitely it is a systematic review and meta-analysis. So you can have different types of essays. If suppose you already achieved what you want, then you can keep writing a biographical essay, then review articles, evidence-based medicine, then systematic reviews, then I have put bold lines like meta-analysis and original research articles, case report, short communication, letters to editor. There are some journals which say short communication. You only give me only 500 words. That's a short communication. Okay. Now, I would advise all the PGs and also for the researchers who want to publish to definitely go through this particular network, which is called the Equator Network. Now, the Equator means it's an acronym for enhancing quality, okay, of articles in the health research. You just Google that, you will find that how to write an article, what are the different components of an article, according to the different types of articles which you are going to publish. For example, you want to publish a randomized control trial, then you follow what is called as a consort statement. These are all acronyms actually. Okay. So, consolidation of statements for the randomized trial. So, that is a consort. Now, mostly we will be doing cross-sectional studies and cohort studies or case control studies. So, you need to refer, please be aware of this, at least the strobe guidelines. So, there will be guidelines listed. Now, it is not just for fun that these have been put. The journals are very serious about it. Journals say you have to tick all these. There is a something like a menu of different items. You need to say yes, 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 and all that. If you find, if you just tick your S and then it is not there in your article, then they are going to send it back and reject it. So, these are the standards which are now set. You cannot send in any article in whatever framework you want. So, there are several guidelines. You please go through this. I cannot go into all of this, but there are hyperlinks and you will easily find what is necessary, but just remember Equator. So, when you write an article, definitely you know all of that when you write a thesis also, but here what is important is that you don't have this review of literature. This review of literature actually in the introduction only. When you write a thesis, we do write elaborate some 10 to 20 pages of review of literature, but that has to be condensed in introduction. Now, why ask this question? That is what always whenever you are trying to write an article, please try to ask a question for yourselves and then try to answer it. Then you will find whether you are very specific or a lot of non-specific things are there. So, this is called as the IMBRAD method, that is introduction, methods, results and discussion. So, let us go into some of these aspects. The standard format of an original article, if you are writing, will be the title, authors, abstract, introduction, materials and methods, results with tables and figures, discussion, acknowledgements, and reference. So I'll go into each one of them along with some of the our own publications, not to because I am familiar with what I have published, so that's why I'm putting out some of these articles. Now, title of the article should be specific. See, what will happen is that when we write a dissertation, we start with a study or is a cross-sectional study of so and so, so and so, so it is a big article. People will not be interested, it is editors will not be interested to read this. This is a very stereotype type of presentation. Okay. Now it should be specific, it should be appropriate, and it describes the subject matter of the article, and it summarizes, it should be eye-catching, all such things are there. Now let me go and introduce to you one article. This is a sample title which we published in Archives of Mental Health, the previous AP Journal of Psychological Medicine. So this is a case report. Now see this, association of pediatric OCD with antithyroid antibodies and hypovitaminosis D3, a case report. So case report was unavoidable because there is only one case. Okay, so what is that we are trying to, actually we are trying to say that there is association between the pediatric OCD with antithyroid antibodies and hypovitaminosis D3. Now if you go back, is it specific? Is it appropriate? Most probably. Is it summarizing? Just by reading the title, I feel that some of these things are satisfied here. Okay. Now read this. This is an article down below which we published in Indian Journal of Psychiatry. Psychological autopsy of suicide, a cross-sectional study. This has got a lot of citations by one of our PGs then. Now he is in UK. So, psychological autopsy is not a very frequent article. Not many people do that. So, here we are trying to tell that we are doing something which is not often done. Okay. Now, let us come to the authors. Who are the authors? Authors are the people who actually know about the entire article and then they know in and out of it. So, the person who does the work and wrote the paper is generally listed as a first author of the research. At least you should be aware of 60 to 70% of the work he has done, that is a first author. For published articles, other people who have made substantial contributions to the work are also listed as co-authors. Now don't think that co-authors have got no importance, definitely they have got. If you are, let us say for example, you are publishing an article in Nature or New England Journal of Medicine, and you find that you are the 25th co-author, but still you are important. Because it's quite rare that you will get a publication in New England Journal of Medicine or in Nature. Okay, so co-authors are also important. But the only thing is that you just don't keep on adding co-author just because they are your associates or they are your friends. Now let us say for example here is a publication of ours. Although I am not the lead author, you can see that this is from the Epilepsy and Behavior published in Elsevier. So here the author contribution, you can see the data collection interpretation by somebody, a study concept and design by a neurologist from KIMS and also by myself, and statistical analysis. And interpretation of data, you see somebody, critical revision, so it should be in that particular order. Abstract is the most important statement which you make, and it should be accurate and clear. Spend a lot of time in correcting and recorrecting your abstracts. Why? Because readers, systematic reviewers and web search tools can have access to abstracts. They may not have access to the full article. Okay. So you see that that abstract itself may be the only part of the paper that is accessible, will be the only part visible in bibliographic indexes like Medline. A good abstract will encourage selection and reading of the full paper. If you read an abstract, it should make you read again. And please remember, editors and reviewers do not have time to read your full article. That will give them a lot of headache. It will give them, they have to spend a lot of time on that. So what they will do is they'll just read your abstract. If your abstract is not good, they'll just outright reject your paper. And authors, and because the abstracts are so important for all authors, they should approve it. And it should use the, as I've told you, some guidelines are there. So even in the guidelines also, they'll tell you, suppose it is a randomized clinical trial, your abstract should be like this. Or some other, it should be abstract like this. So you have to follow those guidelines. So let us say here is a sample abstract. I'm not going to read all that. So this is, so you see that previously I've shown you the psychological autopsy one. You see the breakup here, the background, aim, method, result, conclusion, and keywords. Keywords actually not part of the abstract, but generally all the publishers ask you to give some keywords. Now introduction. As I've told you previously that you cannot put everything, your review of literature, what you have done in a dissertation. You have to follow this funnel type of approach. What is this approach? What is known? That means it's a general area. You don't spend too much of, you cannot spend paragraphs and paragraphs on general known area. It should lead you into the second unknown area. That is, you are now focusing on specific. From that specific thing, you are going to ask a question. So the whole thing is what is not known, and then that should be translated into a question, and your whole attempt is to answer that question. Let us say, for example, here is a sample which we have given in the same article which I have shown you previously from the epilepsy and behavior. This is about the impact of family support on psychiatric disorders and seizure control in patients with juvenile myoclonic epilepsy. Now, what is, you can see, observe this. Now, this, what it says in the introduction is that, to the best of our knowledge, there is no available literature on psychiatric comorbidities in juvenile myoclonic epilepsy in the Indian population, and specifically about the role of family support in the patients with the JME. So data available in other parts of the globe are hindered by lack of clinical psychometric assessment. So you see that in the brackets we are given reference. You just can't say that it is not there anywhere in the globe. You have to give a reference for that. And lack of appropriate definition. For that there is a references there. Or insufficient sample sizes. A reference is there. So you see that how we have funneled out and said that there are definitely some global articles are there on this particular topic, but however, it is not that much, not much of knowledge is there in the Indian situation. So although some researchers have attempted to overcome these shortcomings, we are given the reference again, it is not known if the same findings apply to Indian population. So we were making something like a case for our study. So that is how we have to address your question. So your objectives should be specific, measurable, achievable, realistic and time bound. Let us look at something. Again, same thing. This is published again in the Indian Journal of Psychological Medicine. You can see that comparison of thiopentone sodium and propofol in ECT anesthesia. Now let us examine this, whether these objectives are specific or not. Present study was designed to evaluate the propofol as an induction agent for modified ECT and compare it with the equivalent dose of thiopentone. So if we just go back, are we specific? We are trying to definitely say that we are going to compare two drugs. Is it measurable? Yes, of course you can measure. But thing is that you will find that the objectives which you write in your thesis is slightly different here. Why? Because you have to include these things in the methodology. How much of this particular drug you are going to take, how much of the other drug you are going to take, that you do it in thesis when you write your objectives. But you have to put it definitely in the methods. So this is again another article which you published in Indian Journal of Social Psychiatry from EMRIMS. So we have said what is the main aim there, then we said objectives. Okay, now you find that when you are comparing drugs and such things, that they appear to be very specific, measurable, smart, what you said, accurate and all that. But when you come to psychological measures, we have to be as specific as possible as what is there in the current understanding. Now, methods. When you come to methods, you have to follow this PICOT model. What is this PICOT model? That is about the participants of the population. Then what is the intervention? Is there any comparison? What is the outcome? And what is the time? You should have at least two things. That is, you should have at least the participants and the outcomes. Without that, you cannot go for any observation. The other elements are added depending upon the design of your study. So follow these guidelines and describe measures to ensure ethical conduct, which is the most important thing. You cannot just take any patient and include. Without ethics, no journal is going to accept it. And give references for labs and stats also. Very important that, for example, you do in a particular lab, you have to go to the lab and take out what is the instrument they are using, what is the sensitivity, specificity, everything. You have to put it in your paper. Then include diagram, table or flow chart. All of these things you will find in the Equator guidelines. And provide a study protocol. Okay, there is also star D, which is the how to write a study protocol in the Equator guidelines. So coming on to the results, then report the results fully and honestly, and the text or story and tables, evidence, everything, and give in the statistical analysis, there are guidelines again, which are not there in the Equator guidelines. There are another guidelines for that, which are called as SAMPL, sample guidelines are there. If suppose you are presenting the mean and standard deviation, how you should write the SD, you should not write plus and minus, that is not accepted now. You put a mean, put a bracket and say SD, okay, that is accepted. So like that, a lot of things are there depending upon what type of statistical analysis you are doing, because this is what the journals will look for. And report essential summary statistics, leave out non-essential tables. You might have done a thesis and you have some 30 tables. You cannot publish all that. You have to condense a lot of them. Maximum journals will not accept more than 4 or 5 tables or 1 or 2 figures. So whatever you want to present, you have to present even in that. Even if you may be a Nobel Prize winner, but journals will not accept more than this. And in the results, don't start any discussion there. You just present what is that you found. So in the result section, organize the tables and figures, present the tabular results, and use past tense. No interpretation, just the facts. And table should stand on their own. Stand on their own means if anybody looking at the table should be able to understand it. Okay. For example, here the figure, you know that y-axis should represent the dependent variable and x-axis is the independent variable. So a lot of things are there, minor points, major points, all these things you can look into. Some of the BMJ has published a lot of things about such things, how to actually publish a figure and all that. Now, discussion is the most important thing, because whatever you have presented, you should try to now discuss and tell them what your results mean. Now please remember that in discussion you are not again going to present what is there in your tables or your graphs. You are not going to say the mean of group A is some 13 point this one and the SD is this and mean of group B so and so. Not necessary, because you have already done it in your tables. You are not going to repeat the same thing again in your discussion. Only thing is you have to tell that in what way something is significant. Okay. So like this, whether your results are expected or not expected. If something is unexpected, don't claim as if you have done some fantastic discovery. Sometimes you will find there are something called as spurious correlation. Correlations which are not true according to the literature. What is not known according to the literature? Unless you have some fantastic study and you want to present it, which nobody has done, you have to check and recheck several times. So, in the discussion when you write, you begin and then there is a middle and there is an end. What is the beginning? It states, answer and summarizes main findings. So, you have asked the question in your objectives and all, whether you are going to answer that in your discussion or not. Middle explains answer and how it fits with the previous work. So, in the beginning you have said this is what I found, but now you are going to say whether in the middle part whether it is according to the literature, not according to the literature. And ending is give final conclusions. Conclusions can be of two standard ways. One is to restate an answer or to indicate importance of the work by stating implications, applications and suggesting future work. You can either restate or you can do this thing by future implications. Now let us see this particular article where we have concluded that lack of family support is associated with poor seizure control and higher incidence of PDs here mean psychiatric disorders in patients with JME. Lack of family support increases neither the odds of PDs nor seizure control. Okay, so we are trying to answer the question which we asked initially. So here again the conclusion in this particular article is to conclude. We are very specific here to say that propofol is in a dosage of so and so intravenously can be safely used for modified ECT in so and so group with better hemodynamic results and the recovery of characteristics without compromising therapeutic outcome. Antiemetic property makes the drug of choice for daycare procedures. However, the role in very sick and hemodynamically compromised patients needs further evaluation. So you see that we are leaving it for the other researchers to work on this particular these particular two drugs. So when we are writing, again active voice and passive voice are again important. Active voice is encouraged. What do you mean by that? For example, here you can see the example here. Smith et al. Investigated the relationships. We have analyzed the results. This is an active voice. Compared to this passive voice example, the relationship was investigated by Smith, that is weak. And the results have been analyzed by us. This is again not emphatic, you are not emphatic, you are not very clear in telling others what exactly you have done. Now the following tenses is also important. Now I am not going to much details about the tenses. You can actually look into this particular these slides. So for the present I am not going to stress much upon this, but tense is very important. So let us come to the other part. The ending part of it is acknowledgements. Please don't ever forget to acknowledge people, and like even for typing and permissions. Like for example, I have been associated with this particular article. This is published from the in a very prestigious cardiology journal, Journal of American College of Cardiology. They have given me acknowledgement for statistical analysis. Now the problem is that they could have added me as an author, but there are some journals which say only 4 authors are allowed. So the problem is already 4 authors are there who have done the main part of the work. So they apologized and they said we can only include you in this particular acknowledgement. Of course you cannot disagree with them, and you find that this particular article has 696 citations till now. Okay. So most important thing is citing. What will happen here, the PGs, we have to understand that most of the PGs, what they do is that they do what is called as a cut and paste, copy and paste. So and so author, just 2 paragraphs you put it. Then another author, you put that, again copy and paste and make your review of literature. And then you have your own way of style. You find a lot of variation in the style. One author A has put it in a different format, author B has put it in a different format, and my way of expressing things is different, so there is no harmony. Another thing is that whenever you are quoting somebody, that is called as citation. You cannot say that this is mine. Okay, definitely not, is it not? Because somebody will point out that this is not yours. This statement is not yours. Okay. So this is the what is called as the citation. Now you can see some examples here. Now how do you cite? For example, here a previous study, example in the 4th or 5th line, a previous study, in the bracket you are giving Grover so and so, comma 2005. Okay. Then numerical citing. Okay, if you are going for American Psychiatric Association publication, they will follow this, the way of citing the author and date. And please remember, American Psychiatric Association publications, you have to write even the page numbers and also sometimes para. I would ask you to actually take the pleasure of getting tormented by sending one paper to some American journal. First of all, the APA guidelines itself is about 100 pages. You read all that, try to make your article on that, send it. You will have experience. Most often your papers will get rejected. Don't worry about that. Okay. But you will have experience. So the most common thing now many of the journals follow is the numerical citing, like previously 1, 2, like that, because you are going to put them in the references. So again, this is about the tense itself. Let me not get into that. Now coming on to the references. So you see that what you have cited, you have to put it in the references. Okay, you cannot skip that. Now people will say what is bibliography and what is referencing. Reference is actually your citations, you are going to put it in your references. You may have collected lot of material which could be your bibliography. Okay. So here you see that in the text, the number 1 you can see in the text, cite the literature in the appropriate places. For example, Scarlet 1990, something, then somebody, Indigo so and so, then Magenta so and so. But here in the references I am going to put that. Indigo so and so, Magenta, like that. The details of all that referencing has got to be put. Now please remember that there are different styles are there. Not all journals follow the same referencing styles. Okay, you will get confused in that, but then you have to go into how to cite in different journals. They will give at least a page or 2 about how to cite how to put the references and how to put your citations. So like this, Harvard is there, which is mainly used for the social sciences, and IEEE is there for engineering. Then all the other things are for medical field. Vancouver is the most common one which you use. Even I think TJP also we use Vancouver style. Chicago, again very elaborate again. Then Oxford, American Medical Association AMA style, American Psychological Association APA and MLA style is there. So the journal will ask you to put it in this particular referencing style. If you put it in some other referencing style, they will immediately send it back to you. Now, one of the most important thing is you have to follow what is called as the International Committee of Medical Journal Editors recommendation for manuscripts submitted to biomedical journals. You have to go into this particular site, download that, and then you have to tick, and then you have to send it to this particular journal. Most of the journals will not accept without your submitting the ICJME document. So reporting guidelines for research, as I have told you, equator. So the 2 things which are important in publication is, one thing is your ICJME, other is whether you have followed and signed everything, ticked everything, yes, and all that, and put it in the equator. If you put something which you have not done, immediately it will get back to you. Okay. Now, most commonly what will happen is that many of the journals you find that especially our Indian English, maybe some are very good in English, but let us say commonly, our English is not that good. Okay. So we may be committing a lot of mistakes. So when we were in our schools and all that, they said you should not put a comma before and. But I found that it's not like that. You have to put a comma and then you should put and. Okay, there are some changes like this. Now paragraphs, how they should be, etc. all are there, and you may get rejected and you won't really understand why your paper gets rejected. Okay, so you need to have spell checker which is already there in your MS Word, but that is not sufficient. Okay, so don't use unnecessary commas. Proofread carefully. Better you don't proofread by yourselves, give it to somebody, your colleague, and ask them to proofread. Okay. And then finally you have to use some software. There are online softwares for this are there. For example, there is one software which is called the Grammarly is there. They will allow you to do it for one article or maybe 2 articles. But after that they'll say you pay so many dollars. So it is costly. Okay. But they'll do a perfect way of this one, and then probably whenever editor sends back you are saying that you don't, your paraphrasing is, your paragraph writing is not good or something like that, you put it in this Grammarly and say that I have done it in this particular software and send it. Okay. So the process of paper writing is create an outline first, plan for multiple drafts. You cannot do with one draft, you have to do with several drafts, maybe 4 or 5, and then for each please save all these drafts. If suppose you are sending it for, don't think that once you send a article to the journal, they are immediately going to accept you and tell that you are Nobel Prize winner or something like that. Nothing like that. You will get mostly rejections. Okay. And if you send for one journal, they will say you follow MLA style. Another journal will say you follow Vancouver style of referencing. So please save all these drafts. So now comes which journal I should send. So is the topic of my paper within the scope of and format? You do an article and then send it for biological psychiatry, it is not going to get accepted. Okay, so that's the minimum thing which we should know. Would it match my audience or not? Then ask your mentor or other senior researchers for appropriateness. Okay. Then what is the impact factor? Consequences of wrong decision, time lost and failure to publish. So initially we may think that our dessert which we have prepared is something fantastic and you send it for a foreign journal. Okay. That journal rejects you. Again you send it for some other foreign journal that may not accept you. So like this you are wasting your time. So try to know that which are the appropriate journals where you can publish. So try to publish at least in the local journals first, and then you can go for the other journals when you get the experience. Now here is the pathway for publication. As you can see that you are the researcher who is going to get published. You can see a lot of people with the swords and knives and clubs standing there. So at each stage you can be censored. So what are the stages? So you submit an article. So there is something called, there is some person called as editorial manager. So your article may get rejected from the editorial manager itself because you have not put it in a particular format. They will say you have not put it in the APA format, hence your article is not accepted. Please put it in and send it. Okay. So that is the work of the editorial manager. He is not going to evaluate your article. Once you pass that particular gate, then there is an editor-in-chief, or sometimes they will allot an editor for a particular article. And this is the most difficult thing here is that editor-in-chief or editor who is assigned for you. So there will be somebody intermediate in between the editorial manager and editor-in-chief who might say that this article is of no relevance to this particular journal, or this is already such work has been done. Hence, we are sorry to inform that it is rejected. I am very happy that because sometimes the foreign journals will reject it, but reject it very humbly. You will feel nice. It is something like you have been hit by with a gloved hand. But Indian journals, they are very blunt in rejecting your articles. Okay. And if you get a reply within 1 week, that means most probably your article is rejected. Okay. So editor-in-chief will assign an editor, and the assigned editor will send your articles to reviewers, 2, 3 or 6 reviewers also sometimes, and they will send a review of the article which you have sent. They will send their reviews. It is for you to answer all their questions. You can't say that I am great, I am the professor of so and so, so nothing like that. Everybody is equal there. Fine. Then the decision will be taken by the reviewers, and then only your article can be processed further. Okay, like there could be minor revisions, major revisions and acceptance, and most likely rejection. Okay. Why I am telling you all these things is that things are not as rosy as you think when you want to publish your article for recognition. Okay. The reviewer is always right. Don't ever say that you are wrong because I have found something like this. No. You have to say very humbly that, sir, I have reviewed this and then I found this. According to literature, it is like this, and leave it. So don't respond quickly. So what will happen immediately when you get rejected is that it's just like failing a Viva exam. You will feel bad. Okay. Just relax. Take some 2-3 days, relax, and then you start writing your submission for the reviews. Okay. So there could be so many things which can happen, why your paper gets rejected. I am not going to details of that. Okay. Now, why do journals reject? Inappropriate, incomplete sentence, statistics, over-interpretation of results. You have done something and then you just discuss about what you have done. Inappropriate, suboptimal instrumentation. So if you said that I have done some serum lithium and so, and then I have presented, then they will reject your article because you are not saying what is the apparatus, what is the sensitivity, specificity of that particular apparatus, all these things are there. Then sample can be too small or biased. Okay, unfortunately what will happen is some of the Indian journals, some of the editors who are not statistically trained, they will immediately reject your article within 2-3 days, saying that your article does not have adequate sample sizes. That is unfortunate thing sometimes will happen, which is unlikely to happen in foreign journals. The text is difficult to follow, insufficient problem statement. Like this, so many problems can be there. Now let us see how does international, some very noted journals will accept or reject. For example, NEJM, only 5% is approximately acceptance. For NEJM, even before you send an article, there is a preview where, not a preview actually, that is an assessment which is done even before you can send it to a journal. You have to send your title and abstract, then immediately they will tell you whether within 2-3 days you will get a reply whether you can send this paper to the journal or not. Leave alone the other things of accepting, etc. and all that. So like this, various journals have got different ways of rejecting. Now, that is one part of it. The other part, most important part is plagiarism. Plagiarism is what is defined as an act of taking the specific substance of another and offering it as one's own without giving credit to the source. So that is why citation is important. You cannot say this is my finding. Now you may think that how people will be able to know in the world that what is published. Don't think every sentence which is published, okay, is referenced. I'll show you. how it can be done. Now you can see that there are various ways of plagiarism: quoting verbatim without due acknowledgement, paraphrasing. Paraphrasing is changing the sentence. Okay, Mr. Smith found that so and so, something like this, and you are just paraphrasing it. Okay, the results as done by Smith was found to be, that's paraphrasing, which is also not accepted. Then using someone else's ideas without due reference, cutting and pasting from the internet, submitting someone else's work, and colluding with another person. So these are the plagiarism detecting softwares are there. In the Google Scholar itself, cross-check is there, Authenticate is there, so many other are there. And it is not possible that all your statements, you will get a zero plagiarism. There are some statements where the standard way of stating will be there, which you cannot do anything about it. So a plagiarism of less than 20% is accepted. Because there are some statements which you just cannot change sometimes. Some definition you are taking. Okay. So like that. So keep it below 10%, that would be better. And you think that you will be wondering why? Because we send an article and try to check it. Every sentence of yours, they will tell you this has been from this particular journal article by so and so year, so and so page, like that. So we cannot just fool people. And now I'll come to the another important thing is that you want to see your name published in a journal. Definitely. Is it not? Who doesn't want to? But please remember that there are so many other sharks are there who are called as the predatory publishers. For example, I tell you one article which that is just a case report which I have published on levetiracetam and causing INR changes. Okay. Now what has happened is one of the predatory publishers said your article is excellent, this, that and all that. Please publish in our, please send your articles in this one particular journal. Naturally you will be happier. Why not? But try to know that there are some articles which are called as predatory journals and publishers. Okay. So be aware of that. Now what happens is that these people invite authors via aggressive emails and paper submissions. I'll go into a little bit detail about that. Perform little or no editorial. Why I am focusing on this particular topic is that many of the young people want to get their name. You want to see your name on that, is it not? Definitely. But they are very quick. In 1 week or 4 weeks, you will find your article published. No editorial boards, fake members, they mimic reputable journal styles, sites and confuse you. Sometimes they'll say that our journal is indexed with Scopus. Sai Krishna knows how difficult it is to get your indexing in Scopus. It is an international organization. Very few journals will get indexed. Maybe your Indian Journal of Psychiatry is there. Okay. So like this. So don't expect some predatory journal when they say Scopus. Now suddenly you feel happy. Okay. But then what will happen if suppose you publish in predatory journals? Now let us look at this particular flow diagram. So you are the author who publishes. Okay. Then suppose it is a legitimate journal, go down, legitimate journal. Then improved statistics after peer review and copy editing. Then marketing and visibility, readership, citations will go on. Okay. So your article will get cited. What will happen if you publish in predatory journal? It damages you. How? No opportunity for improvement. Nobody is going to peer review that. Nobody is going to cite your article. Citation is the most important thing. If your article is not cited by somebody, it is just like a person in the desert. Okay. So another problem is that once you publish in predatory, and Rajshekhar was also telling the previous editor, there are some editorial boards where your name will be included and then you are considered as a predatory editor. So as editors, we know that we should not get into such publications. Otherwise, our name will be blacklisted. You cannot go for any other being editor for any other journal. Okay. So, how do you know that? These are insufficient contact information. You will have very few information. They will directly contact you through an email. You won't even know how they are able to know your email. Okay. Then the broad area of subjects like Journal of Social Sciences. Now let us see, for example, this journals treat 2 or more fields of the subject together. You see here International Journal of Business, Humanity and Technology. They will also publish your article, medical science, even though it has nothing to do with medicine. Then Sky High claims like leading publisher. They will have fake, similar ISIN numbers and absence of article DOIs. Okay. Digital object identifiers, which are very important. Now, why these things have come up? Because the UGC previously said that we should have at least 2 articles published in journals. Okay. So, that is when it is not only, don't think only of medical people, it is UGC concerns so many other universities with so many other areas like social sciences, etc., and all that. They also publish it. So, there are less journals, more number of people who want to get their publication. Hence, there is a proliferation. So, these are the different ways in which they operate. Now, please remember that they will ask you to pay some money. Once you send your article, they say your article is excellent, is peer reviewed, we are going to publish it. Please send 1,500 rupees or 5,000 rupees. Okay. You send it, immediately you will get the publication. And if you actually look for a print copy of this, you will never find a print copy of this particular journal. And it is very difficult to find even on the online. And DOI numbers are very important. Our TJP has got DOI numbers, unique identifying numbers for each article. If they are not there, that means your article will not be on the online. Okay. Now, so that's why the HRD ministry has removed all bogus journals. They found that at least 88% of the journals are substandard and they have removed them. Okay, the same thing here. So beware of these things. Now, how to know that? Now please remember, is the publisher listed in any blacklist? How to know blacklist? I'll come to that in the next slide. Check it in any whitelist. There is something called as DOAG. Okay. Which Sai Krishna knows we are trying for that. It's very difficult even to get into DOAG. I understand that it's very difficult because we have started only in 2015 TJP, and Archives of General Psychiatry, which was inherited from the AP Journal of Psychological Medicine, which already got DOAG. Okay. Directory of Open Access Journals, that is DOAG. Okay. Why this name? Something, it rings a bell in you. If you are going to apply for your promotion, DOAG, user article in DOAG or not is important. If not, that means your article is not recognized. Okay. Of course, you can publish in Scopus or Medline and all that, which are international PubMed and all that, which is not that easy to get into. So at least you should get your article in the DOAG, which I am telling for the faculty. Okay, basically. Students, you don't have to worry so much, but as you are going to be faculty later on. So you should search in web databases, are they like PubMed Central or Web of Science, and find whether your journal, the predatory journal, is there or not. Most often it will not be there. Okay. So this is what I am talking about, is the digital object identifier. So this will, numbers will be there, something like that. Okay. So alphanumeric, and this is how your article will be identified. So these are the DOAG journals in psychiatry in India. Okay. Archives of Mental Health, which is from the Unpraised Journal of Psychological Medicine, because it has got 10 years and more actually. I actually requested the editor of Archives of Mental Health, to even publish before 2010. That will enhance. So you see this Indian Journal of Social Psychiatry, Indian of Psychiatry. So these are the different journals. For all faculties, try to get a publication in this. But I would request that our TJP has to grow and we have to publish articles in that. Since we are writing an article and publishing, maintaining a journal is more important because we should not miss any issues. And then articles should be cited also. All these things are very important. Editor himself just cannot go and say that I want a DOAG. They will say what is your track record, and then only they will give. Okay. So I request people to, on behalf of Sai Krishna, to please accept TJP and publish articles in that. So there is a list, there is a site which is called the Bell's List of Potential Predatory Journals and Publishers. Just simply type your journal name and or publisher's name, you will get the list of predatory journals. See, your predatory journals, actually you will see that they are very attractive. Suppose you get your publication in World Open Access Journal, excellent. Or Asia Pacific Association of Medical Research, you get your article published, but this is a predatory journal. Or they'll put some fancy names like American. So whenever you have some prefixes, American, British, you feel excited, but they are all predatory. So people use like international, American, like that, world. So that's okay. Now another important thing is that these days what has happened is that most of the journals have opened up their what is called an access to public. Previously there was a moratorium of you cannot access an article unless you are a subscriber to the journal. Okay. But now they have opened up. This is called as open access journals. Open access journals are not all free. There are very few which are free. So they gain their money by what is called as the article processing charges. Whenever you want to send an article to some international journal, see first and whether there is any article processing charges. You may think it is very less, definitely not. For example, one of the article which I sent for comprehensive psychiatry, which was not an open access journal previously. But after doing all the work, they said you pay $1,500. Convert it into Indian rupees. Do you want to spend 75,000 rupees or 1 lakh rupees for just one article? Okay, you can be Ambani or Adani's daughter or son, which you can do it, but I think most of us will not be able to do that. Okay. For example, they say we have a waiver, but these waivers are not for India. India is no longer considered as a developing country. There are some African nations, all that, some names are there. If they send an article, then probably they will waive off, but definitely not from India. So beware of this. Now coming on to the final one or two slides, journals have got the way of measuring, which is called as metrics. Okay, journal metrics, lot of metrics are there. Even when you publish, there is a citation metrics is there. For example, there is something called as H index is there, I-10 index is there, and G-square index is there. For example, if suppose you send 2-3 articles for H index, then you should have 1, and for the second publication you should have at least 2 citations. For example, you send 10 articles over years, then at least one of them should have 10 citations. So everything depends upon how people have cited your work, not just seen your work. So like this, so many different metrics are there. So citation count is important. Even the journal metrics are there. 5 years metrics are there. It's called the H5 index. Do you know what is the H5 index of Indian Journal of Psychiatry, our prestigious journal? It is only 0.3. You will be surprised to know that. Okay. So even from the Asian Journal of Psychiatry is about 2 point something. And for journals, in some like cancer journals and all that, they have very high citation index. So you may ask me, what is the point in having this citation index of journals? It is that shows your something like an order, okay, 1, 2, 3 like that. So these are highly acclaimed journals. Even NEJM is not too high, okay. Nature also is not too high. So you should be aware of this matrix. So there is a, how to know about the journal ranking is there, which is found in this particular site. You can go to SCI, SC Imagio journal rank, SJR index, which is called as. Search for your journal, type Indian Journal of Psychological Medicine, then you will find what is the matrix. Okay. We wish that some of our journals should get high into the matrix. We know that it's all a hard work. This particular editor and subsequent editors also have all to do persistent work to get our journal into a higher ranking. So that is the end of my topic. And
Sir, thank you very much for your effort to prepare all these things and reaching SVAs and delivering this for the benefit of our postgraduate students from various colleges, not restricted to SVS Medical College, but all colleges. We have opened up to all colleges. I have one question is, suppose the dissertation is done. Can they make 2 or 3 publications from one dissertation? Is it accepted? Because dissertation may have 80 pages, like a publication is only 6 pages or 7 pages. Can they make 2 or 3 articles?
only thing is that suppose we are repeating the tables, because the same number of people will be there, population or sample sizes, we have to see that at least a subpopulation of that is taken and presented in a different form of paper. But suppose we are using the same tables like that, then people will come to know. That is the only problem. Because these days everything, whatever is published can be evaluated.
I have one question to our editor. Suppose I want to publish an article in TJP, I have option, like for TJP I have option, IJP I have option, South Zone Journal I have option. What advantage I have if I submit to TJP? How do you promote this? I may feel that it is prestigious to publish in IJP.
Sir, generally what an author wants, it will be decided by the author, whether he wants to publish in a national journal or a zonal journal or a state journal or international journal. What is his requirement? What are his target group? So first author should know. And once the journal is indexed, it doesn't matter whether it is a state journal, zone journal or national journal or international journal. Every journal becomes equal. Every journal becomes equal. But what is the requirement of author is very important, sir. And depending upon each journal, there may be some different guidelines. So that may be an important factor, sir. That's it, sir.
Thank you.
Yeah, I would also like to tell that even IJP and IJPM also, they will not readily accept articles for the reasons mostly because best known to the editors. As previously JSS, J. Satyanarayana told that, that when he was an editor, we suppose he is one of my friend, then I may pass this article. So there is also sometimes bias and favoritism also which occurs. You may have a very good article, but they may not take it, they may reject it. So let us develop our journal and indexing, then people will flock to us. Once you get in DOAJ, now I send an article to Archives of Archives of Mental Health also, it is not readily taken. They are asking a lot of questions now. Previously it was not the thing. So when my stature grows, all these things will come into play. Another problem is that we need to publish. There are a lot of people now who want data. Now you see that there is a lot of growth of what is called a data science, data analysts, scientists, data scientists. They are hungry for data. But we are the people who are generating the data. So now the journals are asking you to give the data set. That means you give your Excel sheet or you give your tables and all that. That will be put in a something like a locker, which is called as a repository, and the people sometimes they can access. Because you find there is a huge growth of these data scientists doing their projects and asking for data. So we are the people who have to generate.
To answer Ashok Reddy sir's question, the chances of getting my article published in IJP is, I was talking to Dr. O.P. Singh, and he said that around 95% of time we reject the articles. If we go to South Zone, maybe they are rejecting around 50 to 60% of papers. In our TJP, we have around 1:2 ratio. 50% chances are there that our article will get published. Also, we were discussing in South Zone that unofficially, not officially, but unofficially, that around 30 to 40% of the papers should be of South Zone. It is not officially. Officially, we cannot do that, otherwise we won't get recognized. Similarly, in Telangana Journal of Psychiatry, we try to make it a point that we get our own articles. We publish around 30 to 40% of our own articles. So our chances of getting published is more in Telangana Journal of Psychiatry. Am I right,
Yeah.
Sai Krish?
Sir, this is unofficial, sir.
This is unofficial, but yeah.
Nobody has heard it. Okay.
As I think the other colleges, PGs also might have been logged in, no sir, online and all. So other people also may be listening. So sir, I was really interesting to listen. I'm Dr. Joshi here, Vice Principal for this college and all. I'm really happy to listen your lectures and to see that. And because I'm here the coordinator for this biomedical research and for the PGs to emphasize the uses of like articles and all. One point I think that all PGs can also understand and we can emphasize that how the foundations, like with their beginning, when they choose the topic, if the hard work is done, because I am community medicine and esthetician is beside me only. So I know, and even other colleges, how often usually any PGs, forget about psychiatry department, any PG, how often they visit to find out the even a sample size, to frame research questions, to see that how it has been framed, and how the table should be done, how the data need to be collected. So it would be easy for them for the dissertations, isn't it? How the foundation would be as the building would be. After the end of the 3 years, just within 6 months, you copy paste and make a dissertation. And from that dissertation, if you want to publish in a very good renowned journal, definitely it won't come out. It won't come out. So ultimately, it is like from beginning itself, if you plan in such a way, whether any person who is guiding also and the person who is doing also, in a both the way, if we ask them to do the real work, and from beginning if they do in a scientific manner, I think the result for the publication would be better. That's what I would like to share. Thank you so much for giving me that.
The organizers permit, I'll give a brief message regarding TJP. Yeah. TJP was initiated in the year 2015, once we got state branch. Our journal is having e-ISSN number, that is nothing but e-journal, but still we are awaiting for print RIN number, which is stuck in Delhi. Maybe because of the COVID times and all other unexplained factors are playing a role in delaying of print RIN number. Recently we had changed our journal publishing house also. We are right now working with a better journal publisher called as Olter Kluwer, Medno, who is currently publishing National Journal IJP. So we are taking their suggestions so that in future, maybe I had kept a target of 2 years, so that in the next 2 years we'll have a better indexing. And to get better indexing, it is not possible only with the editor. I am always taking opinions from all the researchers, senior academicians, my teachers, my own colleagues, students, so that how I can improve the journal. Why? Because any journal requires publishing of quality articles. And second thing, journal requires timely release of editions. Right now we are having only 2 editions which are supposed to be released on time. To release on time, we should have good articles. Whenever I'm requesting to publish articles, immediately all our young researchers are saying, sir, as our journal is not indexed, what benefit I will get? It may not be useful for my promotion. So I will send to a better indexed journal. See, maybe you should try for a better indexed journal, but at the same time, it will be our responsibility to help our own state branch journal to get indexed, so that in future it will be useful for all postgraduates, young academicians and clinicians of state branch also. So please take this point. I request all young PG students, senior academicians, young researchers to help in this journal building process. And regarding the financial aspect, I thank the State Branch Society, President Dr. Jagannath sir, for his unconditional support, and sir had immediately accepted to even give 2 lakhs budget for archiving all the old editions. Now all the old editions of TJP right from 2015 will be archived very soon into Alter Clever website, so that none of the work which had been done earlier, they won't lose any work. And all the DY numbers, if they are missed also, everything will be archived. So this is all because of the society efforts, and society is financially giving freedom to the journal, so that all the publication part will be looked by everyone. Okay? Thank you, sir. Thank you for giving me an opportunity.
Yeah, again, stressing another very important point is people are doing meta-analysis and systemic review. Somebody in US does this. Your article which you publish in TJP will also be included in that, if whether it is indexed or not. So people look also for non-indexed journals also. So we'll definitely try for a indexing, good indexing, but that is also accepted. So you can find your article quoted by a systematic review or meta-analysis.
Suppose I submit for publication, it is published in TJP now, and the indexing occurs next year. So retrospectively, is it valid or not?
I'll tell you one value and all that, I don't know, but we have previously published in Indian Journal of Psychological Medicine. What I am telling is about 20 years back, 15 years back. Luckily, they have now revised all that, they have put all that in archives and given us DOA numbers. So I find that some of the citations are there now, what we published some 15, 20 years back. So that is still valued. I requested Archives of Mental Health also to do that, which they have not yet done.
Then does not make any difference. As far as concern promotion issues, like if somebody is telling, I don't want to publish because indexing is not there because he is associate. Once the professor cadre publishes, so at TJP also it can be accepted because he doesn't need that kind of indexing over there. So I think it can be helpful.
Yeah, it is just our perception, but one thing is that it is my own child, then definitely I want to be the first author. That is the only thing. But there is no problem at all because 3 authors are accepted.
Acceptable.
So others can be there.
Others can be the other authors. Okay.
I would once again like to thank the speaker of the session, Dr. B. Anand sir, for enlightening us with your knowledge. I now request the chairpersons of the session to please present the memento to the speaker, Dr. B. Anand sir. May I now request Dr. Ashok Reddy sir to present mementos to the chairpersons, Dr. Sai Krishna sir and Dr. Swarupachari sir. Dr. P. Sai Krishna and Dr. R. S. Swarupachari sir. Thank you, sir. With this, I would like to end the session. Next, we will be having valedictory function. For the arrangement of valedictory functions will require around 5 minutes. The organizing secretary of the CME program, Dr. Vijay Pratik sir, will take over the session from now onwards. Thank you.
Good evening, everyone. Thank you for bearing us till the last session. Now, I would like to invite dignitaries on the stage for the valedictory function. I would like to invite first the President of IPS Telangana State Branch, Dr. G. Jagannath Garu, onto the stage. Now I would like to invite our chief guest for the valedictory function, Dr. V. George Reddy Garu, President of IAPP, Indian Association of Private Psychiatry. Next, I would like to invite our guest of honor, Dr. K.P. Joshi Garu, Vice Principal, SVS Medical College, Mahabubnagar. Next, I would like to invite our organizing chairman, Dr. K. Ashok Reddy Garu, Professor and HOD Department of Psychiatry, SVS Medical College, Mahabubnagar. Next, I would like to invite our Vice President and President-elect, Dr. Ram Subba Reddy Garu, to come onto the stage. I'd last like to invite our Honorable General Secretary, IPS Telangana State Branch, Dr. Minaj sir, onto the stage. Now I would like to hand over the mic to President, the presiding officer of the valedictory function, to take over the valedictory function.
Good evening, everyone. Respected Dr. George Reddy, the chief guest of today's function, and other dignitaries on the dais. Good evening once again. It was indeed an excellent CME. Morning itself, I told you, every speaker who spoke today was excellent in their presentations. From Dr. Praveen Kumar Chintapanti to Dr. Jagdish Babu from Warangal. I have seen the slides. I in fact really appreciate Dr. Jagdish Babu for the efforts he has put in. He has done it so well for the journalists, and I really congratulate all the speakers. Lastly, Dr. Anand sir's presentation is like icing on the cake. After listening to him, I feel there are only two persons in the TSB office bearers are working. One is the General Secretary and the other one is editor. And I take this opportunity and I wish that our journal grows more and more under the leadership of Dr. Sai, and soon the citation index will cross 0.3 above the national journal. On the behalf of all the members of Telangana Psychiatric Society, I congratulate and acknowledge the efforts of Sai Krishna in this regard. there is nothing much to talk about. Everyone has seen the efforts put in by everyone. And Dr. George Reddy, a close friend of mine, he is the president of IAPP Telangana State Branch, very active member of Telangana Psychiatry Society. He is the immediate past secretary of Telangana State Branch, and he is the founder secretary of Telangana State Branch. I think with these brief words, I request the chief guest, Dr. George Reddy, to speak.
Respected President, Dr. Jagannath sir, today's organizing chairman, Dr. Ashok Reddy sir, the vice president for the IPSTSB, Dr. Ram Subbareddy sir, my close friend, Dr. Minhas, the general secretary, the treasurer, Dr. Vishal, Dr. Sai, the editor, senior members, Dr. Kishan sir, and distinguished members, speakers. Thank you, Dr. Ashok Reddy sir, for giving me this opportunity to be the chief guest for the program. Though I am now switched to the other association, the Indian Association of Private Psychiatry, Telangana State, and I think I started my career with the Indian Psychiatric Society, Telangana State. I think to work with Dr. Ashok Reddy sir, it's like you learn a lot, and the way he plans, meticulously plans the programs, I think sir has proved, and I think definitely the COVID has given us an opportunity to see the hospitality of Dr. Ashok Reddy sir and SVS Medical College. We had a conference for a day, and I thank the SVS Medical College. Dr. Ashok Reddy sir takes every opportunity to spread the scientific information, and today you definitely would have tasted during this tough COVID time. So meticulously planned, as Dr. Jagannath sir was saying. Every topic is so well planned that it will definitely help us in our daily practice. The way we see it happened in 2 halls, I think it's like a conference come a wonderful CME. And definitely the future is all here. We will be having physical and the hybrid people who are really interested to attend to sessions. I think this is the feast. And I have noticed one thing. Recently I was the organizing chairman, secretary for the midterm CME. Though I'm not an academic oriented person, but when I was there to organize the midterm CME, I think definitely now we see that we are trying to go into the minute of psychiatry. We are trying to look at new horizons, new dimensions of topics. I think it is definitely helping us on our day-to-day practice. Today's topics would really help us in our regular practice, and Dr. Anand sir's last session, how to make our publication, I think lot of insight, and Dr. Anita and other speakers, I think it is worthwhile we come up with so many topics. And the other interesting part is, I think of recent we see young speakers coming up. The opportunities are being given to new speakers, and definitely I think we should let this ball going so that we should even dream of having a recently passed out postgraduate to have an opportunity to be a speaker on these wonderful forums. And thanks to our associations and the wonderful organizing skills, as we have seen Dr. Ashok Reddy sir doing at SVS Medical College, he encourages a lot of youngsters, and he sees that the planning is meticulous, and definitely at the end we learn a lot, and it would help us. And without taking much time, I think I should thank SVS Medical College and Dr. Ashok Reddy sir, the entire Department of Psychiatry, for doing a wonderful job, and hope we would see you organizing another program for our psychiatrists in the near future. Thank you, Dr. Jagannath sir, for giving me this wonderful opportunity. Thank you, Dr. Ashok Reddy sir.
Thank you, Dr. George. I should say, this is the second time we are visiting SVS Medical College. In the same hall we sat and we had the same program, and this is the second time we are visiting. Sir, this is for Dr. K.P. Joshi. Sir, this is an excellent infrastructure you have got. Then staff are very cordial, courteous, very hard-working PG students you have got. Your hospitality is excellent. The guest house here provided accommodation is wonderful. I just want to know when you are conducting another meeting again for us, sir. Now I request Dr. K.P. Joshi to say a few words.
Yeah, so good evening everyone, respected dignitaries on the dais, all the people who are joined online. So thank you so much, sir, for this, you should say, compliment for SVS and for us. Being a vice principal of the institution, as I said, it's my responsibility to do all this job, as I am myself is quite passionate about doing all the jobs since my post-graduations. So I have been associated since that time. And since last 13 years, whatever the conferences, as sir said, we try our level best to provide this thing. And so always our management, at morning also I told you, they are always helpful. All our directors are very encouraging in such kind of activities. But the moreover, the person who should take up, that depends. So here I think all can give a huge round of applause for Dr. Ashok Reddy sir. Because see, infrastructure is there. IM is there, I am already there, but how many people are able to utilize my capabilities in infrastructure, it also depends. So sir knows very well that how to utilize, when to utilize, where to utilize the strength of, and the weaknesses also, because ultimately weakness must be converted in a strength, that only the things will happen. So we do a teamwork, and thank you very much for all your appreciations and all this. We hope in future also we would work together, Association of Telangana would work together along with the leadership of Dr. Ashok Reddy and the other member of the association, and again we would see that some other program is being organized. So thank you so much for being here with us for the CME. Thank you so much for this opportunity.
Thank you, Dr. Joshi Garu. I know Dr. Ashok Reddy for the last 32 years probably, from 89 I know him. He's like my Peddana, and I learned so much from him. His organizing skills are exemplary, and all of us get benefited from you in every manner, in selecting the topics, the way you organize, the way you talk to people and all the things. We are very thankful to you, sir. Second, it is our pleasure. It is the pleasure of every member to come and attend this program here in this college under your guidance. Now I request you to say a few remarks.
Thank you, Mr. President, for the nice words you have told about me. And I thank IPSTSB for giving this wonderful opportunity, which is an opportunity to learn, which has given, like, my total team has learned a lot of skills in organization because the opportunity is given by the society. I think PGs have become better organizers now. My assistant professor Pratik has become a better organizer. And at this time, I've taken one decision that we will not spend much time in organization. Like what happens is whenever we decide 6 months before, we'll be spending all the 6 months for organizing this. This is based on my experience in the past. I don't want to spend so much time. I've decided to spend only 6 weeks for this. So that's the reason I've taken permission only 6 weeks back from the IPS or TSB that I want to organize CME. So that from that day I'll spend energy for this CME program and not beyond that. That's how we planned. Because of all digitalization and all the friends available to me, the links available, I could do very well within 6 weeks. Probably this should be the one, I want to share my experience so that we don't lose our energies unnecessarily for things. Whether we start from 6 months or 6 weeks, results will be same, but we'll be spending more energy if we start 6 months back. That's one thing I want learn from this, and then I could do successfully about this. Second is I want even the next followers also to follow the same pattern of including our non-psychiatric colleagues who are going to help the mentally ill people based on the objectives of our society. Objectives of our society is not just to improve psychiatrists. It is to improve the mental health of the society, common man. So we have to take help of all other professionals who are involved in the care of mentally ill, including the carers of mentally ill. And so future CME organizers, conference organizers, I wish they conduct similar programs. I'll be more happy if this is done and the society benefits from us. We are part of society, we have to give something to society always. And I thank all the speakers who have readily agreed. Nobody said no, including our chief guest, B.N. Gangadhar. In spite of being a busy and aged person, at that age is actually risky to travel all the way to come here. But he never said no. You have called me, I'm coming. When I asked him some other works, he said, I am at your disposal. At your disposal. You tell me whatever you want, I'm going to do it. I asked him to please chair one session. Ashok, I am at your disposal. You tell whatever, I'm going to do it. That's what the affection what he has maintained from that time when I worked with him. It was in 1990 I worked with him as a senior resident. At that time also he maintained same affection. He continues to do that even now. Because of this, even last time for the conference, he came. We invited for the oration. He came. He has taken all the risk, and I'm grateful to him. Because he's a role model. We learn so many things from him. He simplifies the things and puts in our mouth. We can understand very, very clear understanding he will give without any confusions. That is his way of dealing that we have learned from him. I'm grateful to him. And all the speakers, they never said no. Because the affection, relation, what I maintain, I'm thankful to all the speakers who have spent so much energy in preparing their slides, traveling all the way here. Some of them wanted even to talk from there, but I said, no, please come here. I want to make the CME as live as possible, because in the last 1 year, I'm fed up with the webinars, to be very frank. Initially we enjoyed, but now I feel it's not so good. We are not getting the 3D experience through webinars. The human touch is losing. Here we get a 3D experience when compared to webinar is only a two-dimensional experience. So I thought we'll make as live as possible, but keeping the risk of COVID still, we extended through online to all the people who could not come here. They had access. And not only now, access for all these presentations will be continuously present through our website, IPSTSB.org. People can just enter the website and listen to all these presentations whenever they are free. They can repeatedly see the presentations. This effort we are putting so that they'll get benefit in the future also. So with this, I am thankful to my total team. I'm thankful to the pharma companies. 5 companies have come forward to whom we are going to give the mementos. With their support, logistic support, we could make it very comfortable. Thank you, all of you. And thank the management, always encouraging. They never said no at any time. They always encourage. You take whatever you want. They're very good. They're nice to me. Thank you so much.
Thank you, Ashok Reddy Garu. If Dr. Gangadhar is your role model, you are our role model, sir. And we know your commitment. And the morning itself, I told you, for 15 years, on alternate Sundays, you went to Nizamabad in a bus and you were conducting the outpatient clinic for the people. Thank you very much, sir. We are very happy to be with you today, sir. Now, the feedback from the... Yes.
We have to give a report as a part of this. Totally 272 people have registered for the CME. Our objective, our goal was 300, but 272 we have reached. And 240 people have logged in. So 30 people are not logged in, but 240 people around, they are logged in and attended the program.
Thank you, sir. Now, feedback from the senior faculty. Now, I have been seeing Dr. Kishan sir, from morning till evening. I think there is no other person better than you to give a talk about the program today. Dr. Kishan, please.
Thank you, President Dr. Jagannath ji, and thank you, Dr. Ashok Reddy sir. I came since 2 days. I'm spending with Dr. Ashok Reddy and Dr. Gangadhar. Really, I'm enjoying since last 48 hours. Last 48 hours, I think I thoroughly learned so many things, and that first congratulations goes to the IPSTSB by considering Dr. Ashok Reddy sir's request to split the conference and CME, and it is the unanimous support of Telangana State Branch, and we, because of the COVID, we never compromised. Even national IPS little compromise, we are postponing all the activities except the hybrid, the Gautam Saha program at that is at Calcutta. But IPSTSB, I am congratulating IPSTSB as well as the Ashok Reddy and organizing team for completion of total all events we completed with flying colors, and now next only annual conference is due, and we are doing wonderful job, and thank you. And for speakers, I'm really, and during last 3-4 years I was quite busy with a lot of organizational things. Today I'll listen almost all topics. Wonderfully enjoyed. I became a student again, and selection of topics, and there's no technical glitches I have seen this time, and I'm completely convinced about your capabilities, and I thank you very much. And you are improving under guidance of Ashok Reddy as we improved our skills with Ashok Reddy since our student life. Thanks to organizers, congratulations to organizers, congratulations to TSB, congratulations to George. I'm very happy to see George, and his address is wonderful, and everything. Dr. Gangadhar sir's inaugural address, as well as Dr. Chandrasekhar. I want to quote Dr. Chandrasekhar again. Most at this today, I am feeling that how Chandrasekhar sir used to, on record, he attended all conferences, all CMEs of Andhra Pradesh state and Telangana. You can remember Chandrasekhar never missed our Telangana state branch programs as well as AP programs. That was his commitment. We should appreciate him, irrespective of his age and other limitations. He came all the way. Just now he left because of somebody called him, and that should be the spirit. And I think I thoroughly enjoyed how Chandrasekhar sir is doing. I think let us take the spirit from elders, and I'm congratulating Telangana State Branch by overcoming all hurdles, not only COVID, so many other hurdles, and this all credit goes to wisdom of our seniors like Ashok Reddy, Dr. Raghuram Reddy, and Chandrasekhar, and other senior persons. And very happy to see Dr. Anand sir today, because we are missing Anand sir since last 2-3 programs, and I'm very happy to see the madam. Thank you very much, madam, for coming personally, and again thoroughly enjoyed Dr. Anand sir lecture, because I'm having a lot of ideas how to shape the ideas to a paper. I learned again, I reviewed my total. Thank you very much. Congratulations to Ashok Reddy sir again, and I thoroughly enjoyed Chaitanya Lakshmi lecture today. I think Chaitanya is here. Really, I'm seeing that it's a very proud moment for me, how she's expressed, and how she prepared well, and wonderful. It is really I think not Guruchela, it's really I'm enjoyed. Our second generation is coming as a faculty member. Thank you very much. Thanks to IMTSB for giving opportunity. Over to Arghunat.
Thank you, Kishan Garu. I forgot to acknowledge the presence of my teacher, Dr. Anand sir. Even though it is very late, sir, I thank you very much, sir. You have come all the way from Hyderabad, sir. We are very happy, sir, to see you here. Now, Anil, I just want to say you have improved at least by 5 times, sir. 5 times. Last time in the same place, I had difficulty recognizing my face, but this time it is tremendous. It's very good. You have improved tremendously. Now, I want one of the postgraduates to give their feedback, please.
I would like to thank all my co-PGs and all my seniors as they have helped us a lot in organizing the program. I would like to thank all the senior psychiatry members, all the Indian psychiatric members who have come all the way from Hyderabad in this COVID time and have showed his presence here. And I would like to thank our faculty who have helped us guide to how to organize the program, and we have learned a lot from this experience. And I would like to thank all our speakers as well as the chairpersons who have chaired and who have gave us very good speeches about the topics which have been presented to them. And we have learned a lot from Anand sir's presentation, where we have learned how to publish a journal, how to publish an article in a journal, especially about the predatory journals, how to be aware of them. So thank you everyone.
Thank you, Ma. I request Dr. Vijay Raj Pratik to take over and conduct the further program.
Thank you, everyone. We will conclude the valedictory function by presenting the mementos. I would request Dr. Jagannath sir to present a memento to Dr. V. George Reddy garu. I would like to thank our postgraduates and interns of our department for helping us organizing the CME. So I request two of the postgraduates to come on stage and collect a memento on behalf of postgraduates. Yeah. I request Dr. Jagannath sir to present a memento. Sir? Yeah, memento by Dr. George Reddy sir, sorry. Now I would like to extend my thanks to pharma companies. I would like on behalf of Crescent Pharma to come on stage and receive a memento. Dr. George Reddy sir to present the memento, sorry. Yeah. Next, Synergy Pharma, then Symenta. Please come forward. Sun Pharma people. Yeah. Sun Pharma, Synergy and Symenta. Yeah. Come forward. Next, I would like to request Oxygen Pharma people to come and collect their memento. I would like to call Intas Pharma and PJ Pharmaceuticals also onto the stage to receive their mementos. At last,
I think we will conclude by thanking all the doctors on the stage, and by thanking the support staff, especially Anil Martin for supporting us the audiovisual component. Yeah. I would like President to take over and conclude the ceremony. Yeah.
Thank you, everyone. We have come to the conclusion of the program. I thank everyone, the organizers, the hosts, the PGs, pharma companies, and everyone, the speakers, the chairpersons, everyone who is associated with today's program. A big thanks to everyone. Because of your support only we could do it so well. And with this, I conclude, I declare the CME program as closed. We all meet at Nizamabad for the midterm, South Zone midterm CME program. See you all.